That means the portal system means we start in a vein and extremely sorry. We start in a capillary. Very sorry on that one. Then the capillaries are going to form a vein and it will again end in a capillary. What is very important part of this system is what is the technical difference in these two kinds of I need to draw. Number one, in the system circulation, what is the thing that I am to draw? Yeah. What is the material that is present? This valve in the venous side and on the arterial side. What is there on the arterial side? Are muscles in the wall of the vessels. That is arterioles and arteries. Now, whereas in a capillary, which makes into capillary, what is very characteristic is that there is no vein in the full system. So that means it's a direct flow of blood that goes from one capillary and another capillary, and this pressure, that means the term P, is a. Okay. Can you name any other part of the human body? Okay, the gentleman.
Hypothalamus pituitary.
Very good. Excellent. Chocolate. Nowadays I will be keeping a chocolate. So it is from the capillary and goes capillary network of the anterior appreciate that. Anything more, to the best of my knowledge, it is also present in the cortex and the medulla. Okay, sorry, forget about pituitary and hypothalamus. Let us talk about portal system. Now, in this part of the portal system, very, very rightly said, as there are no valves, that means it is very easy for the blood pressure to rise and thus the direction of the blood pressure. So if we erase all of these parts, let me take a second, and if we erase all of these parts, it becomes easy to understand what is portal hypertension and what are the reasons about portal hypertension. Just a second. Just a minute. Okay, right. So it is very easy for us to understand. That means in this type of system, either there are capillaries in the spleen or there are capillaries in the vessels or the intestine. And both of them, that means the intestinal vein is the superior mesenteric, this is the splenic vein. This is something that we knew from our anatomy days. And then it goes to the liver. I have crossed the thank you. And then when it goes to the liver, it again forms major branches to again go back to the liver capillaries, which are technically called as sinusoids. This in turn make into a proper vein, and the veins are going to drain into the inferior vena cava. Now in this part, so this is what exactly is the anatomy, and we all know about a prehepatic, hepatic and posthepatic process, right? So Coma, this is what is a portal system of circulation. Please remember that. If there is an increase in the pressure in the wall, that is the main problem called portal hypertension. Final points before I again ask you about this patient. Normally remember the direction of the flow of the blood is towards the liver, called as hepatopetal. But due to the block, now understand that where has the block or where will the block be, so that the direction of the flow of the blood will now be in a reverse way. Okay. So remember that in that direction, what exactly is the main problem is, if the causes are usually prehepatic, that means that this is the liver and this is the vein. And remember that if there is a block in this part, blood can still try to go on this area and bypass this area to reach up to the liver. Okay. So what is the direction of the flow in this picture that I have made? Hello, what is the direction of the, what is the direction? Is hepatopetal only. In this kind of patients, what is the characteristic finding in these kind of patients is they have a mild splenomegaly. But remember that as there is a block in the portal pressure, there is blood that tries to go from the viscera to the portal circulation via abnormal pathways, or they try to go into the systemic pathways. So this group of patients are technically called as an extrahepatic portal venous obstruction. And what is the main manifestation in this group of patients?
Ascites.
Okay, it is again a GI bleed. Rather than now in them, splenomegaly is not a major finding, but GI bleed is a major finding in this kind of patients. Ascites is there. Okay, right. Whereas if you talk about diseases of the liver and post-sinusoidal or pre-sinusoidal, again blocks like in NCPF, remember that in this one, the extrahepatic part is more or less okay, but they are getting blocked at the second or the third or the fourth order of the venules. Hence, blood does not follow this, blood follows this way. Hence, in these patients, you get a big spleen. GI bleed is always an accomplishment. So this is our background. Okay. Now, the first question is, you said this was portal hypertension. Now, why did you say this is portal hypertension? Why did you say this is hypertension? Okay.
Yes, sir.
Hello? Why did you say this is portal hypertension?
Sir, points in history and points in clinical feature on examination. On history, patient is a chronic alcoholic, and he's complaining of multiple episodes of hematemesis. He's complaining of melena. He's complaining of abdominal distension. And points on examination, there was ascites, splenomegaly.
Okay, wait, one by one. Let us come to it slowly. Now, the reason I said this is portal hypertension is because, number one, the patient had been a user or abuser of alcohol for a long duration, that and in the amount of the alcohol to induce a liver disease. So if you are asked the reason, why did you say this is a portal hypertension? Sir, I said this is portal hypertension because with the history of use of alcohol, remember that the patient may have had a history of a chronic liver disease because of the amount of the alcohol consumption. Okay, so this is the first point in the story. The second point in the story is that the patient presented with an upper GI bleed, okay, and an ascites and a splenomegaly, which is the all of these three are signs of a decompensated portal hypertension. Hence, sir, with this background of alcohol liver disease and with these manifestations of decompensation, I felt this is a patient with a portal hypertension. Okay, good. So this is the way you defend. Now the examiner will be coming back to the history and will come back to the history and will gradually start with a few points to discuss. Now, first of all, this patient presented with a history of a vomiting or a patient of a hematemesis. Now, let us have a quick recap about what are the causes of an GI bleed. Hematemesis is an example of an upper GI bleed. What are the main etiologies of an upper GI bleed?
Sir, is variceal causes and non-variceal causes?
Okay, good one. Variceal and non-variceal causes, right?
Non-variceal causes most commonly peptic ulcer disease, esophagitis, gastritis, polyps, carcinoma, rare
After
causes.
peptic ulcer disease comes Mallory-Weiss. Okay, you have arteriovenous malformations like Dewler-Foy's lesion. You have tumors like stomach cancers and cysts, etc.
Polyps.
Okay, and polyps you may say to talk about. But out of this, the most important one is always a peptic ulcer disease. In a variceal bleed, it is usually esophageal varices, gastric varices, and portal hypertension. Very good that you know that. Now, my question is, if this is the cause of an upper GI bleed, why did you feel this is due to a variceal bleed? Because peptic ulcer disease is the most common cause of an upper GI bleed. So why did you feel this is upper or due to a variceal bleed?
Sir, duration.
Sir, the answer is again, see, the question is why did you feel that upper GI bleed is due to a variceal bleed? Sir, because the patient has a history of long-term intake of alcohol abuse. So that will lead to a chronic liver disease. Yes. And in a patient with a chronic liver disease, the most common cause of an upper GI bleed is an variceal bleed.
And secondly, sir, it's
right. And secondly,
it's association, like pain association with food intake.
Very good. That means, sir, I also took a negative history. In the negative history, remember that the patient in the negative history, that the patient did not have any episode of pain in the abdomen, neither any pain in relation to the food. As I have said, malodorus is not a problem because the patient did not have a history of retching or straining. Okay. Now, so the patient measured the amount to be to 50 ml. I will say it was about a cup of blood. It was fresh blood and that. Okay, good. Now, he also said that in the past 2 years, he had such episodes and multiple endoscopic interventions has been done. This, remember that, is an extremely important point. And for good students, you are asked, what are the criteria that predicts a rebleed? Do you know of any scoring for any rebleed?
Sir, Rockel.
Okay, so the Rockel scores are the common ones that are used. Okay, right. Now, the last episode of hematemesis occurred in last month. You also had a patient of melena. That means you are trying to say about this one and this. Now, but with this parallel, you are also trying to say that the patient had an epigastric pain. How do you explain that?
So he was telling there was mild pain in the abdomen, which is mainly localized to epigastric region.
Okay, so are you trying to suggest that there has been an peptic ulcer disease also?
No, sir.
Okay, very good. Why not, sir? Because you have already mentioned, this is not associated with a food intake. Sir, if it was a peptic ulcer, remember that it had been due to food intake and could have been relieved with antacids. In medications, talk about antacids. Okay, right. So this completes. Also, if this patient complained of a gradual progressive abdomen, more in standing position. Why does this happen, sir? You are trying to comment that when the patient lied or was in the bed, the edema or the abdominal distension decreased. But when the patient stood up, the abdominal distension had increased. When he lied down, the abdominal distension decreased. Do you want to say that?
He was complaining that the swelling increased while walking, more when he was standing and doing work.
Okay. Do you know how does this thing happen? Can anyone explain this interesting thing? Did you understand what your Alcama tried to suggest? Hello? What he tried to suggest is that when the patient stands, remember, fluid is heavier than air. So when the patient is standing, what happens is the abdomen takes some configuration like this with the water and the bowel loops floating up. Okay. So this looks like this. But this patient, when the patient lies down, remember that the fluid is now distributed across the full abdomen. The bowel loops are distended like this. Hence, the patient had a bulging of the flank on both the sides. And the patient had a feeling that the distension had a bit. Okay. So this is usually subjective. But again, really don't mention these points. These are not very strong points to mention in an examination. You could mention a swelling of the feet and the ankle. This is absolutely perfect and done. Okay. Now the patient also complained there was no lump in the abdomen, weight loss or loss of appetite. Okay. Now, history of an alcohol intake. How much amount of alcohol did the patient take?
So he told like he used to take alcohol more than 4 days a week. Like, and every time he used to take more than like 2 to 3 pegs.
Peg. Now, okay, I'm asking a tough question. How much amount of alcohol is there in one peg?
60 ml.
Okay, so it's a large peg then. Okay, right. So I do not drink, so I cannot tell. I know about a small peg and a large peg, right? But important things are, what is the amount of alcohol that a patient needs to take or to develop a cirrhosis of liver, particularly males, because in females it can be.
In males 180 ml.
Okay,
more than 180
so good
ml,
one.
females 120 ml.
Good one. So that means it is said that about more than 180 ml, to make it a round figure, more than 200 ml of an alcohol. Okay, and what is important is to alcohol, which is usually consumed over a period of 10 years, is said to produce the cirrhosis of liver. Now, this is not an independent factor. There are multiple factors like genetic factors, other coexistent diseases like other hepatitis, or let's say like hepatitis C, obesity as a factor. These factors also matter. Okay. So this is all about alcohol intake. We don't have time to talk about alcohol intake, but what you are also required to take is, what are the other problems that occur due to alcohol intake should be asked about. De-addiction, did you try to take any alcohol related medications, etc. should be asked. Now, he also told there is no history of fresh PR bleed. Why did you ask about this one?
So to rule out any lower GI bleed.
Okay.
Right.
Lower GI bleed. Okay, right enough. I will go by this point. Now, talking about the other morbidities. Now, as I have said, it is better called as a past relevant medical and a surgical history. Now, at this point, Coma, I think that maybe you mentioned this point, but then I would be more happier if you had mentioned about hypertension, diabetes, what are the medications if there were. I am very interested with asthma, and you mentioned why am I interested with asthma and COPD?
If the patient is respiratory compromised, then if the patient is in decompensated liver disease, if they're planning for liver transplant.
No, sir. What is the drug of choice that is used to prevent a esophageal bleed? Is propranolol, non-selective beta blockers, isn't it? Now, if you are using a non-selective beta blockers like propranolol, this patient can, remember, will be a beneficial drug. So that means patient who have asthma and COPD, you are not allowed to use non-selective beta blockers. So you need specific selective beta blockers, and in them, this group of patients, you need a calcium channel blocker. Okay, right. So please remember that as a part of the treatment to prevent a bleed, you are required to take, or you are required to give the patient propranolol. Now, propranolol is a non-selective beta blocker which is contraindicated in patients with asthma and COPD. So in these circumstances, we use something called as a calcium channel blockers to be used. Okay, right. So the other points of the story are, apart from this thing, you are also required to take a history about a blood transfusion, maybe in relation with hepatitis B and hepatitis C. High risk behavior. Again, high risk behaviors are more associated with transmission of hepatitis B and hepatitis C. And remember that IV drug abuse in the addiction part is extremely important, again in relation with hepatitis B and hepatitis C. Have I made you understand up till this point?
Yes, sir.
Good? Right. So these are the points to be added. Now, in this pattern, what I'm more interested is the amount of the protein intake. Because what is this diet intake? Vegetarian, non-vegetarian? If it is non-vegetarian, okay, or vegetarian, what is the amount of the protein that the patient took? Because remember, why do I want to restrict the protein in this age group or this?
In this patient, especially to prevent encephalopathy, like.
Very good. So that means I am required to know about the protein. I am required to know about the salt intake. What about salt intake?
Ascites, sir.
Very good. So I need to tell the patient to restrict the salt for the treatment of the ascites. Now, apart from that, we have talked about normal sleep pattern. Why are you so interested in the normal sleep pattern? See, I am going by each and every. Because sir, early encephalopathy, remember, produces a reversal of the sleep pattern. Patients will have a daytime somnolence rather than nighttime sleep. Okay? Right.
Yes.
Now talk about the examination. In examination, first of all, I am very happy that you mentioned hydration. Karnofsky, well, I do not know. Did you feel this is a hepatocellular carcinoma in a background of the cirrhosis liver?
No, sir, I did not feel, but for a safe side, like given.
Ray, come on, Alkama. What
the ECOG is mainly for carcinoma.
I know that, but see, unnecessarily, if you said Karnofsky, does it in any way help you in treatment of this patient? Tell that to me.
No, sir.
I don't feel. Then the only thing that you will be required to use is something called as a child score.
Child.
Isn't it? Right? Okay. If you are talking about the child score, you know the components of the child score. You have seen for ascites. You have seen for encephalopathy. Now, oh, I really forgot. Was there a history of
jaundice? Sir, no history of jaundice.
Yes, so that means again, let us see the child score. No history of jaundice. Was there a history of spontaneous bruises?
No, sir.
No, that means, see that way, I went in retrospective, I thought, this is the point, yes, so this is the point that I need to talk about, something called as the child score. Because the child score is something that is central to my thinking about this
management.
Process. Exactly. So that means what are the points in a child score needs to be talked about. Now, we have said about the heart rate, the blood pressure and this. And in a chest examination, I think we have also noted about the air entry into the chest. I am digressing from the general survey, but these are all important points. Now, you said this is a bilateral pedal edema present. Okay, people will ask you what is the grades of pedal edema, what is the grade 1, grade 2, grade 3, grade 4. We are not required to talk about this. It is better to talk about that the edema is a pitting edema, which is dependent. Okay, now, and then apart from ascites, you said there are no other stigmata of a liver failure. Either you can mention it here or you can mention it during your whole survey. Now, lymphadenopathy, as you have mentioned this cancer story, the virtues may be mentioned if you like that. Clubbing is very, very, very important. And it is good that you have mentioned that there was no clubbing. Why am I interested in cyanosis? Icterus or jaundice, everyone knows. Why am I interested in cyanosis?
Cyanosis.
Okay, good one. Now see, cyanosis because hepatorenal and hepatopulmonary syndromes are technically, exactly. So hepatopulmonary and hepatorenal syndromes are long-term bad endpoints about a decompensated portal hypertension and cirrhosis. Now, hepatopulmonary syndrome, remember a big part of hepatopulmonary syndrome talks about an hypoxemia. That means the major part of the discussion then will go into what is the hepatopulmonary syndrome, what are the striae of hepatopulmonary syndrome, and those parts. So it is good to talk about cyanosis, particularly in a room oxygen saturation. Okay, right. Now, systemic examination, it is not called systemic as I have said, it is called as a local examination.
The local regional.
You have said the abdomen flanks appear full. What is very important is no dilated veins are seen. Now, can you tell me a condition of a portal hypertension? Okay, now I know that it is caput medusae. Tell me one important thing, doctor. In which kind of or at which point of a block in a portal hypertension do you think veins are very prominent? Or I asked you more or less, not a very intelligent question. Exactly. Please remember that if there are dilated abdominal veins, the presence of a dilated abdominal vein goes in favor of a diagnosis of a portal hypertension. But, if dilated veins are not present, can you exclude a portal hypertension from this? No, because there is a subgroup of etiology of a portal hypertension called as EHPVO, where dilated veins are usually absent. Remember that EHPVOs do not usually lead to a dilated vein. But if there is periumbilical vein, that means the caput medusa, whatever you call that to be, what or where is the probable block in the portal system? Prehepatic, hepatic, or posthepatic?
Posthepatic.
No, sir. It is usually, if you are talking prehepatic, then it is maybe NCPF, but more or less, the caput medusas will indicate there is a sinusoidal level block, or that means there is a hepatic level of block for a caput medusa. Now, in a case of a posthepatic, so for example, a bud cherry, what are the sites in the abdomen that you get dilated veins?
So the veins which is above the umbilicus, the direction of the flow will be opposite. That will, it is mainly away from the umbilicus. That will be toward the umbilicus.
Okay, so you are talking about the directions that I asked you about. Where do you get veins in a bud cherry? Sir, in bud cherry, we get veins around the caput medusa, but also we get veins in the lateral part of the abdomen. We get dilated big veins in the lateral part, and are usually due to hepatic venous thrombosis exactly into flanks. Okay, right. Now, so these are all the points. Now, you also said visible pulsations and peristalsis are not seen. Okay, I will agree to both of these points. Good one. Now, whenever you are talking about palpation, now what is more important in palpation in inspection is that you said external genitalia appears normal. In this male patient, what is the changes that you have seen, or what are the stigmata of the liver disease that you have seen or ruled out in this patient? Let us come to that bluntly. What are the stigmata? Start from the face, the chest, the neck, face, neck, chest, abdomen, hands and feet, and the groin. Okay, let us start with the face. So that means the face should have been described in this part. Yes. So now what are the points in the face that happens?
Alopecia, icterus, fetor hepaticus.
Number 2. Number 3. Number 4.
The parotiditis.
Okay. Number 5.
So this much I know in the face.
Okay. Number 2. Okay. So bilateral parotid enlargement. The fetor hepaticus, a pinched up nose. Some people say about and facial, there is a special tan-like color in the faces, right? There is a temporal wasting of the temporalis muscle, and there is a forehead baldness. Let us talk about what happens to the neck. What happens to the neck, doctor? In the neck, you can get spider nevi, or this is a cardiac cause, right? So if you can get this, now in the neck, you can see a dilated veins in the neck due to a cardiac cause maybe. What about the chest now? The chest again the same thing. The spider nevi, right? And in males, remember it is gynecomastia. In females, there can be atrophy of the breast. That is not a major clinical finding that we get. In the abdomen, apart from the caput medusa, ascites, which is seen as a bulge. Okay, so these are the main points. Right. In the genitalia, what are the findings?
Testicular atrophy in males.
Okay. And loss of pubic hair and testicular atrophy. Right. And what about the legs that you see? What happens to the legs?
There's a scratch marks in abdomen.
Scratch marks in abdomen are not very specific. They are particularly due to secondary biliary cirrhosis. What is the finding in the lower limbs? And it is dependent pedal edema.
Pedal edema.
What is the finding in the hands that you get to see?
Hands, brittle nails.
Okay, right. So number 1 is palmar edema. Number 2, right. Number 2 is Dupuytren's contracture.
Yes, sir.
Okay, so then again there can be finer points like changes in the nails, nail changes. Okay, so these are the more or less and summary about your chronic or stigma of chronic liver disease. So that means you are required to incorporate that points. Okay. Now you also found that the spleen was enlarged. Why is this the spleen? We are not going to talk about. What is important is in percussion you found there was a presence of shifting dullness. Fluid thrill was present. Okay. Upper border of the liver dullness was felt in the 6th intercostal space. Now, important questions are how much amount of fluid needs to be present in the abdomen to elicit a fluid thrill?
Sir, more than 1 liter.
Okay, I knew about more than 1.5. More than 1.5 liter is the amount of fluid to elicit a fluid thrill. Okay. Now talk about auscultation. In auscultation, apart from bowel sounds, if you place your stethoscope around the umbilicus and place your stethoscope around the left lobe of the liver, what is the abnormality or what are the sounds that you get to hear in these areas? Anyone please?
Venous hum.
Okay, what is this venous hum story called as? What is this venous hum thing called as? What is the name of this syndrome? Anyone please? What is the name of this syndrome? Come on, what is the name of the syndrome? When you put a stethoscope around the umbilicus, you hear a venous hum. What is the name of this condition? This syndrome is called as Creutzfeldt. Right. It is called as Creutzfeldt syndrome. Is due to increased circulation in the veins in which system? Around the caput medusa. However, if you place your stethoscope near the left lobe, remember that, or in the epigastrium, you get a venous hum, which is more louder on inspiration. What is this sign called as? What is this sign called as? Come on. This sign is called as Cagb sign. Okay. So whenever you put an auscultation, please remember, this is important to mention these two that I did not feel for any of this problem. Okay. So these are the points to say. DRE you have said, okay. Any relationship of hemorrhoids to this condition?
So photosystemic.
Exactly. You walked in the trap, Alkama. Internal hemorrhoids are not a result usually of a photosystemic shunt. This is a base go out of the misnomer concept. If we are talking about a photosystemic shunt, that is a rectal varix that comes due to a decompensated portal hypertrophy. Okay, right. So other systemic examinations are within normal and have completed. So this completes the story about what is what. If someone has any questions, please feel free to ask. Before in the next 20 minutes, we talk about the treatment. Welcome has presented more or less a good case. I am happy with the case presentation. This is not a very easy one to present, but she did a good job. Anyone has any questions till this point? Please feel free to ask me.
Sir, is there any way to differentiate between rectal varices and hemorrhoids clinically?
Yes, sir. Rectal varices are continuous columns of blood that are technically external and internal. Point number 1. Point number 2. Rectal varices are compressible lump. That means whenever you are doing a proctoscopy, whenever you try to blanch that varices, remember that they are again going to come back very soon. So this is one among the rare presentations of a potent systemic hypertension. Internal hemorrhoids, remember, are usually a reducible or they will only prolapse when the patient strains in a grade 2 or a grade 3. So that is the difference between, finally, the color of the blood when it bleeds in a hemorrhoid, it is bright red. because hemorrhoids are dilated arteries or cushions, whereas the rectal varices are venous, and the color of the blood is dark red.
Thank you,
Okay,
sir.
other questions, please.
So criteria that predicts rebleed.
I could not understand that. Can you kindly repeat?
Criteria that predicts rebleeds.
Criteria for
Rebleeds.
criteria for rebleed is a theory question. Please look into the score in Saviston, Rocal score.
Local school.
Okay. So there are other scores that gastro guys use called as a bleed criteria, etc. The Rocal is a very favorite one with our gastro guys. So there are other scores as well. So you are not required to say that in a Viva examination. In theory, yes, it is important. Right. Any other clinical questions? Because we now come to the discussion part of the story. That is pretty important.
Hello, sir.
Yes, sir.
So why is
Sir, could you please explain again?
One by one, please. Would you please explain? Yes, sir. Would you please explain?
Yes, sir. Sir, the direction of the flow and the level of the obstruction in the caput medulla.
Direction of the flow and the caput medulla. That means, do you want to ask me about what is the caput medulla? How does it form in that? Okay, so you are again asking me about the direction of the flow. Okay, see, in a normal human being, the inferior epigastric veins usually go away from the umbilicus and they are going to drain into the great saphenous or the femoral vein. Whereas the superior epigastric vein are not that superficial, they are embedded into the rectus muscle. So when you do an open cholecystectomy, you usually get to encounter them. And these are known to drain technically into the internal mammary and the musculophrenic veins, which ultimately will drain into the superior vena cava. So this is usually the direction of the flow. So this happens in a normal human being in this way. Now, what happens into that liver story? Now, as I've said, the portal vein, understand that the portal vein was like this. This is the spleen side, this is the intestine side, and this is the liver side, the right and the left. Now, what is important is that the right and the left are very good, so far so good, with only one small problem. When the portal vein developed as an embryonic remnant, the communication between the left branch of the portal vein and the umbilicus, which is an obliterated vein, that means a partially collapsed vein, this road now opens up in a portal hypertension because of one single reason. If blood presents that there is a block in the way, that means blood will only have to take a route in this direction. I hope you will all agree with me. So blood is taking the route in this direction. If blood is taking the route in this direction, then remember that we are going to have a vein which are going to come like this. And now see, if the veins are coming like this, there is a new conglomerate of veins which are going to come on all directions. And these veins are somewhat looking like this. But the direction of the flow of the veins, for all practical and technical purposes, are going to be up and in around the umbilicus, towards the umbilicus. From below the umbilicus, they go again away from the umbilicus. But this cluster of veins is called as a caput medulla. So have I made you understand the flow system, sir? Hello?
Yes, sir. Yes, sir.
Good. Right. Now, I think you have understood what is this Baumgarten syndrome, the Kenna-Weissin, etc. Any other question before we go to the treatment?
So what is the difference?
Now, recompensated because it is
आया है compressive collapse of D5 vertebral body noted with evidence of infiltrative disease process and associated with the paravertebral soft tissue extension into the epidural space. अच्छा एक्यूट पैराप्लेजिया बैठा हो तो तुम्हारे पेशेंट डॉक्टर पेशेंट है
like hypersplenism or
अब फायदा है ए भाई 5-6 दिन हो गया तो फायदा कटे फायदा कटे कुछ उसको बोलो कुछ डॉक्टर फायदा है उसको 5 दिन के बाद
there are none, so we proceed to the pardon please I could not can you
नहीं मैं बोलो आने वाला है उसका 5 दिन के बाद
well I do not
जल्दी कर उसको
my gastrocolic
मेडिसिन में है
very well aware of maybe because of I do not know.
जैसे तू मुझे फोन किया था मैंने कहा भेजा ना मैंने
what is this patient now it's not that also so the
मेडिसिन का केस है सर ब्रेन
you with the GI
अबे ब्रेन पार्ट में पैराप्लेजिक कब बैठता है देख मैं जब मैं देखने गया पेशेंट को तो उपासना बोलती सर उसका हमारे ब्रेन में इन्फार्क्ट है हम बोले हमारे ब्रेन में नो इन्फार्क्ट तो पैराप्लेजिक कैसे बैठता है
this must be an blood grouping and cross matching and the patient is prepared for a blood transfusion because in a clinical finding you have always mentioned there is presence of pallor. So this patient is admitted, resuscitated and you need a blood transfusion. Point number 2, after that as I have taught in the GI bleed chapter, within 12 hours it is important to go for an upper GI endoscopy. This patient already has had 6 such episodes. Dr. Alkama said that. And with an upper GI endoscopy, the bleeding varix needs some control. However, if the endoscopist fails to control, then there are other maneuvers. Example being a tips to be done, as if, or not a shunt. A stent nowadays are done rather than a shunt because selecting a shunt, remember, if you do not have a facility for a tips, under these circumstances, in a dire case, as an emergency to control, then and then only, either you go for a devascularization or you go for a shunt. Both of them have their own advantage and disadvantage. But majority of hospitals will be doing a tips or a stent nowadays, which is a covered stent. That now, where does this balloon story come in? The SB tube story come in. SB tubes, remember, SB tubes always remember are a temporary maneuver because the first line of treatment of any variceal bleed is the medical management. What is medical management? Okay, Alkama, can you name some medical management of an upper GI bleed?
Sir, octreotide, vasopressin,
okay, so that means somatostatin, analogs, particularly octreotide, and you are required to know the dose of octreotide.
So 50 micrograms.
Right. You are required to know the dose of octreotide. You are required to know the side effect of vasopressors. Please remember, we do not have that time. It's already 1 hour done. So please understand this part. So dose and side effect. So this is what is usually done, and this is what the examiner is wanting you to say as a part of a viva. I will resuscitate the patient check the vitals, admission for blood transfusion. At the same time, I will start on decreasing the portal venous pressure by use of somatostatin analogs. Whatever you use, the drug and the dose and the side effect, and then followed within the first 12 hours by doing an upper GI endoscopy. What is the algorithm? You know that. Now, after the GI bleed is controlled, please remember this is the first priority. After the GI bleed is controlled, remember the most common cause of death in patients of cirrhosis are GI bleed. Then my next concern is two. Number one, to prevent a GI bleed. Number two, to treat ascites. Okay, and to prevent NCAF, prevent hepatorenal syndrome, hepatopulmonary syndrome. So these are the preventions that I have in my aim. So my aim of the treatment is to prevent all of these. To know about what I can do for all of these is that the first thing that I will do for any like cancer, I go for a staging. I go for something called as a childhood score. I hope every one of you know what is the childhood score. We are not going to talk about what is childhood score, but this is extremely important for a viva and a theory and an MCQ. Okay, Alkama, can you quickly mention what are the 5 parameters of the childhood score?
So bilirubin, ascites, albumin, INR, PTR-INR, and encephalopathy.
Okay, so bilirubin, ascites, encephalopathy, INR, and serum albumin. Now, when I talk about INR, what parameter is usually mentioned in INR? Because there are a group of examiners who are going to pick you exactly or by bones on what are the components of the childhood score. Can you tell me what are the important things to remember in this INR? What is the INR scoring in this childhood score?
Sir, 012, score 012, that is 1.5, less than 1.5, 1.5 to 1.7, more than 1.7.
Now see, what is important is either you can mention the INR or what the examiner is wanting is prothrombin time prolongation.
Okay.
Not PT, sir. Normal prothrombin time can be 35 seconds, 40 seconds. If the normal PT is 30, patient's prothrombin time is say 40. That means how many seconds does it increase? However, majority of us will use INR nowadays. Okay, but there are older books, there are older examiners who will like to ask you questions about the component of prothrombin time, not the prothrombin time. How much seconds is the prothrombin time prolonged in relation with the test? So this is more or less the INR. The other components are something that you know of, and we are not going to talk about this. So this is what is the important part to assess before you plan on any treatment part. Okay. Now, after you have done that, then the first part of the story is if this patient is a child A, then what is your overall assessment of the patient and what is the overall treatment that you plan for such a patient? Okay, if I do get disconnected, there is a gentleman, I do not have there's good internet connection now. There is maybe a thunderstorm that is going on, but still. So I'll be joining back in a minute. So now tell me. So if it is a child A, what is your plan?
The tips.
Exactly. So
we can do conservative treatment.
No, child A is a group of patients who have a 10-year survival, which should be looking good and should have around a 10-year survival of about 50 to 80% should be with a good 10-year survival. And in this group, either you go for a conservative management or you go for a shunt surgery or symptomatic management and a prevention of a rebleed. Whereas if it is a child B, remember that if it is an early B, that means you should think about a shunt surgery. If it is late B, it is always you go for a liver transplant. If it is a child C, go for a liver transplant. But child C, the donor is not available, or a late child B, it is always good to go with a TIPS and then go for a liver transplant. So this is the algorithm that is overall used. Yes,
In
sir.
child C also, sir, is it?
Sir, as I've said, you do not get a donor so easily.
Okay.
Getting a donor is not a very easy thing. Transplant is the term. This patient, remember, the 10-year survival rate of near zero. This patient is not going to live 10 years. His 5-year survival rate may be hardly 10%. Okay. Child B has a 10-year survival rate of about only 30%. So this group also is not a very strong group. So liver transplant has to be selected for a child B and a child C. So this is what is usually done in your plan. Now in this part you are asked various subtopic questions like what is the management modality of a UGI bleed, in which we'll discuss only the questions. That means the main modalities are sclerotherapy versus endoscopic variceal band ligation. What is the advantage? What is the disadvantage? What is the complication rate, or something that you are required to know. Now, we have discussed it in the one ward round class on variceal bleed. As I've told, you have the Baveno consensus or the Baveno 6 consensus to talk about what to do in this part. Now, let us talk about ascites today. Okay. Welcome. How does or why does ascites happen in a patient with a chronic liver disease?
Sir, ascites, it is mainly due to increase in the oncotic pressure, decrease in the oncotic pressure, increase in the hydrostatic pressure. Decrease in oncotic pressure due to decrease in the albumin and protein content due to deranged liver function.
Agreed. That is perfectly right. But tell me, okay, that is something, then you should have a generalized edema, anosarca, isn't it? So now can anyone tell me what is the modern explanation for development of ascites? Hello? See, the main hypothesis that is promoted is that is the reason spironolactone and those drugs are helpful, that cirrhosis of the liver leads to a part of development of or the increase of nitric oxide. Okay. So now what is nitric oxide? Nitric oxide is an arterial vasodilator. So if there is a vasodilatation, okay, now if there is a vasodilatation, remember that there is both an arterial vasodilatation and then the venular vasodilatation. So now if there is an arterial and a venular vasodilatation, then the main problem is the preload that reaches the heart decreases because blood is okay. And also parallel to this, the systemic peripheral resistance is also decreasing. If there is a systemic peripheral resistance, that means preload decrease means the cardiac output decreases along with a decrease in the SPR. Both of these are happening at the same time. Okay. Now, what is important is this leads to activation of the renin-angiotensin system. Now, when the renin-angiotensin system is done, remember that this leads to retention of sodium and free water. And thus you get ascites as a part. What is more important is why does fluid get accumulated in the peritoneal cavity? Why not in the pleural cavity? Why not in the limbs? Why not in the legs? The answer for this is, remember that everything goes by that Starling's hypothesis. There is a vein. Extremely sorry on this part. This is the capillary. This is the capillary. This is the arterial end. This is the vein end. Now, in a portal hypertension, this artery gets replaced by the vein, and the pressure in the vein wall is so great that it produces a transudation of fluid. So this is usually the hypothesis that is given for development of ascites. Okay. Now, so this is what I know with my little bit of medical knowledge. There can be new hypotheses that have come up. So is there anything new that has come up in the recent years? Hello?
Yes, sir.
Anything new that, okay, what is the new thing that has come up in the etiology of ascites? Hello?
New thing, sir, I don't know.
Okay. I also do not know any new hypothesis, but this is what I know. Now, what is the treatment of ascites?
So medical treatment, spironolactone 25 milligram BD we can give.
See, good one.
Restriction of salt.
The first part of ascites that you are required to tell the examiner is something called as a diuretic responsive ascites, which is treated definitely as the name suggests by use of a diuretic. The next stage of the step is something called as a refractory ascites. That means that the diuretics are not working.
This is surgical management.
So refractory ascites, you can treat it by paracentesis or surgical management. And the final route of an ascites is development of hepatorenal syndrome, which is the last part of this. What is important is, viva question, in a compensated patient, there is a new onset ascites. What is the etiology for this kind of new onset ascites? Either development of a hepatocellular carcinoma or a decompensation that is happening. If the patient was in a compensation and he had a minimal ascites, suddenly there was a large appearance, think of a hepatocellular carcinoma. Now, what are the drugs? You know that. Okay, what are the drugs? The dietary restriction of sodium, spironolactone. What is the dose of spironolactone? So these are the things that are to be remembered. Remember that we titrate upward the dose of spironolactone. Okay, right. Now, this is, what is this? Now, what is the disadvantage of use of furosemide or Lasix? Hello? Hello? What is the use of furosemide? Hello? Come on, what is the use of Lasix or furosemide? Hello? Am I audible? Hello?
Yes, sir.
Right. What is the use of furosemide? Remember that if it is not responsive to spironolactone, then under these conditions, you need to add furosemide, particularly when there is an increase in the potassium levels in blood. Okay, so this can be added as a part of this part. Okay, so this completes. Finally, let us talk about refractory ascites. In refractory ascites, what do you mean by the term large volume paracentesis? What do you mean by the term large volume paracentesis? Hello?
No, sir, I can't see anything there. I can't hear also properly. This connection.
Okay. So some of you who can see the screen, can every one of you see the screen?
Yes, sir.
Right.
Yes, sir.
So how do you define a large volume paracentesis? More than 5 liters per day. Now, to decrease the pulmonary decompensation, what is the precaution that you take? What is the precaution that you take?
Albumin transfusion.
How much amount of albumin do you need, sir? For each liter, you need 7 grams of albumin. That means 1 bottle of albumin, which is usually 25% or 20% of albumin, whatever you call this to be. Remember that if you are removing 5 liters, so 5 into 7 is about 35 or 40. You need about 2 bottles of 20% albumin. This is a 100 ml bottle. It contains about 20 gram of albumin per 100 ml. So please remember this. So you need 2 bottles of 20% albumin for each 5 liters of fluid that is used. So these are the things to remember. There are other surgical procedures like peritoneovenous shunts, etc. But they are not that popular given the chance of shunt occlusions or stent occlusions and spontaneous bacterial peritonitis and infections that happen. So this is all about the first part. We already had a class on hepatorenal syndrome. Dr. Rudhik Sena took that class. We'll again have a class on liver transplant as a part of this procedure. So this is all about a long case presentation. I'll come a very good presentation. This is a difficult case at a DNB or an MS level to present. So many arenas that we can go into is this. So please ask your questions in this area now. Then we will end the class. Hello? Hello?
Sir, in child tube score,
Yes, sir.
under the subheading of encephalopathy, there is something called as mild encephalopathy and moderate encephalopathy. So
Which one is mild? Right. Now, I read also that part because this has been always a very important question that I always have. And if you talk to our gastro colleagues, they have something called grading of encephalopathy. Okay, what they have is that they have various codes of grading into hepatic encephalopathy. They use their various codes, but on an overall, grade 1 means an altered sleep pattern. Grade 2 is having a lethargy, asterexis, etc. Grade 3 is somnolence or semi-stupor, disorientation in time and place, whereas grade 4 is coma. If you search the internet, you will get a criteria called as West Haven criteria. Okay. So this is used in the child book.
Thank you, sir.
Okay. Hello. Any more?
Sir.
Yes, sir.
Hello, sir. Sir, can you please explain how the splenomegaly occurs with the hepatic obstruction muscle?
See, the main thing is that this is a portal vein and this is the splenic vein and this is the spleen. Now, the main point is that all the blood is going towards the liver. And this is the liver. Now, the main problem in portal hypertension is that the pressure in this system, P, is more than what should have been normal. The spleen is giving the blood to this system. So automatically, it is very understandable is that if these are capillaries which are draining into the splenic vein, if they are getting a pressure to release their content into the splenic vein, blood will get accumulated in the spleen and the spleen will obviously be enlarged. Then it will be basically a congested splenomegaly. Or on the other side of the story, now consider that there is a block in the portal vein, and this block in the portal vein is allowing the development of multiple collaterals that are again draining towards the liver. So that means, what do you think will be this P gradient? Will that be very high or high? It will be not normal. It will definitely be a little more than normal. But I hope you will appreciate that gradient of rise of the pressure will be moderate or mild maybe. And hence, in a patient with a EHPVO, what is the degree of splenomegaly? The degree of splenomegaly is usually mild. Whereas in a patient with an NCPF or a cirrhosis, what is the degree of splenomegaly? The degree of splenomegaly is usually huge. Why huge? Because there are no collaterals. It is not a circulation towards the liver. It is away from the liver. Hence, all the blood is now coming back to the spleen. Hence the spleen is enlarged like this.
Thank you, sir.
Okay.
So I'm connected that.
Okay, so any more questions? I don't think any. So with this, I think, ladies and gentlemen, we'll be signing off for the day. Thank you, everyone. Thank you.
Thank you.
Thank you, sir.
Okay.
Thank you,
Good night.
Thank you, sir.
Just give me a minute. Just a minute. Okay. Very good evening to all. We will start with a discussion on continuing with our clinical examinations. The last day we talked about abdomen examination. So today we will be trying to now be a little more broad. And before we start with the something called the screen visible for right, good. So before we start the examination of the systems, start with this is going to be a very long class. Last class was something on abdomen that we talked details. So today we are going to talk about what is a systemic examination or what are the other points to remember. Now, for a recapitulation, whenever you are examining a patient, particularly in an examination day or an examination table, what is important is you are required to ask the patient a few questions. That is something that is called as a history. And the more you mature with age, definitely your history should get truncated and your history should get focused. If you are planning to prepare for an MRCS examination, remember that in an MRCS, you are going to get about 7 to 8 minutes in that day to see and discuss with the examiner, just keeping 1 minute extra or 2 minutes extra with you for concluding your discussion. So that means in a DNB and an MS examination of the Indian system, this part of the history taking definitely can be a little more elaborated. But at the end of the history, remember, you must have a provisional clinical diagnosis that you thought over. Let's say, for example, a patient has a jaundice or he or she has a periampullary malignancy. So something that comes onto your mind and you are more or less proficient in the diagnosis thereafter. But the major part of the story that we are going to talk about is not about these parts. And then you go to something called as a local and examination, then you go to something called as a general survey. Extremely sorry on that part. So we talk about something called as a general survey. And after we have talked about the general survey, we will be talking about then into local examination. Now, the last class we talked about an abdomen examination. And finally, then we'll talk about, and after this, into something called as a systemic examination. Okay, so this is the schema of the things that we are going to talk. Now, whenever we talk about the systemic examination, what I will plan ahead is that I will talk about in each case or what are the common scenarios in surgery, and then we'll try to talk about with each scenario what could have been the findings on each case. Now, let us start with a patient with an abdominal pathology. Say, for example, the abdominal pathology could be a groin hernia, or could have been a abdominal lump in a quadrant, or could have been an obstruction, benign or malignant, or could have been a patient with an abdominal stoma for any reasons, or could have been a patient with an obstructive jaundice, etc. So I have given you a few couple of common scenarios that we are expected to find in a patient with an abdominal lump. Now, whenever we talk about the systemic examination, remember that systemic examination starts, or there is no definite rule that it will start with CVS, then it will go to SP, then it will go to musculoskeletal, then it will go to CNS, and sometimes even GI, etc. What is important for us to remember is that whenever we get one system, say for example in this patient, we got the GI system to be examined and we have done this part before. So now let us talk about the other systems of the evaluation that includes cardiovascular, respiratory, MSK, CNS. Now the minute you talk about these areas beyond the abdomen, remember that you are a surgeon who is examining the patient. You are being examined by a surgeon who is also going to treat the patient today or tomorrow exactly in the same thought that you will have. And hence, if you are having the same thoughts as the surgeon or your examiner, remember that your questions of examinations are very focused on what you are required to know for as a surgeon. Definitely, we are not medicine guys to talk over a detailed examination of the cardiovascular system, or we are not musculoskeletal, or you can be an orthopedic surgeon, but again, you have to be truncated in your approach. So let us start with the first one as having been talked over with the central nervous system and the spine. I always start with these two entities and sometimes as a part of the central nervous system. Remember that in general survey, you have already noted something called as alert, conscious, cooperative, and oriented to time, place, and person. Now, what is important is that these four words, alert, conscious, cooperative, oriented, this is a mnemonic that I remember, has to be described in the patient in general survey. That means because if your patient is tuberose or comatose, it becomes difficult for you to think over that what has happened. So this is usually the first part of the story to talk over. So alert, conscious, cooperative, and oriented. Now, on the other hand, when you are seeing the CNS, remember that particularly in patients with trauma or with a history of trauma or head injury, it is important to comment upon the Glasgow Coma score or the Glasgow Coma scale. Now, few words about the Glasgow Coma score and the Glasgow Coma scale, because this is something that you have to record maybe every day. And as I have said, this Glasgow Coma score is something that more or less of us as surgeons know that, and it is important for you to not only know that, it is important for you to elicit a Glasgow Coma score. Now, what is important, I feel, is a few modifications or something, some special things in the Glasgow Coma score that needs to be said. But before I talk about these points on a Glasgow Coma score, I feel that it is very quick and it is an apt time to revise about the three components of a Glasgow Coma score. Now, when I talk about or how to see a Glasgow Coma score, more or less every one of you know how to see a Glasgow Coma score. The first of the entities to see on a Glasgow Coma score is that you shout in front of the patient that what is your name, okay, and Then the next important part is that you see the response of the patient in a Glasgow Coma score. Now, what is important for us to remember is that this Glasgow Coma score, remember, is a very gross estimation, but a very global estimation about some three components. It technically is going to test you about the higher cortex. That means the parietal and the front, again, the temporal cortex and the parietal cortex, which are mainly sensory cortexes, the occipital cortexes and the parietal cortexes, which are again a part of the motor cortex. Now, what is importantly tested in that is, when we talk about this term called eye opening, remember that when is the first of the components is called as eye opening. Sorry, you all know about this, so I'll just quickly take you through the Glasgow Coma score. Now, eye opening is given a score of 1, 2, 3, and 4. Please remember that 1 is no eye opening, okay, even on pressure. Now, when you talk about the pressure, can you tell me what is the area that you are expected to elicit the pressure to, because in 2, the patient has an eye opening to pressure. So can you tell me which is the area that you should give the patient pain? Hello? Anyone with an idea? Well, still. Now, the common things that are done includes our orbital pressures and sternal rubs or sternal knock, you may say. Now, what this is exactly was done with the present critical care. If you talk to your critical care colleagues or you talk to your neurosurgery colleagues, they usually give pressure in 2 areas of the body. One, they see the fingernails, and in the fingernails, there is an area called as the lunule, L-U-N-U-L-A, the lunula of the nails. That is the white of the nails, they give a pressure, and that is very painful. Or they squeeze the trapezius muscle, which is again a very painful entity. So trapezius, I'm bad with spellings, and the pressure on the lunules. So this is all about pressure. 2 is eye opening on a painful stimulus. 3 is eye opening to speech. That means you tell the patient, and then this patient opens the eyes. And 4 is eye opening spontaneously. Now, there was once an examiner who asked a candidate a very interesting question. So by the time, as examinations in India run pretty long, the patient was asleep by the time the examiner came. And then the candidate called in the patient, okay, so Mr. XYZ, please wake up. The patient, okay. So he woke up, and then the examiner asked him, okay, doctor, so what do you think is the eye-opening score in this patient? So ladies and gentlemen, what do you think is eye-opening score? The patient was asleep, and then when you commanded, he woke up. So what is this part?
4.
Exactly. So remember that someone who is asleep, and then he wakes up, and you reassess the assessment again after 1 minute, is technically a 4. So this is the difference between a patient who is comatose versus a patient who is sleeping. So please understand that. A patient who is sleeping and is now awake gets a score of 4. Okay, right. The V component is technically called as the verbal response. You all again know about this one. 1, 2, 3, 4, and 5. Now, rather than talk it from 5, 4, 3 to 1, I call it as 1, 2, 3, 4, 5. It becomes easy for me to remember in an exam. 1 is the patient has no verbal response. 2 is the patient has incomprehensible sounds. That means moaning. Whereas 3 is inappropriate word. I know that all of you know this, but I still felt this is such a problem. Now, what is important is that 3 means the patient does not speak any technical sentence. Now, inappropriate word means I drink water, fruit, water, juice are all sensible meaning words, but the sentence is an incompletely formed sentence. So that is called as an inappropriate word. 4 is a patient. I want to drink fruit, but I am not. What am I going to drink? This kind of statement, remember, if the patient can form a statement, that is called as a confused on or 4 in a Glasgow Coma score. So please remember that the patient is thus still incoherent to your command. 5 is the patient is oriented and can complete the sentence. Say, for example, what type of fruit juice will you like to have, Mr. XYZ? I will like to have a glass of apple juice. Is a coherent statement. So please remember. Or what is your birth date? Is, that is, say, for example, 26th of January is the birth date. Okay. So that's no. So this is the verbal response. Whereas the last one is something called as the motor response. Now, in the motor response, again, I go from 1, 2, 3, and then 4, 5, and 6. Now, the reason about asking you or telling you this is for only one single simple reason. There are now days, particularly in an MRCS examination and in a ward round, where the examiner can ask you to measure or calculate the GCS. Please remember that. If you are thinking that, well, GCS is a table or a chart that is either downloaded in your mobile or is hanging in your ear, okay, I know that. All of you know what's a GCS. You have crossed a very tough examination to come here. But in an examination, remember that the examiner will exactly be pointing the questions that I asked you. Example, point number 1 is there is no motor response. Point number 2, the patient has something called as a decerebrate posture. And decerebrate posture, remember, is accentuated by pain or increased by pain. Now, when I talk about a decerebrate posture, what is the important thing to remember and how do I remember? Please see the picture that I'm going to make. If this is the patient, then the patient makes somewhat of a picture like this. You are, I know that you are smiling like me. I'm drawing an alien-like picture. Okay. But always remember the arms of the patient. See the arms of the patient. The arms of the patient look like the letter E. So decerebrate. So decerebrate is point number 2. And remember, the main point is decerebrate. I end with an E. And the response in this pattern is extensor across the upper limb and the lower limb. We are not going to tell. What is important, the examiner can ask you in a neurosurgery rotation is that if the patient does have this kind of a posture, understand that the pathology is in the midbrain or the pons. So this is something that is important for us as general surgeons to know about this part. You must be wondering, why should I be seeing these parts? Because this is important for your daily examination of patients, for all patients, not only one. Number 3 then is something called as decorticate. Now, if I have drawn the picture of decerebrate, so it is always good to also draw a picture of a decorticate. What is a decorticate? Now see the picture. The picture, remember that, and always remember we draw a picture like this. The patient's hands, remember, are somewhat like this. So what have you seen? The patient has his legs and the legs are crossed like this. So please remember this kind of a posture, the arms are now looking like the word called as C. and hence decorticate. C for decorticate. The arms are C. Okay. And remember that the legs will look like, if you have seen a carrot, again a C, looks like a carrot trunk which is gradually tapering down. So this is the way I remember. Decorticate is 3. 3 is C, whereas decerebrate is E. That means it is 2. Okay, so this is the way. Now, what does this decorticate nature of injury means? It means that there is either injury to the cerebral hemispheres or there is injury to the spinal tract, or there is injury to the spinal tract. So either it is cerebral hemisphere or it is problems with the cerebral spinal tract. Okay, so this completes this part. So this is all about the extensor in decerebrate, the flexure in a decorticate. Now talking about number 4 is withdrawal to pain. Now withdrawal to pain. Okay. Now withdrawal to pain, what is important is in this part, particularly in our head injury patients, etc., it is important is that when you give the pressure to the trapezius or the nail bed, whatever you do, the patient tries to lift the hand and you are required to stand at the head end of the bed. And if you give a pressure at the trapezius, definitely he tries to lift his hand above the level of the head to block you. But if he could not lift his hand, remember that above the level of the head or above the level of his chin, that is a number 4. Whereas number 5 is localizes. That means now this chap wakes, or this chap has his hand which is above his head and he tries to stop you giving him pain. So he localizes the pain. That means moves the hand beyond the chin to hold the examiner. And the last point is point number 6. This patient obeys the command to follow and moves the limb according to your command. So that is the number 6. Now the reason about talking like this, or the reason about knowing these parts, is very straightforward. In a patient with a head injury, particularly in an MRCS examination, you are given a patient who had a history of a head injury or a concussion injury couple of days back. So please remember that under these conditions, you are given this patient and you are asked about assess the or see the patient, in which the actor or the patient real one will be having a Glasgow Coma score below 14. So that means he or she will try to do this act or play act in which you are required to calculate the Glasgow Coma score in front of the examiner. Now, what is important in this is that, now let me see how good you have been in your emergency to know that. A gentleman, remember, has a bad form of head injury and he has a bilateral black eye. How do you assess the eye opening? Hello? 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 How do you assess the eye opening in this kind of patients? Am I audible, everyone? Hello?
Yes, sir. Yes.
Right. So how do you assess the eye opening in these kinds of patients? Right. See, if it is a bilateral eye opening, or say bilateral black eye, then it is better called as, NT. NT means it could not be tested. But if you can see the patient has one black eye, remember that the patient has a black eye and one black eye, then in this case, this eye is responding to command, like as you have said, but this NT and E4, remember that C. That means one eye was 4 and the another eye was C. That means you are going to take the 4 in the calculation, agreed, but you are also making a comment that another of the eye is C to look into. So please understand, this is a new terminology that have come up. This patient had a tracheostomy. So now what is this one? Under these conditions, the patient cannot tell any verbal command. So it is given as a T. Okay. The patient has an endotracheal tube in place. So you cannot assess the GCS. It is called as a VT, etc. So this is what are the minor modifications that has come into the Glasgow Coma score. And this is what you are required to know in this part on measuring the Glasgow Coma score. Now, what is the significance of a Glasgow Coma score in head injury is not the topic of discussion today. What is mild head injury, moderate, severe is not the topic today. My topic is to talk about systemic examination, and measuring the Glasgow Coma score is one among the most common pitfalls that a surgical resident has in his daily rounds or in a ward round scenario during an examination. Now, if the patient has a Glasgow Coma score 15 by 15 or a 14 by 15, but the patient says, I had a history of a head trauma and I am confused, under these cases, particularly in an MRCS examination, it is always important to assess something called as the mini mental state examination. The mini mental state examination, if you are into your neurosurgery rotations, then you will get to see neurosurgeons do this, or neuropsychiatry residents or neuropsychiatry colleagues do this. Now, this is a big examination. There are multiple points to look into, but for our purpose as a surgeon, we have truncated this into 10 simple questions. And please remember, we will exactly go through those 10 questions. And in the next, say, 5 to 6 minutes, you are required to remember the sequence of these questions. Because as I have said, particularly in an MRCS examination, this is one such way where the examiner wants you to comment upon, apart from the Glasgow Coma score, the examination of the neurological system. This is the second one, then followed by the pupillary examination, the sensory and the motor examinations. Okay, right. So let us quickly start on to this part. Now, whenever we talk about the mini mental status examination, remember that if we give a maximum score of 5, okay, and then this is the patient score. As I have said, this is going to take a bit of time, but I will rush through. The first of the questions is usually asked is, you are required to ask about which year or which season is it? Is it summer or is it rainy season or is it winter season? Can you tell me which date is this? Can you tell me which month is this? So this is the first question. The maximum score is 5. The second one is, so this is all about the time orientation. The second one is about a place orientation. That means, where are you now? Are you in a hospital? Which country is this? Okay. Which city is this? Is a second question. Now, the third one is that, if this is, the third one is a short-term memory. Okay. And then, what is important is, the examiner asks them, say for example, I name 3 items. One is an apple, one is a cat, and another is a biscuit. And then I ask you, can you name again all of these? You must be laughing at me. Oh my God. So what are the 3 things that I said? An apple, a dog, and a biscuit. Is it like that? Or have I made a mistake?
Mistake.
Oh, yes, very good. Thank you for pointing it out. I did a mistake deliberately. This is what you are exactly going to see from the patient. You are going to ask about 3 words, an apple, a cat, and a biscuit. Now see whether he repeats the 3 words. You must be laughing, sir. All of us will repeat. No, sir. This is again talking about some part of integration, particularly in the temporal cortex. Now the fourth of the question. So there are 3 objects that are named in the third question, or the question number 3. The fourth of the question is, you ask the patient to count from 1, 2, 3, 4, 5, 6, and then tell them to count from 10, 9, 8, 4, 0, 0. I again made a mistake. So that means you are going to have one direct round of example A, B, C, D, E. Oh, let us count from backward. X, Z, Y, T, R, 1, 2, etc. So that means you are liking to see the integration of the cortexes in that. Now, at this point, again repeat this question and then again ask the patient to recall the name of the three objects. Like it was, what are the three things that I said? Let me see how oriented you guys are. What are the three things that I told you? Hello? Oh my God, you have forgotten this point. Apple, carrot, biscuit. Okay, it was an apple, a carrot, a cat, and a biscuit. Good one. So these are the three objects which are recalled. Good one. Now, then the next question is, if you have said this one, take a picture of an apple or draw a picture of an apple, okay, or take a picture of something that looks like this one. This looks like a bulb and an apple, and something that looks like a leaf, which are related objects but are closely. So please remember that. So this is something in which the patient identifies that, okay, so these are the common shapes. So for example, this is a square, this is a rectangle, this is a circle. So this talks about this part. Now, then after this, talk about how is the cerebellum integrated with the rest of the brain. Utter the word no, if, and what. So no, if, and but. Okay, so you may have your regional dialect translation for this, but this is a very simple English word. No, if, and but. That means you are trying to integrate the cerebellum and the motor cortexes along with that. Then you tell the patient to do a motor job dependent upon the frontal and the parietal and integration with the cerebellum. You tell the patient, take a piece of paper, fold the paper, very simple test, and then place it on the ground in an inverted way. That's it. So please see the command. Take a paper, fold the paper and place it on the ground in an inverted way. Okay, good one, simple test. Okay. And then what you do is that you have a very simple instruction written. Write your name. Very simple instruction. The patient writes his name, Ramanuj. That's it. So tell the patient that means you are now sensing the occipital cortex, his vision, as well as his cerebral integration into that. The final two questions, and then remember that say me any sentence or any first line of a song that you like. Again, your regional dialect can come in. Say me your sentence. What did you eat for breakfast? I ate 2 bread or 1 chocolate for a breakfast. Okay, so say me a sentence. And if the sentence cannot be completed coherently, that means you are not going to give the patient a marks. And the final picture is a simple one. I am going to require to draw this picture. See this picture easily. I have drawn a pentagon, and on this picture, I have drawn another pentagon. It's a very simple picture. If you are not happy with this, I think you can draw this picture and tell the patient to draw this picture and see if there is an overlap. So let me go for these questions again. What is the date, time, place, person? What is the place? Name the 3 objects. Again, name the 3 objects. A, B, C, D is in one way and then come back reverse. What are the 3 objects that you named? Draw a simple picture. What is that item? Say that name, no, if, and but. Fold a paper and then place it on the ground. What is your name, or write your name? There is an instruction card. Tell me, what did you eat for breakfast? And finally, please draw this picture. So please remember that this test that you have done has a maximum score of about 50. Okay. So this test that it has been done has a maximum score of 50. There are, as I've said, this is a part of the big part of something called mini mental status examination. Okay, so some people have more objective.
Hello. Hello.
Yeah, got it.
Hello.
Hello.
Shilajit, am I audible?
Yes, sir.
Please make me the co-host.
Yes, sir. Done, sir.
Done. Thank you. Okay. Important now. So welcome back. So sorry, I got disconnected. So let us again talk about. Okay, now. So what is the exact point that I got disconnected? Hello.
Maximum score is
Right. The maximum score technically is 50. Okay, and then you can give the score dependent upon that. So again, as I have said, you can search the internet for something called mini mental score evaluation. There are multiple score sheets, but this is what we remember for MRCS examinations. Okay, and these are the things to remember for an examination. Now, to start with, then, as I have said, whenever remember that to start with, what is important after you have done the higher function examination, okay, then examiner will ask you what are the other things that you have looked into the central nervous or the neurological system. remember you are quickly required to see something called as the cranial nerves. And cranial nerves are very easily, more or less, things to remember, that these are some things that you remember up till this. Okay. Now the first part of this part is, well, how do you test for cranial nerve number 1? How do you test for cranial nerve number 1? Hello. How do you test for cranial nerve number 1? Come on. I got disconnected at this point. By? Array?
Sensation of smell.
Okay, so it is that means you are required to give the patient something of strong odor of 2 different types. So that means you are required to give 2 odors of different type. How do you test for cranial nerve number 2? Hello.
Acuity of vision.
Very good. That means for this one, what do you need, sir? In your examination room, what is the thing that you need? Sir, I need something at a Snellen's chart would be the best one. If not, there will be something of a letter that is written at least 6 feet away on the screen, and with the spectacle on, you can ask the patient, can you read that? Yes or no? And then after that, you are required to see the pupillary reflexes. Okay. How to test for 3, 4, and 6? Very good. Are movements of the eyeball or extraocular movements. How to test for 5? Okay. How to test for 5? Quickly. Long way to go. Sir, how to test for the 5 or the 5th cranial nerve? Sir, it is sensory. This is the ophthalmic division. Right. So this is the ophthalmic division. Remember that this is the maxillary division and this is the mandibular. Remember that we are testing the 5th of this. How to test for the 7th cranial nerve? 7th cranial nerve, remember, is facial, and you are required to ask the patient to either close the eyes and smile. How to test for the 8? For this, you require a tuning fork, which will be provided if the examiner is asking you. Now tell me how to look for 9th, 10th, and 11th cranial nerve. How to look for 9th? Hello, how to look for 9th? Quickly.
Taste in the posterior part of the tongue.
Ask the patient to, ask the patient to open the mouth and say the word ah. What is the movement of the structure that you are noticing? Movement of the palate on equally on both the sides. How to test for the 10th? 10th is for any change in the voice. Remember, both the recurrent and the external laryngeal nerve are responsible for the voice. Tell the patient to say a word with a different tone. I am not a good boy. So this is the change in the pitch that is responsible by the vagus nerve. How to test for the 11th one?
Sternocleidomastoid and trapezius.
Exactly. Sternocleidomastoid and trapezius. Good one. Particularly, I will go for the trapezius test. And how to test for the 12th is the movement of the tongue. Now, what is important is there are examiners, particularly who are interested in asking you these tests. You may feel that these are very childish, MBBS-like. Absolutely not, because not only in an MRCS but a DNB examination, in a head neck cancer, you are required to show to the examiner that I have seen these cranial nerve testing done. This is an extremely important point for head neck malignancies if you get one such, which is very common to be given in an examination. Okay, so I think that this is something that you are required to know for this part. Now, after you have completed this one, after the cranial nerve things are done, then you are required to come to the upper limb and the lower limb, and then in upper limb and lower limb, you are required to examine the dermatome and the myotome. Now, as I have said, we do not have that huge amount of time with us today, but I will just tell you how to remember about this part. Now, how do I remember about the dermatome stories? Say, for example, of the lower limb. Okay, then how do I remember the dermatome? I have a simple mnemonic to understand. Okay. What is the mnemonic? The first one in this is the lower limb means we are from L1, L2, L3, L4, L5, S1, S2, and S3. Now, what is the mnemonic? So the mnemonic is very simple. I stand on, or if you are standing now, what dermatome are you standing on? Come on, what dermatome are you standing on?
L5.
Okay, you may say, sir, L5 and S1. If you are sitting on a computer screen, what is the dermatome you are sitting on?
S2, S3.
Is S2, S3. Now, what I do is that if I was live in front of you guys, then I would have done something called as a dermatome dance. And then I would have like to impress upon you how good a dancer I am. So, how to do this dermatome dance? The first one is on the L1. Okay. What is T12? T12 is a suprapubic area. And then keep your hand at a hand's breadth below the level of the inguinal ligament. Okay. Which dermatome is this? Which dermatome is this? Which dermatome is this? Come on. Hand's breadth below the inguinal ligament is L1. Purely L1 is L1. Now, if this is the medial aspect of the leg and this is the lateral aspect of the leg, in the dermatome dance, I am now placing my hands on the outer part. Which dermatome is this? Outer part of the thigh?
L2.
L2. Place your hands on the inner side of the thigh. Which dermatome is this? L3.
L3.
Okay. Now, place your hand on again the inner aspect of the leg. Which dermatome is this? Which dermatome is this?
L5.
This is L4. Okay, please see the sequence. L1, L2, L3 to L4. So if this is L4, place your hands on the outer aspect of the leg. Which dermatome is this?
L5.
L5. Very good. If this is L5, now talk about the L5. Remember, what is the mnemonic that I told you? I told you, you stand on L5 S1. That means when you talk about the foot, remember that the lateral aspect of the foot, what is the dermatomes? If I draw the picture, there are 3 colors to be given. And remember that these are extremely important, particularly if you are having a soft tissue sarcoma in the limb, like something in the thigh or the pelvis or the abdomen. Examiners at a postgraduate examination are going to ask you about these dermatome examinations. If you say, oh my God, yes, it is an important thing for a postgraduate student to know this part extremely well. So please don't shrug away. This is important to remember about these 3. Okay, so now see about this one. The 3 fingers are supplied by which dermatome? Hello?
L5.
Exactly, sir. L5. The last digit is supplied by which dermatome? Is S1. Whereas the grade 2 is supplied by L4. Okay. So please remember the grade 2, I cannot draw good pictures, but this is L4. So L4, L5 and S1. Right. Now if it is L4, L5 and S1, okay, where is the S2 then? Where is the S2? Now, when you draw the patient back, so this is the crease of the buttock. Remember that S2 goes with a narrow strip to the best of my knowledge in this part. Okay, so this is all about the dermatome. Okay, but remember that if that is a dermatome, what is a myotome? What is a myotome? Hello? Oh, the S2 region probably is around this part, right? I forgot. Okay, what is a myotome? Hello?
Muscular distribution.
The muscular distribution. And particularly if you have a patient with a hip deformity, psoas abscess, retroperitoneal collections, retroperitoneal abscesses, which are known to have something in the retroperitoneum pathology, and you are expecting a nerve pathology. This is something that it is extremely important for you to remember as a surgeon in a postgraduate examination about a couple of things that I'm going to show in front of you very quickly. To start with, this is the hip joint, and this is the knee joint, and this is the ankle joint. As I've said, I draw very crude pictures. Okay, right. Now, doctor, tell me, hip extension. What is hip extension? You tell the patient to stand up. This is hip extension. Hip extension is done by which myotome? Is L4 and L5. Please remember that. Hip abduction, that means taking the leg out, is done by L5 and S1. So I remember exactly like that. Whereas if the hip is adducted, that means inside, it is L2 and L3. So I'll again repeat for you guys. What is the myotome for hip adduction that is keeping the leg inside? So I remember this by making it very simple. If you keep the leg inside, that means this is an easy job to do. You need less numbers. So that is L2, L3. If you require to keep the thigh back, that means stand up, that is an extension. So that is technically maybe an L4, L5. Whereas if you want to take the leg out, so that's a big job for the hip joint. So that is L5, S1. So this is the way I remember. Whereas on the other hand, talk about the knee. To extend the knee, you need L3, L4 for extension of the knee. To flex the knee, you need L5, S1. So these are things that you come to know by practice. And the more you do your practice, in particularly in patients when you get to see an OPD, this is important. Regarding ankle. Now, when you talk about ankle extension, that means a dorsiflexion. Dorsiflexion is L4, L5. Whereas ankle flexion, that means plantar flexion, is S1, S2. So this is what you are required to remember. Particularly remember for pathologies of the spine, pathologies of the abdomen, soft tissue sarcomas in the limb, and the MRCS examination and DNB examinations. This is mandatory for you to remember and remember. Quickly, tell me one thing. Knee jerk. Which dermatome is or myotome is responsible? Not dermatome. I should be talking it. Knee jerk. You know, everyone knows what it is. Very good. Is L3, L4. Congratulations. Ankle jerk. Tendo Achilles. Which one is this?
Which one is two?
L4 and 7.
Ankle jerk. Ankle jerk. Which one is responsible for producing a plantar flexion? S1 is 2.
S1 is
Right. So please do not forget this, because examiners are going to ask you this. In a thyroid patient, you are required to elicit an ankle jerk. Okay. On the other hand, tell me, as I have said, the thyroid, I am now interested in eliciting the biceps jerk. Okay. Which one is this? Which myotome? C5, C6. Triceps jerk is C7, C8. Okay. So please remember that this is what you are required to understand. I have made a detailed neurological examination with only one purpose. Inner examination, particularly for an MRCS and a DNB examination, this is what you will be thinking that, oh my God, then what is a DM neurology? No, you know more than that. Okay, maybe. But for a surgeon, if you are having a deja vu about your MBBS days, that's very nice. But still, please remember that this is what you are required to remember minimum. These are all things that you read in your MBBS days. So it is good to go with those books. Have a look, because in a postgraduate examination, if you are doing well, particularly dermatomes and myotomes are always our Achilles heel. Right. Now I have talked too long. It is about an hour. Talk about examination of the cardiovascular and the respiratory. Now these are things we as surgeons, remember, we are not, now I am not a cardiac surgeon. So until and unless you are a cardiac surgeon, I'm not going to ask you about the finer details of an auscultation, which area is what. So what is So, ladies and gentlemen, I was when did I get disconnected?
Beginning of CVS.
Beginning of CVS. Now, in CVS, as I have said, the major parts that we are interested to look as surgeons are characters of the pulse. That means rate, rhythm, character, particularly like say high volume collapsing pulses. If you could feel any rhythm abnormalities and volume. Remember that we are all surgeons. And if you pick up some abnormality, we are not going to analyze that abnormality in details, because as I will be calling a cardiologist, so will you be calling a cardiologist for the detailed management. But it is good for us to identify that there is a rhythm abnormality. That's it. I'm not going to talk about a complete heart block, etc. Those of you who will be going in for an MRCS examination, this is an area that needs to be strengthened, particularly for your viva, where you are asked about the characters of the pulse. You are given an ECG showing an atrial fibrillation, a ventricular fibri, and a complete heart block. So that is a part of your critical care classes in an essence of pulse examination. Now, when you go for auscultation of the heart, that is in auscultation, what is important is again the 4 areas of the heart, where to auscultate, what are the findings, and again, as I have said, I am not a cardiac surgeon, but it is expected that you are required to identify any murmurs, you are required to identify the 2 heart sounds, you are required to identify a systolic murmur versus a diastolic murmur. This is the minimum that you are required to identify, and rare or an occasional, sometimes in some centers occasional, some centers rare, you are likely to be given a patient of a mitral stenosis who or he or she had an open surgical procedure for a mitral stenosis. Now, in your cardiothoracic rotations or in your cardiac rotations, you must have seen those patients commonly. So the only finding that the examiner is wanting to ask is, what is the nature of the murmur and what is the quality of the sound? Murmur. So, or what are the events or what are the complications of a mitral stenosis? What are the events that led to mitral stenosis, etc. So these are all the points to talk about in CVS, remember, as a surgeon. As I have said, we are not a cardiology class or a medicine class. Now talking about respi. Now again, respiratory is something like CVS that you see every day in your wards. You put your stethoscope to the patient and look into or hear into what are the sounds. As I have said, you should be looking into the position of the trachea, extremely important for a thyroid case. And you are required to know what is the trail sign that help it, or sorry, the thyroid cartilage down. And then you come up to the sternal notch, where you put your finger, usually the index finger, on both the sides and look whether the index finger goes equally on both the sides or not. If the finger goes equally on both the sides, that means there is no tracheal displacement. Now, in thyroid, remember that there is a group of examiners who ask you particularly to rule about a retrosternal extension by doing something called as a percussion of the sternum. Now, let me ask you on this one. What is a normal percussion note of the sternum?
Dull.
Dull. If there is a retrosternal extension of a goiter, what is the node then?
Stony dull.
It becomes stony dull. Okay. See, I do not appreciate, my ears are not so sensitive. Okay, it is dull and it will remain dull. So that question that what is the change in the node is technically a dull question. So what is the way to understand a retrosternal extension? Sir, it is by inspection, it is by palpation, and if the patient gives a history about a sleep discomfort or in sleep apnea, and you ask the patient to do a Pemberton sign. Remember that Pemberton sign sometimes can be a very tricky test and the patient can end up with a hypoxia. So if the patient has an obvious history of a sleep apnea or a change in the voice, please do not do a Pemberton. There are other better ways in this century to know a retrosternal extension rather than choke the patient by doing a Pemberton. Okay? Now, what is important is that after you have seen the trachea, the examination of the respiratory system is again by the respiratory rate, the air entry into both the sides of the lung by inspection, palpation, but more important is as a surgeon, percussion, particularly for the amount of the liver and the trop space dullness, and finally auscultation. Now, this is a routine job for all of you, and the basic idea for an examination of respiratory system is what is the air entry in both the sides of the lung. Can you hear some adventitious sounds like crepitus or creps or rhonchi? And if there is a decreased air entry, is there any evidence of a pleural effusion? In this picture, sometimes people can diagnose a consolidation also clinically by the indrawing of the trachea to that side. But whatever you do in a cardio or a respiratory examination, if you do find that there is a pathology, so for example, the patient is a patient with a cancer breast, whereas the patient also has a bilateral pleural effusion. So please remember, talk about that clinically, this appears to be a metastatic disease, but to confirm the nature of the pleural pathology, I will always like to have a chest X-ray. So this is your way of saying that, sir, this is the confirmatory test. Okay, right. Now, finally, before I end, what about musculoskeletal? Now, as I have said, those of you who are with a good background in orthopedics, this becomes the routine examination every day. Now, for others who are in general surgery, remember that the basic thing across an orthopedics is, their basic idea is look, feel, move, I can add the word, measure. Now, whenever you get a pathology in the limb, particularly remember that in musculoskeletal cases, a sarcoma, a big lipoma, a nerve injury, when you are examining the musculoskeletal system, this is always important to talk about examination of the joint, which is proximal to the pathology, an examination of the joint that is distal to the pathology. So, for example, in this patient, the patient had a soft tissue tumor in this area. So, this is what you are required to remember in this group. Look, feel, move, and measure. You are required to know the screening test in the upper limb for the 3 nerves, as I have told, and that again comes under the dermatomyotome part. Talking about the spine, remember that for examination of the spine, you ask the patient to take off his or her shirt and sit on a chair. Now, you are required to go on the back and examine the level of the spine of the scapula on 2 sides. Now, in the same patient who may be standing up like this, remember that the patient can have a scoliosis in the spine, which can compensate for the 2 scapulas. So this is a way to look into the deformity of the spine, which gets unmasked by sitting. For doing and fixed flexion deformities, for example, of the hip, etc., we have special tests like thomocystis, so that depends upon the region. The basic idea is that it is always good to ask the patient, say for example, a patient with a breast malignancy, that whether there is any pain, and it is routine that you must palpate the spine, the tip of the spine, palpate the long bones, ask the gait of the patient, also to see what is the pathology that went wrong. So this is overall the systemic examination. Please ask me your questions now.
Sir, in Glasgow Coma scale, you said about E4 to C. What does to do with the C part?
C, because one eye was closed, sir. One eye was closed.
Okay, thank
Now,
you.
it was E4 means we could understand that it was E4 because the other eye was open and the patient had asked or had evaluated this part. Okay, right.
Sir, in Glasgow Coma scale motor response, is there any specific way for inflicting pain, sir?
I told you, pain is given, you are standing on the head end of the patient. Either you give a pain on the trapezius or you can get access to the hands, give a pain on the fingernails. Some people say that standing on the leg side, give a pain in the fingernails. Standing on the head side, give a pressure on the trapezius. Now, previously, we used to do that supraorbital pressure. In bad head injuries or scalp injuries, this becomes a difficult area. And so is exposing the sternum sometimes does become a difficult thing. So it is good to expose the trapezius, which is an easy thing to do and is easily accessible for giving pain.
Thank you, sir.
Okay, no other questions?
Maximum scoring of MMSC, sir?
See, to the best of my knowledge, sir, mini mental status examinations, there are multiple scores. You can look into the net for that. I know of a score of maximum 10 questions, 5 each, so 5 into 10 is equal to 50. Some people say no, there are abbreviated mini mental scores, that is 30. You give specific scoring 5, 4, 3, 2, 1 like these ones, that makes it 30. So to make it my points easy, I make it 10 questions into 5 is equal to 50. Okay, other ones please, other questions? Hello? Please remember dermatomes, myotomes, Glasgow Coma scale, cranial nerve examinations are things that you read in your MBBS medicine, maybe neurology. And then as surgeons, we always tend to forget that. Many of you may have given your books to your junior colleagues. But in an examination, particularly remember not only in a real life, patients with head injuries are commonly given as a part of your examination. In an MRCS, this is one among the most common cases, but there is an actor who is sitting in a room and has a history of a head injury 2 days ago and is now disoriented, and you are required to see this gentleman. Whereas on the other hand, getting a patient with a limb sarcoma or getting a patient with a deformity in a limb is very common in an MS or a DNB examination. And the examiner is always wanting to see, as a postgraduate, what are the residual nerve compression anomalies that you have seen in such patients. So please be knowledgeable about dermatomes and myotomes. Okay, right. So this, if there are no questions, thank you everyone. Okay, I hope you have taken down today's points and class, because in the next of the classes, the more we go into the depths of examination, I will require you to be more proficient with this kind of detailing. Okay, thank you. Thank you everyone.
Thank you, sir. Good evening, sir.
Good evening. Am I audible?
Yes, sir.
Okay, I'm going to start sharing my screen. Shurajit, I'm going to start at 8. I can see a number of you joining, but then the is going to come in at 9. I think I better start. Okay.
Yes, sir.
Right. So what we're going to discuss today is carcinoma of the gallbladder. And as we always, we keep on repeating every time, never mind what you're discussing, you have to have your clinics right. And once you have your clinics right, then and then only can you proceed on further. So without much ado, let me start off by presentation. Now, the presentation can be with jaundice, pain upper abdomen, fever, nausea and vomiting, bloating, and abdominal lump. The carcinoma gallbladder, when does a carcinoma gallbladder present with jaundice? Who's going to help me out? Sorry, I didn't get that. That's the liver. Let me draw the gallbladder out here. Sometimes what happens is you have the bile duct leading duct out here. Can be a direct infiltration directly causing a problem. It could also, don't forget, the other ways of causing jaundice is that you have lymph nodes traveling down. That's the stomach, that's the duodenum, and your bile duct is traveling all the way down out here. And unfortunately, the lymph nodes, the lymph nodal spread for the gallbladder is often pancreatic, and as a result of which you have pressure out here causing jaundice as well. Sometimes the infiltration is upwards and you have the confluence involved. So it could be a direct involvement, could be a result of the lymph nodes pressing on the bile duct. Right. So you could have pain upper abdomen. Now, what sort of pain do you have with a carcinoma of the gallbladder? You have a local infiltration because of the growth. You have a local infiltration, and then you have pain in the local area when the visceral peritoneum is involved. So you have a gallbladder involving, let's say, you have the visceral, that's the costal margin, and there's local infiltration out here that can cause pain. What are the other causes of pain? Again, with the spread of the lymph nodes, lymph nodal spread. Hang on, chaps. When you chaps join, I can't see my drawing. I'll just drawing board. Yeah, sure. So what happens is that you have the aorta, and the hepatic artery comes in, travels up along the bile duct, and you have lymph nodes spreading out here along this tract, and then you have the celiac group of lymph nodes involved, and as a result of which sometimes you can have pain traveling to the back, so pain can be that. Can have fever when you have a blocked bile duct, and cholangitis is one of the terrible conditions to have when you have a carcinoma of the gallbladder. Can have nausea and vomiting due to all the tumor necrosis factors that are elaborated in the blood. You have nausea and vomiting, but it can also be a direct invasion of the duodenum. So you have a gallbladder. If you think about it, you have the gallbladder. I think people are stopping joining, so I can go up there. That's the carcinoma of the gallbladder, and you have a direct invasion of the duodenum, which is traveling down out here. So you have a direct invasion of the duodenum, and then if you have an invasion of the duodenum, you have a gastric outlet obstruction, and you have sometimes you get non-bilious vomiting as a result of that. You also get bloating for the same reason, and of course an abdominal lump. Some people present with an abdominal lump. So number of ways that people can come in and present. Right.
So why there is bloating?
Bloating is because of involvement of the duodenum, the duodenal outflow. So whenever you eat, there's delayed emptying of the stomach. So that gives you a bloating sensation. Okay. Get it? Let's suppose you have, let's say, the duodenum out here. Let me draw it up for you. You have the stomach and the duodenum, and that is often involved by a carcinoma of the gallbladder, as a result of which what you do have is delayed gastric emptying. So you have delayed gastric emptying and bloating because the channel is very narrow. You can it travels down, trickles down, and when it absolutely blocks, then you get vomiting and non-bilious vomiting at that. Okay, right. And presentation can be with jaundice. And I'm going to ask you, where do you search for jaundice? Anyone? Jaundice? Where do you search for jaundice? Sclera? Yep. Upper bulbous sclera. You're supposed to use that term. Which part of the tongue?
Undersurface.
Why the undersurface of the tongue? Absolutely right. I'll grant you that. Why the undersurface? Why not the dorsum of the tongue? Why not the dorsum of the tongue? The dorsum of the tongue is full of something. Taste. It's full of papillae. It's very difficult to, two reasons. It's very difficult to get that to stain because it's completely working all the time. So it stains the undersurface. The other reason is one of the spices that Indian food always and always uses is turmeric. The moment you use turmeric, there's a staining of the top end of the tongue because of the use of turmeric. So you need to remember that, guys. Where else? Soft palate, okay, and palm, isn't it? What happens if you have obstructive jaundice? What other symptoms follow an obstructive jaundice? You get pruritus, don't you? Why do you get pruritus?
Excess bilirubin deposition in skin.
Yes, so you have a stimulation of the free nerve endings, isn't it? Free nerve endings get stimulated because you have bilirubin deposit out there. That normally goes through the spine. It enters the posterior spinothalamic tract. There are two parts. One is the normal part. The other is called the cow cage part. It goes in out there. And one of the things that is often asked, why is pruritus more at night? Can somebody tell me why is pruritus more at night? Pruritus is more at night. Why do you think pruritus is more at night? I mean, surely the bilirubin deposition is equal, be it daytime or nighttime. See, the moment you see this track, there's something out here that, have you heard of the gate theory? Sensory fibers are allowed in at, when you have a number of factors. Let's suppose you have a large street and cars traveling down out here, and there's a certain area of narrowing. So what happens? Isn't there a traffic jam all the way behind? Because the gate theory means that if you have multiple impulses coming in, the pruritic impulse travels in only a bit. At night, when your other symptoms are less, pruritic symptoms come in hugely, as a result of which pruritus is more at night. You also have a palpable mass in the upper right quadrant, and then when you have a mass in the upper right quadrant, you have the liver, you have an irregular liver, and there's a pyriform swelling, which is hard and it's continuous with the liver, and the rest of the liver is irregular and hard, and so is this irregular and hard. It, however, moves up and down with respiration, and you cannot distinguish between the liver and the pyriform, irregular pyriform mass, as opposed to a fact when you have stones blocking the stones, or let's say a carcinoma of the pancreas, blocking the lower end of the bile duct. Then what you have is, if that is blocked, you have bile duct large, and you have, sorry, that's wrong. You have the gallbladder hugely distended. So that's classic, the Courvoisier's law. It says that if you have a palpable gallbladder with obstructive jaundice, it is due to a pancreatic head mass or blockage lower down. If you have stones, it is presumed that if you have stones, what happens is that the gallbladder is shrunken, and sorry, that's not the correct color. So I'll take that color. The gallbladder is contracted, and you have stones out here inside the bile duct, a distended bile duct with stones. You also have stones inside the gallbladder, and you have stones out here. So that is the principle of the Courvoisier's law. Right. You sometimes have periumbilical, it's not lymphadenopathy, it's a mass, sorry, I'm wrong out there, nodules, periumbilical nodules. So what are these nodules called? Sister Mary. You know who Sister Mary was? Difficult question. Sorry to ask you.
American nurse.
Absolutely right. She was a nurse to another very famous man. She was William Mayo's nurse. Okay? And it's only 10 years after that that Hamilton Bailey, who worked with Mayo, thought of obliging Sister Mary by naming that nodule after it. It's called Sister Mary Joseph's nodule. Isn't it? Mary Joseph's nodule. Good. Well done. She was, as you quite rightly said, an American nurse. Good. Irregular hard hepatomegaly. Now I'm going to ask you about the left supraclavicular adenopathy. What is this left supraclavicular adenopathy? What is this one called?
Virchow's.
Very good. Virchow's lymph node. So the usual question is, which station node is this? Which node?
CS stomach.
No, if you have it's normally found in CS stomach. You can get it in carcinoma of the gallbladder as well. But if you have a left supraclavicular, traditionally we call it the left supraclavicular lymph node. But is it truly this left supraclavicular lymph node? Where do you feel for the left supraclavicular? It's between the two heads of the sternocleidomastoid, isn't it? Right? In between the two heads. So classically, supraclavicular lymph node, station 5, lies behind the posterior border of the sternocleidomastoid. So this is actually station 4. Okay? Lower deep cervical lymph node. Remember that Virchow's is actually the lower deep cervical lymph node. That's the station 4 lymph node. Now, some of the other questions that are asked. Why the left supraclavicular lymph node? Why the left? Why the Virchow's node? How does it spread to the Virchow's node from inside the abdomen? Anyone? From the abdomen around the celiac crown, it drains into a longitudinal lymphatic channel. What is that called? It lies slightly not to the thoracic, cisterna chyli, isn't it? Cisterna chyli inside the abdomen. Cisterna chyli. And from there, you're absolutely right. It travels up on the through the chest, lying to the right side of the vertebra, and it crosses over at T4. Some people say T5, but accepted as T4 junction, and it goes up and drains where? Thoracic duct. It drains into the junction of two very big veins. It drains into the junction of two deep veins, which is the innominate and left subclavian. Right. So it drains in out here. So that is how it drains in. when there's a blockage out here, there's a retrograde flow, as a result of which you have the lymph node out here, virtuous lymph node. It's a retrograde spread. Following on this, there's another retrograde spread, particularly found in carcinoma of the stomach. It's being described in the carcinoma of the stomach. And can anybody tell me what is that name of that lymph node that is found? You find the virtuous lymph node, and you often find another lymph node lying just below the pectoral major, pectoralis major. There's a lymph node found. It's the anterior axillary lymph node. Found usually, absolutely right. There we are. You know it all. Irish nodes. Very good. Excellent. So you have an Irish node. Okay. Now that we are on this, some of the other questions that are asked is the virtuous lymph node. It's a cancerous lymph node. What does it lie on? What lies behind this? As a result of which, there's some neurodeficit that can happen. What is a neurodeficit that can happen because of the virtuous lymph node? Corner? Or not corner. There's another nerve, C234. It travels behind it. It's the left phrenic. Okay? So you sometimes have hemipulse of the diaphragm. Okay? Hemipulse of the diaphragm. There's the other thing that travels behind and sometimes causes bleeding is the transverse cervical, and it lies on the scalenus anterior. Okay? Scalenus anterior muscle. So lymph node, you have the transverse cervical, and you have the left phrenic, and then you have the scalenus anterior. Okay? Right. So sometimes it is asked that if you have a left supraclavicular adenopathy, what node station is it? It is truly the node station 4. It is the lower deep cervical lymph node caused by retrograde spread because of blockage of the thoracic duct, spreads into the lymph node out there. It normally lies on the left phrenic nerve and the transverse cervical artery, and behind that is the scalenus anterior. So if it is involved, then you'll sometimes get a left hemiparesis of the diaphragm. Right. Okay. Right. So you also can get ascites. Ascites, how do you find out whether there's ascites? Let's suppose you have an abdomen which is distended all the way. You find that the abdomen is distended. Sometimes the umbilicus is protruded out. First and most important thing, get the patient to pass urine. Okay? People will wait for you to say that, please, please, please. You know, we are going to go very deep into this topic. But, people from you chaps are never going to get caught out. You chaps are never going to get caught out because you will pass this with flying colors. You will ask the patient to pass urine. You know, very stupid things, but for heaven's sake, don't get that wrong. Then you percuss from the top all the way down, come back to the point of maximum resonance, then you percuss on the side, and you mark the side where it becomes completely dull. You mark the side where it becomes completely dull. Then you turn the patient to any one side, and now you percuss on the side, and it becomes resonant. And then you percuss all the way down, and now you mark the side where it becomes dull again. So remember, because some of your examiners will insist on that. Why? Because it's a sign of shifting dullness. Okay? It is not the sign of shifting resonance. So you have to prove that that which was dull is now resonant, and what was dull only up till here is now dull all the way out here. So that's a sign of shifting dullness. Guys, this is very stupid. First year stuff. I know I'm probably boring you all, but please do not get this wrong in an examination. Okay, pelvic seeding, it happens much more in signet cell cancers of the stomach. The mass is palpated on this distal rectal examination as a hard shelf. And what is the sign called? Okay, glomus shelf. So you feel a hard shelf. Just remember that some people, internet is 50-50. Some call it P, glomus shelf, but I would actually go with glomus. It's also called Schnitzels, SCHNITZEL, Schnitzels sign. Okay, remember all these signs. Some examiners are very unfortunately hooked onto that. For me, if you palpate a mass, it's perfectly all right. Gloma, that's even better. But just remember that this is sometimes that happens. Right. So what are the tests that you do? You do a blood test, you do an ultrasound scan, you do a chest x-ray. In the blood test, what do you find? You find jaundice. What sort of jaundice do you find? What jaundice? You find high, you find conjugated. It's also called, it has another name. Conjugated bilirubin is also got another name. It's called direct, isn't it? Now, what a question. Why is it called direct? Why is it called direct? Anyone? Come on, let's see. Direct. It's called direct bilirubin. Why is it called direct bilirubin? See, when you take serum, first of all, that's a serum. And you have half of it is, let's suppose, conjugated. For purpose, the other one is unconjugated. If it's unconjugated, it is not water soluble. So if you test it with the Vandenberg reaction, you actually use a diazo compound to find out whether the color changes. So if you put in diazo out here, what response is the conjugated? So how do we get the total bilirubin? Then you put in alcohol to dissolve both the conjugated and the unconjugated to get the total bilirubin, from which you subtract the direct bilirubin to get the indirect bilirubin. Okay? So that is why conjugated bilirubin is called direct, unconjugated bilirubin is called indirect. Okay? So I should remember that. Again, basic things that you have to get right. Right. So that's a blood test. We found that this is conjugated bilirubin is high. You're absolutely right. Find out what the albumin is, because that's also important, to hemoglobin, because you're going to subsequently work. You're going to see the urea and creatinine, because you want to make sure that the kidney isn't damaged because of the high bilirubin. Right. We then ask for an ultrasound scan, and in an ultrasound scan, the classic feature is that you have a thick-walled gallbladder, which is thickened asymmetrically. That wall is thick. That wall is thick, but less so. The moment you have something like that, you're worried. Asymmetric thickening of the gallbladder. Sometimes the interface between the liver and the gallbladder is completely lost. So you should have an interface out there. If that is lost, then you've got a major problem on your hand, guys. You've got a major problem if that's the sort of feature that you have. So it's a good test because it sometimes identifies ascites, if you have ascites. That's the end of the story, for the end of the road for your patient. Unfortunately, you might have multiple metastases in the liver, which is again a reason to be sad. You do a chest X-ray just to make sure there aren't any metastases to the lung. And then you do a CT abdomen. You do a triphasic CT scan. The rationale for doing a triphasic CT scan is you're going to search for signs of inoperability. You can supplement that with an MRI or an MRCP, and some people would prefer doing an endoscopic ultrasound scan, particularly if you have retroperitoneal lymph nodes. Sometimes they prefer getting an FNA from that. If it is blocked, if you have jaundice, and in particular if you have cholangitis, then these are the two things that you would think about. You do an ERCP and a PTC that are blocked up. If you can't put it in from down below, you will have to do a PTC and do a drainage from the top. So the rationale being that if you have a duodenum which is blocked, the duodenum is completely blocked out here because of the cancer, you can't access it with the endoscope. So you can't do an ERCP really, in which case you would rather prefer going in from the top and doing a PTC. And then sometimes your radiology colleague will be kind enough to internalize the drain of the stent for you so that the patient doesn't have pipe sticking out draining pipe. Right. So we come to our next.
So,
yeah.
Why there is need of triphasic CT?
Sorry, I'll tell you. Why the need for a triphasic CT? Is that your question? Okay.
Yes.
You just wait for not the first CT scan. You have to wait for the second set of CT scans. Okay, it's coming up right now. Okay, and I'll tell you why. Right. Now this is the first CT scan on the left and an MRI on the right. So tell me what you see. If I were to so this is a CT scan. This is a CT scan through the upper triaxial scan through the upper abdomen. It's a contrast because I can see contrast in the aorta. I can see contrast in the kidney. So it's a bit of a delay, and I can see contrast in the IVC. Now, a few questions. What is this structure? Liver, absolutely right. What is this structure? Spleen, lower pole of the spleen. Now, when you come and see gallbladder, you see that the serosal aspect is not very thick. But look at this liver aspect. Can you see that area? Okay, can you see that? That there's a loss of interface between the gallbladder and the liver out there. Okay, you can see that. There aren't any lymph nodes, but there's something else that I noticed, and I always was worried. If you look at the IVC, it sort of looks separated. That part is brighter than this part, isn't it? What do you think is going on? Can you see that? One part is brighter than the other one. Why do you think that one part is brighter than the other one?
Thrombus?
No, it's not. Actually, I thought you're quite right. I also thought that was a thrombus. Then one of my radiology colleagues, actually Dr. Avik Bhattacharya, discussed me. When you have a tubular structure and the veins are draining, you see what happens is that is the color of this coming from the right common iliac, and what comes from the left common iliac is slightly different. So we have a turbulence. It's separate in color. So that sometimes you have it all the other way around. You have that brighter than this. So you see that is where the two flows don't mix. There's a bit of a it takes a bit of time. It sometimes goes up to the heart to mix. So you sometimes, if you see one of the confluences of a river, you find one river which is green, the other is brown, and for a fair bit of time they don't match. So that is the phenomenon called turbulence and differential flow. So don't think that's a thrombus. I was very prompt at thinking there was a thrombus when I was earlier on, but it's not. Okay, right. So that's a CT scan. That's an MR. Now I need one of you guys to tell me, is this T1 or T2? T1 or T2? Why is that T1? How do you know? Absolutely right. You're right. But why?
Water is white in T2.
Sorry?
Water is white in T2.
Yeah, absolutely. So always look, absolutely right. Somebody was saying, look at the spinal column. If that is white, then that is T2. I mean, that's the surgeon's cheat code. Okay? If the CSF is white, then it's a T2. Absolutely right. So right now you have here an irregular thickening of the gallbladder with a loss of interface between the liver and the gallbladder. So, and it is better defined in this T1 picture. You can see that that is a tumor growing out. Can you see that? I'll wipe that off. Okay. So can you see that that's a tumor that is going in? So what are you going to do for this patient? There are no lymph nodes out here, no signs of spread. So what are you going to do? What are you going to do for this patient? We've staged the disease. On radiology, it looks like a carcinoma. We staged the disease. We've done a CCT of the whole abdomen, and this is the CCT. You can't see any para-aortic lymph nodes out here. So, seems operable. So what do you do?
Radical cholecystectomy.
Very good. You do a radical cholecystectomy. Excellent. Do not, under any circumstance whatsoever, put in a needle out here. There's no scope of doing an FNAC and an operable carcinoma of the gallbladder. So you're going for a radical cholecystectomy. Very good. At best, I mean, you have to counsel the patient, however, that we are going in, we think radiology cases 95 to 97% right, proof that you have a mitotic lesion of the gallbladder. There is a possibility 2% or 3% that it might actually be something else. What's the other thing that mimics a carcinoma of the gallbladder? What is this?
Xanthogranulomatous.
Yeah, okay. Xanthogranulomatous cholecystitis. If a xanthogranulomatous cholecystitis happens, sometimes it is far more uniform in its swelling. So you would have a thickening all around. You would have on this phase, you will notice that if you look very carefully, you see the mucosa out here. And I'm just drawing it out for you. You see the mucosa out here, going through out here, but there's a distinct gap, and then it starts again out here. You don't have that in a xanthogranulomatous cholecystitis. And also because it happens because of cholesterol deposits. Cholesterol deposits are sometimes present as little dots inside the wall. So you get that in a xanthogranulomatous cholecystitis. So guys, just remember that these are, some of the basic things that you need to think about. So you're absolutely right, 100% looks operable. So you will go ahead and do a radical cholecystectomy after counseling the patient. Very good, excellent. Right, now I'm going to give you, somebody asked me why a triphasic. Now you will see why a triphasic. Okay, this is imaging 1 of 2. So same patient. So somebody tell me, what is this? This is a CT scan. Always remember, you start off by saying that this is a CT scan, an axial slice of the upper abdomen. And I can see the liver, the spleen, buy yourself time during an examination. I can see the right kidney. I can't see the left kidney, so it's sufficiently higher. So I can see the spleen. So I can't see usually the left kidney is higher than the right kidney, but I think there's a bit of a splenomegaly as a result of which I can't see the left kidney. All right. I can see a hypo, I can see that the gallbladder, this is the gallbladder lumen. This is the gallbladder lumen. And there seems to be a mass which is extending all the way up out here, completely out here. What is this structure? What is this structure? And what is this structure? That's the aorta. This is the IVC. So you can now see that that mass is actually coming in, actually extending in between. Can you see that it's extending in between the aorta and the IVC? Okay. Now, somebody asked, why a triphasic? The moment you have a triphasic, what you now have is, you can see that that is the aorta, isn't it? There's one vessel which is coming up. What is that vessel?
Celiac trunk.
Likely to be celiac trunk, except that I would have been happier if I'd seen a far more stronger. This is the cross of the diaphragm. Can you see that the cross of the diaphragm is here? Can you see that? That's the cross of the diaphragm. So I would grant you that that is the celiac trunk. So if you see the next plate, that will tell you why we need a triphasic. Right. Same patient. So now you can see better that you can actually see the lumen of the gallbladder there. You can see that there's a huge thickening which is extending all the way into the liver, extending into the portal area. Now this is the criteria. I'm going to trace. Now you can see that that is the cross of the diaphragm. And you can see that that is the aorta. That's the celiac trunk. Celiac trunk has how many branches? It has the left gastric, the splenic, and the hepatic. Now that is the hepatic. Can you see the hepatic? And can you see that that is completely encompassed? That hepatic is completely encompassed on all sides by tumor tissue. Okay? Now do you realize why a triphasic? Because the moment you have the hepatic completely, encompassed, it becomes completely inoperable. This is an inoperable carcinoma of the gallbladder. Not only that, have a look out here, guys. I'm going to let me choose some color which is slightly different. Let me choose pink. This is the cross of the diaphragm. This is not the cross of the diaphragm. This is likely to be the venous outflow from the kidneys. Okay, and you can see that there is some infiltration in between. That has to be the venous outflow. That's the IVC, and you have infiltration in between the aortocaval space. Is completely involved by tumor tissue. So this is basically something that you have to accept. It's inoperable to start off with. And here, if you want to palliate, some people would prefer doing an FNA from here. Okay, so that is the rationale for doing an FNA. Okay, guys, I'm going to go to the next one. Now, the next one is you're going to get 3 slices. Right. So somebody take it away from me. Let me show you all the 3. So first set is this. Second set is this. Third set is this. Okay, so we go back to the first. Right. This is also a CT scan through the upper, showing the axial view. And just let's make sure. I hope I don't want to transgress onto Mauritius time. So that's the liver. What is this? Spleen. Okay. That's the kidney. We know that is the kidney. Now, you can see that that is the lumen of the gallbladder. and there's infiltration, some sort of soft tissue that is growing out here. So now you tell me something. I need you to tell me two things. One is, what is this structure? This structure. What is this structure? Very good, excellent. So it's a duodenum which is being narrowed. Okay. Now bloating. Now you understand why vomiting and sometimes non-bilious vomiting. Okay, because the duodenum is narrowed. Can you see that the duodenum is narrowed completely? Right. Now I have another structure which I want you to see and tell me. That's the duodenum. Medial to it is the head of the pancreas. And what is this structure then? So if we go to the next plate, I have this. Okay, same plate. Okay. So what is this structure? That's the duodenum. Sorry?
Pancreatic duct.
No.
Common bile duct.
Common bile duct, absolutely. So that's a common bile duct which is distended. So this patient has nausea, vomiting, and jaundice. Okay? Because that is the common bile duct which is distended. Why is this common bile duct? I can see the tumor out here. That's a tumor. That's a gallbladder tumor. That's a gallbladder tumor which is pressing on the duodenum. Okay, fair enough. That's a gallbladder tumor pressing on the duodenum. So why should this be distended? Okay, so that is the duodenum. We are clear about this being the duodenum. Okay, that's the duodenum. Everybody agreed? Okay. What is this structure? Yes. What is this structure? Sorry.
Aorta.
Is this structure? So if this is the pancreas, if this is the head of the pancreas, and that is the IVC, tell me, what are these structures which show features of necrosis inside?
Chain of plate pattern.
Sorry? That is the bile duct. Okay? That's your cancer. What happens if you have cancer? It spreads down to lymph nodes, isn't it? These are the retropancreatic lymph nodes. Can you see that these are the retropancreatic lymph nodes? I'm going to wipe them out so you can see that. You can see it better in the next plate. So these are the retropancreatic lymph nodes. Remember what I told you. Jaundice happens either by direct infiltration, that can also be because of the infiltration of the common bile duct by infiltration of the common bile duct by lymph nodal spread. Shilajit, hello, Shilajit, are you here? I don't know whether Shilajit is out here. We can tell Tapush to come in slightly late, I think. Just about give me 10 minutes. Anyway, I'm sure he's going to be here someday. So if I go to the next plate, it will become a bit more obvious. Right. Now you can see, have a look out here. You already know that we've seen the spread of tumor out here. That's the duodenum which is being pressed on. That is also lying inside the head of the pancreas. That could be the common bile duct, but you can see that standing in front of the IVC, that's the IVC, is a necrotic lymph node. Okay? And just above that is what is this structure? What is this structure? Sorry? That is the portal vein. Sphenic vein. Bring it out. Very good. See, I mean, guys, you're going to be surgeons. You have to learn to read your CT scans yourself. Don't completely depend on your radiologist. Sit with your radiologist. I've learned only by sitting with them. Okay? Right. Right, guys. Okay. So what are the risk factors? Gallstone disease. The highest incidences in middle-aged multiparous ladies from the Gangetic plains having a single large calculus. And this was a trial by Tata Memorial Hospital, and that is one of the biggest trials that they did. You have primary sclerosing cholangitis. You have a sessile polyp with a gallbladder wall thickening, which is more than 4 millimeters. Sessile polyp, remember, with gallbladder wall thickening more than 4 millimeters, or a porcelain gallbladder. Sometimes you have malignant polyps. You have a malignant adenocarcinoma, can be a squamous cell carcinoma, can be a mucinous cyst adenoma, or an adenoacanthoma. The incidence of malignancy is about 120 per 1 lakh person years for polyps larger than 1 centimeter, and 1.3 for 1 lakh person years for polyps smaller than 6 millimeters. Of course, you have non-malignant polyps, which is why I had given them. Please, these are not pre-malignant conditions. These are entirely benign. You can have cholesterol polyps and cholesterosis. You can have inflammatory polyps. You can have adenomyomatosis, can be diffuse or even segmental. When you have segmental adenomyomatosis, that creates a bit of a problem because one of the walls is thick and the other isn't, and you often have adenomas. Okay, right. The difference being, that's not the color I want green. If you have cholesterol deposits, that's cholesterosis. In an adenomyomatosis, you would have Rokitansky ash of sinuses. So you have little sinuses that are going in like that, various sizes, Rokitansky ash of sinuses. So the wall is thick. And the problem is, if you have an irregular thickening, then you're in a bit of a soup. You don't know whether you're dealing with an early cancer or not. Okay? So that is the difference. That's the problem of an adenomyomatosis, which is why some people if you have a segmental adenomyomatosis, they would plan to take that gallbladder out. Right. The other is chronic salmonella infection, which you have a chronic person who is a chronic carrier of salmonella. Helicobacter bilis, like a cousin of Helicobacter pylori. If you have an abnormal pancreaticobiliary ductal junction in which you have, let's suppose, a more than 1 centimeter long area where they have a common channel. So you have the bile duct out here draining, and you have a pancreatic duct out there, and there's a fairly longish channel which is common. If that is 1 centimeter or longer or more than 1 centimeter, then you have pancreatic juice refluxing up there. And because gallbladder is an area where, while it stays for quite some time, it faces pancreatic juice, and you have apparently a higher than normal incidence of gallbladder cancer. As a matter of fact, there have been papers where, if you have this particular lesion, people would do a prophylactic cholecystectomy. Medications like methyl dopa, oral contraceptive, isoniazid, carcinogens like smoking or any other nicotine in any form, aflatoxins, radons in minors, cellulose acetate fiber manufacturing. Fortunately, with the advent of PowerPoint, we've done away with them. Do you know what cellulose acetate was used for, guys? You had the transparent, projecting plates. Yes, that's right. So cellulose acetate chains, very good. Obesity and elevated blood sugar. Okay, all these are risk factors. Right. Now I'm going to show you an imaging. This is an imaging. I'm sorry for the picture. It's a horribly old picture. It dates back to the time when I was actually a student. So what do you think that is being shown? I'm sorry about that as well. Porcelain gallbladder, absolutely right. Very good, excellent. So remember that this is supposed to be a pre-malignant condition, except with one exception, that there are two variants that are I don't need that. I need green. I need a thicker. So if that's the gallbladder, there are two variants that can happen. In one, you have porcelain sort of sensation all the way around. So it's called diffuse, and diffuse is apparently non-malignant, whereas if you have segmented forms like that, and you can see that that is segmented, that is there, that is in, this is called stippled. If you have a stippled thing, that is the one that is more prone to cancer rather than a diffuse change. But for all intents and purposes, please don't go into this. If you're asked at an exam, porcelain gallbladder is pre-malignant condition. That is a bit of info from MCH stuff. Right, the histological types are adenocarcinoma 76%, papillary 6, mucinous 5, adenosquamous 4, squamous 2, oat cell 0.5, and unspecified 8. And that's from a huge series of over 3,000 patients collected. So what is the staging? TIS is carcinoma in situ, T1A, where the tumor invades the lamina propria, invades the lamina propria. 1B, where it involves the muscular layer. T2A, T2 is perimuscular connective tissue, where it comes in out here without involvement of the serosa is 2A, without involvement of the liver is 2B. 3, penetrates surrounding connective tissue. If it's here, it spreads into the liver. If it's here, into the surrounding structures. Maximum of 2 structures. So it could be the duodenum and the colon, for example. But if it involves more than that, numbers of, or more than that, more than 2 extrahepatic organs or structures, it becomes a T4, or if it invades the main portal vein or the hepatic artery, it becomes T4. N0 is no nodes, N1 is 1 to 3 nodes, N2 is 4 or more nodes. So that's your staging of gallbladder cancer. And of course, M0 is no spread, M1 is metastases. So lymphatic drainage of the gallbladder, and I'm going to talk a bit about morbid anatomy, cholecysto retropancreatic pathway. There are basically 2 structures. You have a spiral pathway which moves around slightly to the right and then goes down all the way, and it ends in the retroportal lymph nodes. You've seen the retroportal lymph nodes and what a problem it creates with jaundice on the third set of pictures. It would also be a streak to the posterior surface of the CVD. So remember, that's called the cholecysto-retropancreatic pathway, number 1. Number 2, it's called the cholecysto-celiac pathway, where you have, this was a route that runs down into the celiac, running to the left through the hepatoduodenal ligament to reach the celiac lymph nodes. And also you have the cholecysto-mesenteric pathway. This was a route running to the left in front of the portal vein, connecting to the superior mesenteric route. Now, this is morbid anatomy during dissection. There was a brilliant study, but the number of patients were very small, only 20 patients. So they put in carbon particles and they did a dissection. So what they did find was the active drainage, 95% drained into this, the retropancreaticoduodenal lymph node or the retroportal lymph node, and reached the para-aortic nodes. That was stained in 95%, in 50% towards the medial to the hepatoduodenal ligament and through the posterior aspect of the head of the pancreas. And as a matter of fact, the posterior common hepatic node was stained in 45%. And the hilar route ran up to the hepatic hilus, was stained in 20%. So this is active drainage. So basically, I think I'm just about in time radical cholecystectomy. It's established that radical cholecystectomy means removal of the gallbladder en bloc with hepatic dissection and removal of the lymph nodes confers the maximal survival benefit. But the number of lymph nodes resected contributes maximally to survival and decreases cancer-related mortality. It's the strongest prognostic factor contributing to long-term survival. So basically, remember that that area doesn't have a serosa. So what you would do is remove either either have two options, either do a wedge resection of segment 5 from here, wedge resection of segment 5, 4, and 4B. So you remove the gallbladder plate. Or you could do a complete anatomic dissection where you take the actual segment 5 and you take the 4A as well. Oops. In addition to that, you would actually come down out here if the tumor extends to the cystic duct, then you have to take the bile duct out as well. You will take normally what we do is we do a complete dissection of all the nodes along this common bile duct, along the portal vein and along the hepatic artery. That's the common hepatic artery. So you do the dissection all the way up here, and the modern tendency is to go right up to the celiac node to take that. So in America, one of the largest trials, they found that most people took 3 nodes. That's horribly less. You actually need to take more nodes out than that. So this was a study, and remember that the first echelon nodes are located along the cystic duct and the bile duct. The second echelon nodes are the nodes out here that you can see. This is a post, when you've done a cauterization. So located posterior superior to the head of the pancreas and around the portal vein and artery. The hilar nodes are considered here as these are usually harvested during a radical cholecystectomy. All the other nodes, including these ones, are considered as distal nodes. For your intents and purposes, that is what is it. You can see that in this patient of mine, we've done a wedge resection of segment 4B. That is 4B, and that is 5. Because this patient unfortunately had a tumor at the cystic duct end, so we've taken the bile duct out, and you can see the hepatic artery, and it's where it diverges. This is the right hepatic, that's the left hepatic, and you can see that we can see the portal vein out here. So that has been stripped completely dry, and you can see that we've taken all the lymph nodes out from here. So that's a complete dissection. So you need to ensure that your dissection is complete for your operation. Right. So remember that some controversies, the number of lymph nodes that has to be taken out isn't really well defined. The problem is that out here, these are the second echelon nodes. As of now, you take the first and the second echelon nodes when you're doing a radical cholecystectomy. We are working on an additional factor which you guys want to know, because it's slightly MCH stuff. Shall we talk about it, guys? Yes. So long as you promise not to come out with it during the examination. So, okay. So this is there's a rich plexus of lymph nodes that's the lymphatic drainage of the gallbladder. You can see that there's an enormous amount of multiple collaterals and joining, nodes spread all the way around. The reason for that is very simple. You see, that part lies in case when you're looking at the free margin of the lesser omentum, it lies between two layers of peritoneum, so it cannot spread out here. But the moment you come into this area is retroperitoneal. That area is completely retroperitoneal. So think about that. It is, out here it doesn't spread. It cannot spread. You have an epiploic foramen out here and it cannot spread out here. It cannot go in out here. But the moment you're dissecting out here, when you lift this up, you're actually dissecting. Think about it, that you're dissecting when you're doing a cauterization, you're dissecting along this area, which is just on top of the IVC. So there's no blockage to spread of tumor. So you cannot have a classic node stations like you have in a stomach, for example. So you have node spreading, you see it spreading all the way out here. And surprisingly, it actually goes into the para-aortic, the aortocaval lymph node. So, and along the uncinate process as well. So basically, very soon, you might realize that we are also doing a para-aortic lymph node dissection as part of the operation for a carcinoma gallbladder. But, Giant, this is just a rationale, it is just though the thing was initially described in 1990. We're still thinking about it. We haven't come across it. But, if somebody is interested, there we are. Right, guys. Any questions? I think we've just about finished in time for Tapush. Tapush, have you joined? Hello, Tapush, have you joined? Chatterjee hasn't joined. So, any questions? Any questions, guys? Right, if you don't have any questions, let me just find out when Tapush is joining. You have the second part of the CNS tumors today, haven't you?
Yes, sir. Can you show the slide of the treatment part?
Okay. I'll try. What you need to remember, there's a hell of a lot out here which I haven't shown you actually. This was one of my presentations at the, sorry. See, that is what you need to remember. That is the accepted modality. The first echelon lymph nodes are located along the cystic duct or CVD. I think Tapush has just come in. Tapush, have you joined? Hello? Tapush?
Yes, sir, just joined.
Tapush, I'm just holding the fort for you. So you're all yours. Just one thing I just need to tell them. The first echelon nodes are located around the cystic duct of CVD. The second echelon nodes are located posterior superior to the head of the pancreas around the portal vein pharynx artery. Hilar nodes are usually considered here. These are usually harvested during cholecystectomy. For your intents and purposes, we remove the first echelon nodes and the second echelon nodes. Okay? Right, guys? Tapush, all yours.
Thank you. Thank you very much. Thank you, sir.
Shilajit, you need to enable Tapush to share, I think.
Sir, I have enabled, sir.
Okay.
Hello.
Yes, sir.
I'm just starting in 2 minutes, all right? Just 2 minutes. 2 minutes.
Okay, sir.
Okay, guys, so if you have any other questions, you can post them and I'll take your leave. So stay safe.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you. And stay safe, all of you, please.
You too, sir.
Good evening.
Good evening, sir.
So you had a long class with Dr. Sanjay Debokshi, and we'll just go quite swiftly over some idea about spinal tumors, okay? I don't know whether it's of much significance in DNB, but we'll go about last week we discussed about brain tumors, and today we'll discuss in a gist about the various spinal tumors that we encounter in normal practice and how they present, the clinical presentations and the investigations we do, and obviously the modalities of treatment and the prognosis. As you know that the spinal cord consists of a central canal surrounded by an E-shaped gray matter region containing neurons, and the outer myelinated nerve tracts termed white matter surround the central gray matter. Central canal is lined with ependymal cells and astrocytes. So there is ependymal cells which can lead to ependymomas. Astrocytes support gray matter as a tool in the brain tumors. They are the substance in which neurons are engulfed, and they are insulating substances called the astrocytes, the glial tissue, which can lead to formations of various forms of astrocytomas. Like in the brain, we can get gliomas in the spinal cord, we can get ependymomas, we can get meningiomas, we can get all the tumors that we get in the brain. The incidence is 15% of primary CNS tumors. That is, obviously, it's less common than brain tumors. And primary, as I told, because metastasis is the commonest tumor of the spinal cord. Metastasis is the commonest tumor, but amongst the primary tumors, tumors which originate in the spinal cord itself, the incidence is 15% of primary CNS tumors. Right. Types of spinal tumors. It can be of three types really. It can be extradural, that is, the dura covers the spinal tumor. You know, this is the dura, and this is the spinal cord proper. So if there's a tumor outside the dura, this is extradural. And if there's a tumor which is intradural, and there's a tumor which is intramedullary. 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 So it can be outside the dura, which covers the spinal cord. That's called extradural tumors, as we find extradural tumors or exohematomas. And inside the spinal cord, there are two parts. One is the centralmost part, which is called the medulla, where actually the H-shaped neurons are there, and the outer part where the tracts go up and down, the various tracts, the cortical spinal tract and the spinothalamic tract and the posterior columns. That is called the extramedullary region. The tumors can be in three places: extradural and intradural extramedullary, which is 40% of the tumors, and intradural medullary tumor, that is within, it's in the very center of the spinal cord. Those are known as intradural tumors, which is about 5%. The prognosis in most cases is quite bad. Spinal tumors don't do well. And in majority, they are of the malignant variety. We'll discuss it further later. Now, etiology, as I told earlier, whether we discuss about brain tumors or whether it is spinal tumors, etiology in most instances is unknown. We have little idea about what are the reasons for the causation of these tumors, and the etiology is unknown. Genetic predisposition like astrocytomas and ependymomas are more common in patients with neurofibromatous type 2, a condition. And spinal hemangioblastomas occur 30% of patients with von Hippel-Lindau syndrome. So von Hippel-Lindau syndrome is a condition which is a multisystemic genetic disorder where patients have tumors in the brain, both supratentorial and infratentorial. They have hemangioblastomas in the spinal cord. They have various cysts, like in the pancreas and in the kidneys. They have cysts and they have brain aneurysms. So the aneurysms in the brain, the hemangioblastomas in the brain, the hemangioblastomas in the spinal cord, and various. It's a syndrome. It's a syndrome because it affects more than 2 organs. So it's a syndrome. It affects many organs. That's a syndrome. It's named after von Hippel-Lindau syndrome. It's an autosomal dominant disease, and the genetic defect is on chromosome 3. And you get what is called the spinal hemangioblastomas and brain hemangioblastomas and aneurysms in the brain and various forms of cysts in the pancreas and the kidneys. Now coming to extradural tumors. So as I told, extradural tumors, let me tell you once again. So if this is the spinal cord, if this is the spinal cord, okay, and if this is the dural covering, this is a dural covering, okay. So tumors here is extradural. Tumors here is extradural, outside the dura, extradural, okay. And then if I go further, supposing this is the medulla, okay, and if I go further, maybe this is the intradural extramedullary region, okay. So as I told you, tumors can be outside the dura, extradural, tumors can be intradural extramedullary, and tumors can be within the dura, within the medulla. These are called intradural intramedullary. So this is the basic way we classify spinal tumors. So the extradural tumors, as I said, metastatic is one of the commonest. Lymphomas are very notorious for they being found in the spinal cord. Cancers of the lung, breast, and prostate quite frequently metastasize to the spinal cord. And primary spinal tumors are rare, like chordomas, neurofibromas, and osteoma, osteoblastoma, aneurysmal bone cyst, and vertebral hemangioma. Primary intradural, but maybe extradural, are meningiomas, neurofibromas, chloromas, and angioliphomas. So these are basically the tumors which are extradural, but sometimes they can actually perforate the dura and become partly intradural and extra medullary. So intradural, extramedullary, as I told, that is the tumors which are located inside the dura, inside but not in the medulla, the central spot, but on the periphery of the spinal cord, are many tumors, neurofibromas, lipomas, and metastasis. And then we come to the intramedullary, the tumors which is found in the central part of the spinal cord, are the various gliomas like the astrocytoma, similar to ones found in the brain. Then ependymomas and others like glioblastoma, dermoid, epidermoid. Dermoid and epidermoid are benign tumors. Teratoma is malignant. Lipoma is benign, and hemangioblastoma is essentially benign. Which is, as I told earlier, which is a syndrome of the von Hippel-Lindau syndrome. Hemangioblastoma of the spinal cord, hemangioblastomas of the brain, pancreatic and cysts in the kidneys, and there is aneurysm in the brain. So this is part of the syndrome called the von Hippel-Lindau syndrome, where hemangioblastomas are found intradural, intramedullary tumors, intramedullary tumors. So coming to presentation, obviously, as in everything in life, the commonest presentation is pain. If there is no pain, obviously, the patient would not come to a doctor. So pain and temperature are the two things which make people aware that something is wrong. That is the way nature has given man that if you have something wrong, then the easiest way to know is that you will feel pain and you have a high temperature. And these are two things that really cause people to go to a doctor and seek help. And they have quite early symptoms. Sorry, guys. So presentation-wise, the first was the pain. And as you know, the spinal cord, the motor tracts go up, go down, the corticospinal tract, and so they can motor disturbances, sensory disturbances can happen because of the spinothalamic tracts. Sphincter disturbances can happen because of the autonomic dysfunction. And others that can happen is called scoliosis, torticollis deformity, and SH. So kyphosis is a forward bending of the spinal cord, that's called kyphosis. And scoliosis is a lateral bending. So you should be very clear about what is scoliosis and what a kyphosis is all about. Scoliosis is the lateral bending of the spinal or the vertebral column is called scoliosis. And the forward bending of the vertebral column is called kyphosis. So various deformities can take place if there are tumors, and they can be cervical hemorrhage also. So these are presentations of spinal tumor. So physical examination, a patient comes to you and says that I have feeling quite a severe pain in my maybe in my back over the spinal cord region, and lately I'm feeling some weakness in my legs. I find difficult to walk because of my weakness, and they might be pain beating down the spinal nerves. It's called radicular pain, and there might be various forms of sensory disturbances like decreased touch, pain, and a temperature sensation because of the numbness of the nerves being affected. Hypothesias are conditions where if you touch, the areas become more stimulant and become very obnoxiously, you feel a very bad feeling when you touch hypothesia. So there is an increased amount of sensation to areas where that tumor has affected. Decreased proprioception is a condition where the balance sensation and joint position sense are lost because of tumors affecting the posterior column, where the nerve fibers go which help us in the balance and proprioception, that is the joint sensation and the sensations of balance. Abnormal sensation below the level of lesion. Abnormal sensation only at level of lesion is a spindle level. So obviously, the thing is that when you do an examination, you'll find that there is an area beyond which the motor symptoms occur. there's an area where the sensory symptoms occur, and then you can actually understand. So if it is at the level of the lower legs, from the inguinal region, you find that the limbs are become weak, and the patient has abnormal sensations below the inguinal region, then you may think that maybe the tumor is at the level of L1. So that is the reason it's important for students and doctors to know the dermatome level and the motor level. So as far as dermatome is concerned, you should understand that which areas of the body are supplied by which spinal nerves and which muscles are supplied by the spinal nerves. And there is usually a coordination. There is usually a coordination with the spinal sensation-wise and the motor-wise. And then you come to working diagnosis. You come to working diagnosis about where the tumor can be. Obviously, in the age of imageology, in the age of CT scans and MRI, obviously, did not be very evaluative, but it's a good practice to firstly take a history properly, and then you do a good clinical examination. Then when you do the images, it's a great sense of satisfaction that you find that exactly the way you have taken history and the way you have taken the examination and the diagnosis is similar to the region where the tumor is. And in most cases, you can actually pinpoint the tumor even before you do the CT and MRI, which is a very good practice. The physical examination obviously is that, as I told, hyperreflexia, as I said, that the reflexes in our body are in a sense of inhibition, and when there is affection of the corticospinal tract, the inhibition is gone, and the reflexes below that level become increased. So, if there's a tumor at the level of L1, the biceps and the tricep jerks, which are not affected, are normal, but the knee jerk, which is L3, and the ankle jerk, which is S1, are exaggerated. So that is one way that the jerks get exaggerated, the ankle jerk and the knee jerk. So on that basis, when at the level of the tumor, the jerks are actually diminished because the spinal nerves are affected. Below that tumor, because the nerves are not affected, but the spinal cord is affected and the corticospinal tract is affected, the jerks are exaggerated. So in simple parlance, try to remember that the jerks are exaggerated. Hoffman sign for cervical lesions is a condition, it's difficult to explain, but it's a condition where if you flex one of the fingers, just one finger, if you actually press your distal digit of your middle finger, normally nothing happens to the other fingers, but in Hoffman reflex, if you press it out, the other fingers also go into some form of flexion. That is called Hoffman reflex. So if you're just pressing the distal phalanx of your middle finger and you watch the movement of the other fingers, in normal person like you and me, nothing will happen. But to a person with cervical spondylotic myelopathy, the jerks are exaggerated. The other fingers also go into some form of flexion. That is called Hoffman's reflex, which is important for you to understand, but obviously that needs a physical demonstration. Clonus is a sustained act where there is a multiple, when the jerks are sustained, like ankle clonus or knee clonus, it is a feature of upper motor neuron lesion. It's called clonus. So there is, it goes into perpetual jerks, like when you are shaking your ankle, when you're sitting down and the ankle is shaking and your leg shakes, that is called the ankle clonus. But you can stop it. If you want, you can stop it. But when it can't stop with the patient and it goes into a perpetual movement, the ankle moves, it's called a clonus. The extensor plantar response is the Babinski sign, which is very important and is one of the most important reflexes. It is a superficial reflex. And when you stroke the lower part of your sole, you should see what is the movement of the great toe. Normally, to a normal person, the great toe flexes. In many books, many things are written. They say that you watch the great toe and you watch the panning out of the other toes. But the only thing that you remember for the rest of your life is that when you're seeing the Babinski or the plantar response, you're stroking the lower part of the sole of the foot and you see the first movement of the great toe. If the first movement of the great toe is extension, then it means the bapnicity is positive, or the plantar is upward. There's the upper motor neuron lesion. But if the first movement is down of the finger, of the toe, watch the toe movement very carefully. Normally the toe always will go down. But in an upper motor neuron lesion, in a lesion of the spinal cord, the toe will go up. That is called the positive bapnicity or positive plantar sign. It's the material to see what the other fingers are doing, other toes are doing. Normally in books, they're written that the great toe is extended and the other toes fan out, but then you can be confused. Only watch the movement of the great toe. If the great toe goes into flexion in the first movement of the great toe, then the plantar is downgoing, you say, or the plantar is normal. If the great toe is up, then it can go down again. But the first movement of the great toe, if it goes up, that is called a positive bapnicity sign. Is one of the most important reflexes of neuroanatomy. And it is a sign that there is a lesion either in the brain or the spinal cord. This is called the positive, the plantar response. Okay. Then you got spasticity. That is the muscles go into some form of spasticity. That is, normally when the muscle flexes, the muscle is contracted. But when you are doing a passive movement, that is when you are actually not flexing your elbow, but actually when you're extending the elbow, the muscle should be flex, isn't it? But if there is some resistance in passive movement, not resistance when you are actually folding the elbow, that is when the biceps is contracted, that's fine. But when you're relaxing, when actually the arm is falling down, even then if there's some resistance in the fall, if the muscle is still tense, that is called spasticity. That means that there is a degree of spasticity in the muscle, even when it is relaxing. And there is also a feature of increased tone. So a tone increases that if you see a muscle, then it's normally very soft. But when you flex the muscle contracts. Okay. Now when you are like the arm contracts. Now when you let the arm go, when the elbow is extended again, you feel the biceps and you find that there's resistance. Normally there should be no resistance, it should just fall, isn't it? If you fall. But you find there's some resistance even when it is relaxing. That's called increased tone. And muscle atrophy. Muscle atrophy is a condition which happens when you don't use the muscles for a long time, especially when some weakness develops. So muscle atrophy. Muscle atrophy of upper motor and lower motor is different. Upper motor is where there is an affection of the brain and the spinal cord. That leads to upper motor neuron lesion below that level. A lower motor is when the spinal cord itself is affected. Then everything becomes flaccid, even if the tumor is at the spinal level. So, in a lower motor type of condition, there is very quick atrophy because the muscles are in total flexibility. But in upper motor neuron lesion, that muscles are spastic; they are in a perpetual contraction. So that's why they say when there's a spinal cord lesion and the muscles are spasticity, the muscle loss is less, and the chance of the person being able to walk again is better than when the muscle goes into complete tissue atrophy and it becomes a flaccid tissue atrophy and the muscle actually total atrophies. The chances of the power coming back is even less. So there are conditions, as I told, spinal cord syndromes. I think I discussed it in some of the class. Complete transection, that is, the spinal cord is complete transected. So all sensory, motor, autonomic function below that level is lost. The patient is completely paraplegic. The patient loses all sensation, all bladder and sphincter control is gone, all proprioceptives. It's all lost. It's a complete transection. And higher up in the spinal cord, the worst is a devastation. If it's a level of the, if it is at the level of the lumbar region, you just lose the power of your foot. If it's the level of the dorsal, you lose power of your foot along with maybe some power of your intercostal muscles and some power of your lungs. At the level of cervical spine, where all the fibers, both of the upper limbs, lower limbs, and all the fibers go, then you are completely quadriplegic. So you're completely quadriplegic. It's a transsectional part of the spinal level, completely quadriplegic, and you lose all sense of sensation, all motor power, and you cannot breathe yourself because your are gone. intercostal nerves are gone, your phrenic nerve is gone, and you have respiratory distress. Is a very serious condition. So higher up the transection, the worse is the prognosis. Central cord, I said, is a syndrome surrounding the central canal, the spinal cord. Anterior cord, I'll show in pictures. Brown Sequard syndrome is where there is ipsilateral motor weakness and contralateral sensory diminution. That's called a Brown Sequard syndrome. Posterior cord syndrome is where the affection is in the posterior part of the spinal cord, and quadraequinoconus syndrome is where the spinal cord ends at the lower part of L1 upward L2. And if there is a condition there, then that's called the quadraequinous syndrome. So this is a complete transection. That is, the whole spinal cord is gone. All the tracks which go from here, all the thing, everything. So all part of the legs, both motor and sensory and autonomic. Whenever you discuss spinal cord and you discuss function, you discuss the motor function, you discuss the sensory function, you discuss the deep tendon reflexes, and you discuss the autonomic functions. So that covers everything. In the motor function, you discuss about the motor part of the limbs below. In the sensory function, you describe sensation of pain, touch, temperature, proprioception. In the autonomic function, you discuss basically about the sphincteric control, the bladder and the bowel, and and the other one, as I said, the autonomic and the sensory and the motor, and you also discuss on the deep tendon reflexes, which is actually a part of sensory, and you find that the reflexes are all exaggerated. So that is the way you make a plausible diagnosis in a case of complete transection of spinal cord. The prognosis is absolutely dismal. Central cord syndrome, as I told. So here is the central cord syndrome. The syndrome is it could be a tumor. So most of the spinal cord escapes, It's like a syringomyelia, and it has various features. But basically, when that part is affected, it's called a central cord syndrome. Okay. Anterior cord syndrome is when maybe because of the distribution of anterior spinal artery, there is infarction to this part. This is part is gone. So the posterior column is okay, and part of the cortical spinal tract is okay. So only some sensation is gone below the level, but rest is okay. So this is called the anterior cord syndrome because maybe the spinal artery supplies anterior 2/3 of the spinal cord, and the posterior spinal artery supplies the posterior 1/3. So if there is a thrombosis or an embolism in anterior spinal artery, the anterior 2/3 of spinal cord in the transverse cut section, is lost. And the amount of area that is lost, that leads to what is called anterior cord syndrome. The posterior cord syndrome, as I told earlier, is this in the posterior spinal artery is affected. Okay, so this is the posterior cord syndrome. So here, proprioception, joint position, sense, and various other sensations are lost, but the spinothalamic tract is intact. Okay, and basically you have the cortical spinal tract. So the motor part is okay, sensation is okay, but some special sensation of the proprioception, joint position, senses. So you should be very thorough about the anatomy of the spinal cord to realize what can happen when any part is affected. Brown Sequard syndrome is something you should know. So what happens is this is the Brown Sequard syndrome. The cortical spinal tract is going on in this way. So the motor part, if this is the leg motor part, and what is happening is that the spinothalamic tract is the one that comes from spinal cord to the thalamus, the motor sensory, is actually going out this way, It's going this way and it crosses this way, and then it goes up. So if there is a lesion here, what will happen is that sensation of the opposite side will be affected, and the motor part of the same side will be affected. I think, is it clear how is that happening? Because the spinothalamic tract is coming from the limbs and is crossing over this way in the spinal cord. So this part actually, this on the right side is actually giving sensation to this part. And if you see the motor power, motor power is this. This is the motor, and it is actually coming out this way. So, ipsilateral motor weakness, there is the motor power of the right side, and the sensation of the left side is called the Brown Sequard syndrome. Okay, so this is a syndrome which you may be asked for a short note. So please recollect, if there is hemisection of the spinal cord, then the sensation, the spinal salmic tract actually, which is enters spinal cord and crosses the other side. But actually, it supplies sensation on the other side, isn't it? So if it is from the right leg, the spinal salmic tract crosses to the left side. And the cortical tract, which is crossed from the brain, obviously there's a crossing in the brain, but ultimately it is supplying the right side. So if there's a lesion on that region, there's weakness on the side of the transection, and there's a sensory distribution on the other side. That's called the Brown Sequard syndrome, named after one single person. Okay, so Brown Sequard, unlike many syndromes which actually are after two people, please remember, just for your information, that Brown Sequard syndrome is named after one person. Brown Sequard, one person, not two people. So investigations we have to do is a plain radiograph. We have not done much because not much information can be got, but even then you may do it. Lumbar puncture, rarely done for spinal tumors. Myelography, rarely done nowadays. It's like putting a dye in the spinal canal and then you see. But these are actually a bit outdated investigations. The best, obviously, is CT scan and MRI. If you do an MRI properly, you can get all the information. And then you can go for a spinal angiography to see if there's a vascular lesion or not. So primary investigations are CT scan where the MRI cannot be done. If the patient is having pacemakers or the patient is claustrophobic, sometimes the MRI can be done. You can't give a contrast MRI if the patient has high urea and creatinine. Otherwise, the MRI is the diagnostic modality of choice in case of spinal tumors as in brain tumors. CT scan, as I told you, is a diagnostic modality in head injuries. But in spinal tumors and brain tumors, the investigation of choice is an MRI, contrast enhanced MRI. And you can do a CT MRI and you can do a spinal angiography, but the MRI is the cornerstone. So lab studies, obviously, if you think that there's some degree of infection, you can go for a complete blood count, you can go for a prosound time and activity partial, but these are more due to making ready for the operation than actually it gives any indication about the condition of the patient. The CT scan is non-specific spinal canal and spinal cord widening, scalloping of vertebral bodies, possible intraparenchymal syndromega. It doesn't give much picture. It doesn't give much picture of the tumor. And the MRI is so much superior that the CT scan is hardly done nowadays unless until the MRI is contraindicated. So CT scan is hardly done nowadays. But if there is a contraindication to the MRI, especially when the person has metal clips in the body, that also steel clips. Maybe he has some operations in the abdomen where steel was used. But then nowadays we use titanium, whether it's in the abdominal surgery or other spinal fixations, we use titanium, and titanium is MRI compatible. So because in MRI, there is a huge amount of magnetic effect, and so if the steel plates, they might be distorted in the body. And the other is a person having a pacemaker, that's a contraindication. So because the pacemakers can be very severely affected, adversely affected. So when a person has pacemakers or the person has any steel plates obviously, if the person operation made 20 years back when we used steel plates for spinal fixation surgeries, but nowadays we use titanium, which is MRI compatible. And obviously some people are extremely claustrophobic. When you go inside the MRI gantry, people are very claustrophobic. Claustrophobia, the fear of a closed space. Agoraphobia is a fear in an open space. When you go to an open space, you have a lot of things. So agoraphobia. And a claustrophobia is a person having fear in a closed space, in a closed room. Maybe in a closed tent or in a closed space, you have a fear that's closed. And acrophobia is the fear of heights. So if you're claustrophobic, genuinely, then obviously I find people, they just come out. They just can't do it. Okay, so that's the reason. Otherwise, the CT scan, MRI is much superior. Hemorrhoid is fine with and without gadolinium, enlargement of spinal cord and pseudongomatous cystic cavity with the lesion. You can see an ependymoma, T1 weighted images or images on T1, isointense signal with spinal cord, and T2 weighted images are hyperintense. So please remember that in a CT, we discuss images as hyperdense, isodense, and hypodense according to the degree of to the brain parenchyma. So if a lesion is equal to the color of the brain parenchyma, that is called isodense. If it is darker, if it is blacker, it is called hypodense. If it is whiter, it is called hyperdense. In MRI, we use the term intensity. So if there's a lesion which is darker than the brain or the spinal cord parenchyma, it's called hypointense. It is in same category, more looking like the same color as the brain parenchyma and the brain as well, is called an isointense. And it is whiter. It is just simply remember it is whiter. It's more brighter. Then it's called hyperintense. Astrocytoma, which are the commonest spinal cord tumors, T1, there are various sequences of MRI. You have to understand that it's called a T1 sequence and T2 sequence. The T1 weighted images, you have isointense or hypointense signal with spinal cord. In T2 things become hypointense. So there's a sequence of T1 and T2 and cyst formation and heterogeneous enhancement with contrast. Why heterogeneous? Because the blood-brain barrier, similar to the spinal cord bearing barrier, is not completely lost. So there is some degree of dye going in and some degree of dye not going. So that's the heterogeneity. If it is outside the blood barrier, there will be a uniform, intense enhancement, as it happens in meningioma, which is outside the blood-brain barrier. But when it is inside the spinal cord or inside the brain and it has not broken the blood-brain barrier completely, as it may happen in astrocytoma, then there is some dye going in, some dye not going in, that causes a heterogeneous. That is, the tumor has various sequences. Some are dark parts, some are white parts. So it's called heterogeneous, not homogeneous. The tumor is of not one intensity, it's heterogeneous. And there's a feature of a malignant tumor which has reached the blood-brain barrier, but some parts have not been reached, so that part is outside the blood-brain barrier. So that's the reason for the heterogeneity. Hemangioblastoma, as I told, a condition which is found in born hepatocellular disease, a condition which is a syndrome where there are hemangioblastoma, special tumors in the brain, both in the infratentorial region and the supratentorial region. And there is cysts in the kidneys and the pancreas, and there are hemangioblastomas of the spinal cord, and there are aneurysms in the brain. So in the T1 weighted images is isointense signal to spinal cord. In T2 weighted images is hyperintense. Cystic with tumor nodule, you find it's called a mural nodule. And you find a large tumor with cystic with nodule. Enhances strongly with contrast and extramedullary extension in 15% of patients. Spinal arteriogram are conditions like CT angios and the MR angios. You see the vascularity of the spinal cord. This may be beneficial if hemangioblastomy is suggested as a differential diagnosis. Hemangioblastomy arteriogram finds include a vascular blush with a prominent draining vein. So coming to ependymomas are special tumors of the brain and the spinal cord which develop from the ventricles of the brain and inside the spinal canal. So tumors coming from the spinal cord, from the walls of the spinal canal. So there's a central canal of the spinal cord. I think you have this picture. If you don't have, let me show. If this is the spinal cord, and this is the H-shaped neurons, and this is the area where there is the. This is the area. This is the central. This is the central part of the spinal cord. And if tumors occur here, it's called ependymoma. This is the neurons, and this is the outer. So, this is the region. This is the region where this ependymomas can happen. Inside the central from the walls of the central canal, which are similar in continuation to the walls of the ventricles of the brain. So the tumors that occur there is called ependymomas. The mean age at presentation is 43 years. They are malignant tumors, mind you. So there's a slight female predominance. Pain localized to the spine in 65% of patients. Pain worsening at night or upon awakening. Dysphasias and various forms of abnormal sensations. Dysphasias. Long history of symptoms and mixopapillary variant. Mean age of presentation of 21, slight male predominance. And the mixopapillary form of epidermomas are found more amongst males. So this is a tumor of the spinal cord. It's also found in the brain. Inside the brain is found in these ventricles where there's a lining. So the ventricles, which are the fluid cavities of the brain, continue as the central canal of the spinal cord. So tumors in that region occurring from the walls of the spinal canal is called epidermomas. And the other thing that is quite common among these tumors is they're very much calcified. So if you do a CT here or if you do an MRI, you can find that areas in MRI calcification looks like hyperintensity because there's no blood flow marks. So calcification is quite common. So there is this is epidermomas tumor, which you should know is an intradural intramedullary tumor. So intradural tumor, one example is an epidymoma, and these are the features as I told. And to add to it, in images, it's very often calcified. Astrocytomas, as I told, in the brain, as also in spinal cord, is one of the commonest tumors. They're also intradural intramedullary. Equal male and female prevalence. Pain localized to spine. Pain worse at night or upon awakening. Okay, and paralyzations, various forms of abnormal sensations, paralyzations. So astrocytomas can be, they form under what is called the gliomas, I told you. So astrogliomas lead to astrocytomas, oligodendrocytes leads to oligodendroglioma. Tannocytes, the tannocytes are the special cells inside the ventricle that lead to epidermomas. So they are from the glial cells. The glial cells are the cells where the neurons develop, and they are actually like a packing tissue of the spinal cord and the brain to keep the areas insulated. So they are like a packing tissue. They are like the foams inside which the costly things like glasses and all come. There's outer packing, a special foamy packing. That is the glial tissue. They're not the neuron tissue proper, or it is the tissue on which the neurons are housed, and they insulate one neuron to the other. So if there is a stimulation happening in some part of the spinal cord, it follows a specific direction and doesn't go everywhere because there is a packing tissue called the glioma, packing tissue called the glial cells, which prevent the electrical transmission from going everywhere. That is the reason why this packing tissue is there inside the brain and the spinal cord. And unfortunately, they are not the main part. They actually have no function other than insulation and packing. They have no functions in sensation or motor functions, but they are the ones which cause the most notorious cancers. Very few cancers inside the brain and spinal cord are outside the glial tissue, like proper neuron proper. Most of the tumors in the gliomas, the epidermomas, and maybe the oligodendrogliomas are tumors from the packing cells called the glial tissue. Hemangioblastomas, I told you earlier, nothing much repeat. Onset of symptoms by the fourth decade of life, 80% symptomatic by age 40 years. So if you have hemangioblastomas, you would be symptomatic. 80% of us will be symptomatic by 40. Familial disorder is a von Hippel-Lindau syndrome. But please remember that if there is a von Hippel-Lindau syndrome, they will always hemangioblastoma. But every hemangioblastoma doesn't mean that he'll have the syndrome. So if there's a von Hippel-Lindau syndrome, you can be certain that he has hemangioblastomas in the body. But there are conditions where hemangioblastomas can be sporadic. They may be present just as hemangioblastomas, and they may not be part of a syndrome. In that case, they will have just hemangioblastomas. They won't have aneurysms in the brain. They won't have hemangioblastomas in other parts. They won't have the cysts of the kidney. So all von Hippel-Lindau syndrome patients will have hemangioblastomas, but all patients having hemangioblastomas need not necessarily be part of the von Hippel-Lindau syndrome. Decreased posterior column sensation and back pain. So the things that is very common is that there is pain in the area of the tumor. There is some form of sensory and motor dysfunction, there's some form of autonomic dysfunction. And that is the way you realize that you have a spinal cord tumor. The tumors can be outside the dura, it can be between the dura and the medulla, and it can be inside the medulla. So these are tumors. Hemangioblastomas, astrocytomas, and ependymas are, when I said, intradural, intramedullary. Okay. So coming further, you have, what do you do? So cervical resection. So what is important is that there are various modes of treatment. You can go for Coma, and you can go for chemo, and you can go for other forms of therapy, but that is after the surgery. There's a dictum in brain surgery and spinal surgery is that in the first go, you do a surgical resection and try to take out the tissue as much as possible without injuring the eloquent part of the spinal cord or the brain. The word is eloquence. That is areas which are immensely important. So you can't destroy the part. So keeping the eloquent area of the brain spinal cord intact, you try to take out as much as the tumor as possible. So you take out maybe 99% tumor. Then you go for chemotherapy. The various chemotherapy agents that you know of, you go for that. And that decreases the tumor for a further 19% of the 1% that is remaining. And then you go for radiotherapy, which reduces it to a further 1% of the remaining end. So ultimately, a very small fragment remains. Unfortunately, in most instances, it is impossible to eradicate the tumor completely. Why? Firstly, they have this. It's very difficult to delineate which part is the tumor and which part is not the tumor when you do a surgery. And other thing, as I told, is the eloquence of the brain. It's not like the stomach. It's not like the muscle. It's not like the kidney also that you can go for an effectomy. You can go for a complete gastrectomy. You can't chop off your head, isn't it? You can't just chop off the spinal cord. Why they do a radical nephrectomy? So they take out the full tumor. They take out the kidney, they take out the veins, arteries, and ureter and do a radical. That's called radical. But there's nothing called radical in brain surgery because when the patient won't live, eloquent areas will be lost. So that's the reason brain tumors are notorious for recurrence. So you have to be very judgmental when you do an operation and try to take out the tumor as much as possible under the microscope, keeping the eloquent area of the brain spinal cord intact. After that, you go for a course of chemotherapy and a course of radiotherapy. So under general anesthesia is a prone position, that is a position upside down. Radiographic confirmation of the appropriate spinal level is called in the C-arm. Laminectomy, that is cutting part of the lamina of the spinal of the vertebral column. You bring a microscope and you benign neoplasms is crossed to resection. So then you see the tumor. You take out the lamina and you can find the tumor bulging out. Then it's an extradural tumor. If you don't find the tumor, you cut the dura and then you find the tumor bulging out. That might be extradural, intradural, and extramedullary. And then you go further inside and find the tumor inside the medulla. There's intradural, intramedullary. So that is the way you do the tumor. You try to locate the upper pole and the lower pole. Okay, so that you know the uppermost extension of the tumor and the lowermost extension. And with very fine microsurgery, cautery, and surgery, you don't use much cautery also because you have the propensity to destroy very specific spinal vessels which can lead to infarction of the spinal cord. You try to take out tumor as much as possible. The more benign the tumor, the better is the tumor and cord interface. That is, the level of dissection is very clear. You can find a place where there is a tumor and where there is the spinal cord, and you can dissect it out. But as malignant sets in, the delineation is very, very hazy. You just can't make that this is the tumor and this is the normal spinal cord because it is extremely, it has infiltrated. So that is the reason in a malignant tumor, you may not be able to take out completely. And the other thing, obviously, is that you should be very careful that with taking out the tumor, you are not injuring maybe a motor tract or a sensory tract, whether it be in the brain or in the spinal cord. So complications, very important. The first thing that we do after we do our surgery in spinal cord is that the moment the patient is resuscitated, he is reversed from anesthesia, we ask the person to move his limbs. Please move your limbs. That is very, very important. Nowadays, we do various forms of electromonitoring, like MEP, motor evoked potentials, and somatosensory evoked potentials, when we know, even during surgery, if the patient is the motor parts affected. Now, you have a patient who has a complete paralysis, and you go for the tumor surgery, you have nothing much to lose. But you go for the surgery when the patient is walking. You walk into the theater, and then after the operation, he's paraplegic. So it's very important that you be very careful in the surgery. And the first thing that you ask after the operation, the first and the most important thing that you ask is the patient, is he able to move his limbs as before? And then you realize that whether you have done more harm or good. Bladder and bowel dysfunction can happen because the autonomic nerves can be affected. A bleeding can take place in the tumor, which is like a hematoma. Similar to the brain, a CSF leak can happen because there's a CSF in the central canal. Patient can have chronic pain after the operation because you might have transected the nerve, or you might have injured part of the spinal cord, which leads to various forms of dysfunctions. You can injure the nervous system. You can have meningitis if there's infection in the spinal operation. Too long an operation, you can leave some bugs inside, leading to a meningitis. Meningitis doesn't necessarily mean that it has to be infection of the brain. It can be infection of the spinal cord also. The patient can have paralysis after the operation. He can have a sensory loss, sexual dysfunction, skin infection or cellulitis, spine instability, ventilator dependence because it's a high cord, maybe a spinal cord tumor when you operate it, and after that you can't take him off from the ventilator because the phrenic nerves are affected, the intercostal nerves are affected, and he can't breathe himself. So the patient is on a long-term ventilation, and then you do a tracheostomy, and then you try to win him out. And wound dehiscence, obviously, is that you do a surgery, there's a wound infection. After the time when you try to take out the tumor, there is, when you take out before you even open the stitches, there is wound dehiscence. The wound breaks out. Right. Coming to outcome and prognosis. Overall prognosis depends on the neuroplasm system. As I told earlier, if there's a cancer, whether it's in the brain or the spinal cord, the prognosis is bad. As of today, the 6th of May. Hello. As of May, the 6th of May 2021, the prognosis of brain tumor which are malignant, spinal tumors are malignant, are quite bad. 5-year survival rate for patients with benign spinal cord neoplasm is greater than 90%. The goal of surgery is to prevent further neurologic dysfunction, which is very important, and to cure the neoplastic condition with complete resection. And we always be very, very particular that when you operate on a tumor and the patient was able to walk, and you do a very good surgery, and the tumor is gone and the patient can't walk, so the patient is a failure. Because he was walking and now he can't walk. He came here for a problem, and you say that you've taken out the tumor but the patient is paraplegic. You might think it's a success, he will live long, but to the patient it is not a success. So be very careful to note the motor function, sensory function, speak to the patient before the surgery, and tell him very categorically there's a 5 to 10% chance that the power of the limbs might weaken. They might be permanent sensitive. The way we say is that there might be a transient weakness to limbs, which may be transient and temporary, or which may be permanent. You have a chance of transient or permanent sensory limitation, bladder and bowel dysfunction. You may have infection. You may have bleeding, and you might be on a ventilator for a very long time. Because after surgery, it may be not possible to take you out from the ventilator. So before the surgery, you should be very specific to what you want to say, and don't hide any fact. Don't say that just because the patient might feel bad, you don't say that there is a paralysis. It is better to commit a paralysis that can happen after the surgery tend to have a paralysis, and the patient then suing you and saying that I would have never gone for the surgery if it said that there's paralysis. So as a doctor, keep things straight and simple. Don't be rude with the patient, but be very categorical that all these things can happen, including deaths. You have to be very clear. Whether you say to the patient or to the relative, in the United Kingdom and other Western world, the consent is always taken by the patient. Because it is the patient who is giving the consent to be operated on. In India, obviously, sometimes the patient relatives give the consent, which is wrong. It is a patient because it is my body, I'm being operated. I'll give the consent of whether I want the surgery or not, and not my wife or not my children or my relatives. Anyway, all the complications, which is having a chance of 1%. So what are the consents you take? All the complications that happen, which has a 1% chance also. You speak very carefully, very clearly. Say it nicely, that these are things can happen after surgery. You may not be able to walk. It may be permanent. It doesn't matter if it doesn't go for the surgery, that's fine. But it is very dangerous not to commit and say that everything will be fine. And then the patient cannot walk for the surgery. They can disaster. Even if you give a consent and everything, even then the patients create trouble. But if you don't say it, they'll create more trouble. So this is a picture, as I told you. This is, if you see how they look like. This is basically a tumor, intradural, intramedullary tumor. This is a tumor. It could be astrocytoma. This is basically on a sagittal section of the called high up. So this is part of the brain coming down, and this is the high cervical spine tumor. Okay. So this is a similar. There are just pictures here. Our spinal cord tumor. This is a cervical. Because why it's called cervical? Because you can see the lower part of the brain. You can see the lower part of the brain. You can see the medulla. Okay. So this is the cervical spine. I'll just a bit lower down. This is more like, it looks more like a metastatic tumor. There's a metastatic tumor here. Encompasses the vertebra and compressing of spinal cord, which is very common for metastasis because they first affect the bone and then they affect the spinal cord. And so all features below this will be affected. All features above this will not be affected. And you can actually explain to the patient that sometimes when the patient comes with neurodeficits, you can go for a gross surgery because there you are not in a position to improve his motor function. But if you do a gross surgery, you have a good chance the patient might survive, as most of the cancers may be gone. So this is a tumor very high up in the spinal cord. You see, this is the first and the two. This is this is basically called a tumor of the craniovertebral junction. So this is the brain. This is the vertebra. So it's called the CV junction. Tumors very high up in the spinal cord, very near the brain, are called CV junction anomalies or tumors, which are very, very dangerous to treat, because you can injure the brain, and while taking the tumor, you can injure all the nerves which affect the upper limb and lower limb. And the patient will have, what will the patient have? Patient will have what is called quadriparesis. We will have complete sensory diminution, autonomic diminution, and respiratory arrest. So all the lymph below that level will be lost, all sensation will be lost, sphincter functions will be lost, and last but not least, because of high cervical spinal tumor, the phrenic nerve, which has a root value of C3, 4, 5, and the intercostal nerves, which have root values from the intercostal nerves, that is the T1 to T12, all affected, so the patient can't breathe. So patient has respiratory arrest, along with total weakness of the upper lower limbs, and all sensations and all motor functions and autonomic functions lost. A very serious condition. These patients are prone to long-term mechanical ventilation. It's very difficult to win them out. And then the patients develop bed sore. The patients develop deep vein thrombosis because the legs are not moving. The patients develop various forms of chest infection, and ultimately the patient dies. So a quadriplegic patient is very, very difficult to manage. even though the patient is completely conscious. Because the patient is conscious, it's even more difficult to manage them because they can understand what's happening, unlike unconscious patient. It's totally conscious. Okay. So these are further tumors. This is a neurofibroma. If you see, it is a coronal section. You see how the tumor, which is actually developing from outside from the muscular region here, is actually bending on the tumor. This is actually coronal section. Section is called coronal section. This is called a neurofibroma of the, also the CV junction as well, the craniovertebral junction. Junction of the cranium where the brain is ending and spinal cord is starting. All the ligaments, all the nerve tissue, and all the bone, all the region, that whole region is called the CV junction. There's a special region in neurosurgery. It is neither completely the brain, it's neither completely spinal cord, but it is the junction of the brain and spinal cord, a very, very specific area and extremely prone to, it's very difficult to manage it if you're not very sure of the way you manage it, because you can lead further injury to the brain and further injury to the spinal cord. So this is basically a cut section in this called the axil. You see the tumor. So this is a hemangioblastoma, as I told you. This hemangioblastoma most probably is in the level of the T12 means an L1 vertebra is hemangioblastoma. And inside you see that's the hypointensity. This region is called hypointensity. Okay. This is called hypointensity. And the rest is hyperintense. This part is hyperintense. Okay, so these tumors you can remove because since it's lower down, you have no chance of injuring the cervical spine. So the patient will not become quadriplegic. So the most patient can become paraplegic. The respiratory muscles are most of them escape because they are above this level. So the patient survives, rarely dies, but he can become paraplegic unless somebody is already paraplegic when the tumor is presented. Okay. This is another spinal cord tumor. This is basically a continuation of a brain tumor inside the spinal cord. And if you can see a junction. So these are basically the various forms of tumors that we deal with, but you should know in nutshell. The pictures are obviously not very nice. So this is another tumor you see. This is a tumor. So this is a tumor you see. Probably it's in the dorsal spine. And it has affected both the spinal cord, the medulla, and the extramedullary region. And the patient obviously is paraplegic, I think. But in this case, the patient is paraplegic. It's better for you to do a complete resection because they have nothing to lose. But if you can take out the full tumor, the patient has no cancer in the body or well, and the patient does good with radium chemotherapy and survives. So that is in a nutshell about spinal cord tumors. The tumors can be basically extradural, intradural, extramedullary, and intramedullary. The commonest features are pain, some form of motor and sensory dysfunction. They may have various forms of autonomic dysfunction. The common tumors in the extramedullary region, extradural, are the neurofibromas and some form of meningiomas. Even the intradural extramedullary neurofibromas and the meningiomas. And inside the medulla, you have tumors like the adenoma, which develop from the gland cells of the central canal or the astrocytomas, and the tumors of the various forms of gliomas. And a special tumor is there, which is called the hemangioblastoma, which is part of the syndrome, sometimes of a syndrome called the von Hippel-Lindau syndrome, which has hemangioblastomas of the brain and the spinal cord, and cysts in the pancreas and the kidneys, and aneurysms in the brain. It's a benign tumor. If you are dealing with a benign tumor, the chance of surgical resection and improvement is greater than in a malignant tumor. But unlike in other parts, even in a benign tumor of the brain, you have to be very careful if you are injuring normal brain tissue. You can't go for radical resection because even if it is not a cancer, you can cause irreparable damage to the structures outside. So you have to be very careful. Because malignant tumor, obviously, after the operation, you have to go for a course of chemo and radiotherapy. And even then, they do reckon. The complications that can happen after a spinal cord tumor depends on where you're operating. If it is very high in the cervical spine, you can have quadriplegia, which is complete loss of motor power, or quadriparesis, which is partial loss. So there is some movement that's called a paresis. Paraparesis, where there is some bone legs. Paraplegia, complete loss of motor function. Quadriparesis, some movement of the upper and lower limbs. Quadriplegia, complete loss of limb power, upper and lower limbs. You will have various sense of sensational affections, motor affection, sensory affection, and autonomic affection in the form of sphincteric disturbance or the bowel impact. After the operation, the patient can have complete paralysis of legs or the arms or both. You can have sensations, you can have infection, you can have CSF leak, you can be on a ventilator for a long time, you can have recurrence, you can have bleeding. And everything of this will be clear to the patients. Is it okay, class? I think that is sufficient for you to know about spinal cord tumor. You don't need to know much more than that. You should know the presentations. You should know the symptoms. Yes, and the other thing is obviously the presentation is the pain and motor and sensory dysfunction. And the investigation-wise, you can go for a CT, you can go for an X-ray, you can go for a lumbar puncture. But the diagnostic imageology of choice is a contrast-enhanced MRI, where you can see the tumor very well, and you can delineate whether the tumor is intradural extramedullary or intramedullary or intradural extramedullary and or extramedullary. MRI is a contraindicated if the patient is claustrophobic or the patient has metallic implants, but not titanium. If it is titanium, it is MRI compatible. And MRI is also contraindicated if the patient has a pacemaker. In that case, you have to go for the CT scan of spinal cord, but that is of not so much of significance. It doesn't give so much of information as MRI gives. Is that okay, class? Any questions? Hello? Are you guys there or not? Tell me first. Are you sleeping? You're there? A lot of you are there, it seems. Hello? Would someone answer me, please, so that I'm not speaking to myself only? Are you there? Hello?
Yes, sir. Thank you, sir.
Yeah, please answer me. Or else I think that maybe I was speaking to myself for half an hour. Okay? So, is that okay for you today?
Yes, sir.
And as Dr. Sanjay Dev, she was telling also, please be safe. Please be safe to yourself, to your patients, and to your family. It's a very, very dangerous time that we are going over. Please keep your safety to yourself first. First, help yourself and then help others. This is my small piece of advice to you. First, always keep yourself safe and then help others. Because if you don't keep yourself safe, you can't keep others safe too. Keep yourself safe, keep your family safe, and then keep the world safe. Good night, guys. Take care. Bye.
Thank you, sir. Good night, sir.
Thank you, sir.
Start in 2 minutes. Right, I think we'll start now. Silajit, am I audible?
Yes, sir.
Good. Right. A very good evening to everyone. Before I start, let me ask Shilajit. Shilajit, am I audible?
Yes, sir.
Good. So today's topic discussion is something for a ward round scenario. a thing that you have used every day more or less in your surgical practice. All of you know many things about these topics. So the discussion can go on and on, but we will be very focused and we will only discuss things because we have two problems to deal. One is we'll be talking about drains, which as such take out 2 to 4 hours to talk about. And another one is something called tubes, and particularly we'll be talking about something called as a T-tube today. So what I have divided is that I have divided today's talk about 45 minutes to 50 minutes into 2 parts. So please keep your questions reserved for the end so that we can discuss many of the things as they go by. Now, so let us start with drains and what are the types of drains and what are the differences of various types of drains and what to use at what time. Now, as I have said, whenever we start by talking about drains and tubes, there's 2 things to remember that. Number one is that in drain, there are 3 terms that a postgraduate sometimes is asked in his ward round or in his exams. What is a drain, what is a tube, and what is a catheter? Because all of them, to a layman's term, is technically a cylinder that conducts a fluid. So if you think over that all of this is a cylinder to conduct a fluid, absolutely rightly said. Now, what is the special things that are important to remember about a drain? Okay. Now, first of all, let us start with the term catheter. Now, remember that all of these terms, particularly the term catheter, is a Greek term. Now, the term catheter means a cylinder or a hollow cylinder that allows an outflow of a fluid, majority usually from an organ or a space. So it allows an outflow of a fluid, whereas a catheter can also allow an inflow of a fluid. Example being an IV line or an IV catheter and a vein flow, for example, into a vessel or a cavity. And the reality to begin with is that all of these 3 terms, more or less, are interchangeably used. We should not be too rigid in these terms. Is to use with what? The best example of catheter that we have in our practice is usually a Foley catheter. All of you have known what is a Foley catheter for a very long time now. Now talk about tubes and what is a drain and what is a tube. Now when you talk about drains, remember that drains are those cylindrical structures which allow an excess amount of fluid. Now this is an important part of the definition. This allows an excess amount of fluid. Now fluid does not mean only liquid. Fluid means both gas and a liquid, something as a fluid, and it allows the removal of the excess amount of fluid either from a space, a cavity, okay, a wound, etc. So that is what exactly is the definition. So remember that a drain is always used for taking out excess amount of fluid that comes out. So that means you are not required to take out everything. A catheter more or less tries to take out everything that is accumulating in that cavity. So the reason about telling you this so-called simple issues are because at a postgraduate examination, I have seen examiners ask candidates these simple questions which are enough of a very difficult nature. Now, the tubes, remember, could be usually with both the purposes, and that means either the tube could be used as a catheter, that means to put in a fluid in the cavity or to take out the fluid, or could be used as a drainage. So remember that it becomes a very difficult terminology in English to talk about what is the difference between a tube, drain and a catheter. To start the day, I told you about this one. Please remember, as surgeons, we use them interchangeably and we do not squabble about what is what. So this is what I felt should be the first one, because majority of you know many of the things. Now, what is important for remembering is that before we talk about why should we use a drain. Now, the reason number one that I could find out or that I could think about is that when I want to remove an unwanted amount of fluid or a pus or a exudate or a gas, say for example, here will be a gas. Okay. So am I audible? I think, am I audible? Hello?
Yes, sir.
Good. So the first use is that you want to remove an unwanted amount of fluid, etc. Sorry. Oh, extremely sorry. The screen sharing went off. I think we are back again. Right. So what is the first use of using a drain? So the number one is that the unwanted removal of the fluid, the pus, the exudate, or the gas or the air. So this is the first one. Number two is that it allows the diversion of the body fluids. Now the best example of this probably is a T-tube, and we'll be talking about a T-tube in the next part or the next topic that we'll be discussing after drains. The number three thing is that it allows the tissue apposition. Now this is important for surface surgery. Say for example, after the mastectomy, you have given a drain so that you need the flaps to come and sit on the wound. Now, rarely you need the monitoring of the quality of the fluid that comes out, and it allows you to diagnose a pathology. Example probably is a pancreatic leak. We all know about pancreatic leaks, how to diagnose the drain amylase levels, etc. Okay, last part of the story is that some procedure that was called as drainogram, called as tubogram. Particularly remember if you have conditions like a biliary fistula, etc. Okay. And so these are the reasons of use of drains that I could think of. And this is the reason that I use a drain for a surgical procedure. You can think of more better answers than this. Now, after we have thought about drains, remember that as I have drained. Now, the next part of the question is, what are the types of the drain? Now, as with any surgical instrument or surgical device, nothing of these drains are usually the best quality of the drains. Definitely, there are more important things that you require from the quality issues. Now, examiners can ask you about this strange question. What are the qualities of an ideal drain or a good drain or a good drainage tube or a good drainage pipe or a good drainage catheter? Now, the qualities that we are looking for are that they are soft, which do not produce any damage to the surrounding organs. Definitely, they are always inserted in a sterile way. They are stable. That means the amount of the inflammatory reaction to the body is limited. Now, this one is an important, interesting entity. Remember that materials that are made out of rubber are usually orangish red in color, or something that is made out of latex are usually allergic to the patient. And as they're allergic to the patient, remember that if you're using this rubber-made materials for the drains, always take a note from the patient that are you allergic to something. Okay, number two is that what is good about these things are that they form a good amount of tract. And in a T-tube, we are going to require that, whereas a polyvinyl chloride or a plastic forms a bad tract. Particularly remember that the inflammation that is there is very low in this part. That means they're good for the body because the inflammation that they produce are much less. Okay, they should be, remember that, smooth to operate, smooth to insert, smooth to remove, I say. And finally, they should be simple to manage. So I usually, when I teach our undergraduate students, I tell them there are 1, 2, 3, 4, 5 qualities of a drain, which are remembered by the word 5 S's, which are the typical qualities of a good drain. Now, definitely, we do not have any drain which fulfills all. There are good and there are bad things about each and every one. Now, after these drain things are done, examiners in the ward rounds can ask you an interesting question. What is the mechanism of the drainage? Now, this strange question of a mechanism of the drainage tubes goes by a very simple philosophy. Wider the drain, definitely, as the common sense says, the more wider the drain, the better is the flow. So we all know that. But definitely remember that if you talk to a physics chap, so this philosophy in physics or this mathematics that is called as the Poisson's law. I'm not good in physics or maths, so excuse my knowledge. So this is technically called as Poisson's law, which that means says that if you double the diameter of the drain, remember that the flow rates are going to increase by 16-fold. So the basic story is that if you double the diameter of the drain, the flow rates are known to increase by 16-fold. Now the logic about knowing this part is very simple. Hence, in a patient with a trauma, when you are expecting a pneumothorax or a hemothorax, it is always good to give a 32 or a 28 French drain, which is a wider drain. Whereas if you have done, the patient is with a pneumothorax, and you know that the pneumothorax is an iatrogenic procedure for any reason maybe, you need to take that little amount of chink of the air out. You can go in probably for an 8 French small pigtail catheter drainage. So please remember, your intention to take the material out determines what is the size of the drain. So if the examiner will ask you what is the philosophy of using the drain, that equation in physics is called as Poisson's law. You can look up what is Poisson's law into that. Okay. Now, what are the important things that allows the material to come out through the drain? As I have said that today's class we are going to talk about drains and we are going to talk about. Now, there are 4 things that determine. Number 1 is something that I always feel is Mr. Isaac Newton, is gravity. So this is probably the most important part. That means if there is a fluid in this cavity, it is going to come down by gravity. Very important part again. Point number 2 is important part for drains that are given in tissues by something called as capillary action. Now remember that capillary action is not a very strong force, and the capillaries can drain fluid until and unless the column of the blood or the column of the fluid is small in size. So maybe if the column of the fluid is about 1 to 2 centimeters in depth, that probably still is the reason you can use a capillary action. Point number 3 is something called as a tissue pressure. Now, tissue pressure is an important part, particularly when you are in the peritoneal cavity or the pleural cavity. Remember that peritoneal and the pleural cavity can only drain fluids when, if you are considering that the cavity pressure is P1 and the bag pressure is P2, if P1 is greater than P2, it is only up to that point that the tube can drain. If remember that P1 becomes equals to P2, definitely there is no drainage. And in these circumstances, we use the point number 4 is something called as a negative pressure. Is something called as a negative pressure in the drains. So please remember there are 4 things to understand. What are the important factors that govern the efflux through a drain? Sir, point number 1 is gravity. Point number 2 is capillary action. Point number 3 is a tissue pressure, particularly as I've said, P1 versus P2. And point number 4 is the application of a negative pressure. So these are the 4 things that are important to remember. Now, finally, before we talk about each and individual drains, examiner can ask you, what are the classifications of drains, or how do we classify drains and that? Now, please keep these notes well, or if you will be seeing the videos in a rerun, I will be, as I've said, I will be exactly saying the words in a way that you are asked in an word round examination. Now, the first one is that examiners will ask you about what are the types of brains, or how do you classify the usage of brains or types of brains. Now, as a postgraduate, you can think up with many new classifications. What I know is that classification number 1 is based on the rationale of use of the brain. Now, what do you mean by the rationale? The rationale number 1 is drains which are given for prophylactic purpose. So, for example, after a mastectomy, you give, or after a thyroidectomy, you give a drain with an expectation that whatever is going to get collected, that is going to be taken out. Point number 1. Point number 2 is drains that are given for a therapeutic purpose. Now, this is the best example is that after a cholecystectomy, the patient develops a bilioma. So that is a collection that needs to be drained. So that is a therapeutic drain. Or it could be a diagnostic purpose. Say, for example, you have given a T-tube cholangiogram. Yes. Which is a drain that is kept in the bile duct, and the reasons we'll be talking later. Why do you need a T-tube cholangiogram? So the first classification that I could think over is what is the rationale in giving the drain. So the first rationale is these 3. The second one, or the second type of classification that I know of, again, as I've said, you can definitely modify, improve, is something called open drains versus a term called as a closed drain. Now, what is an open drain and what is a closed drain? Now, very simple. Open drain means that these drains are going to come out from that cavity or the wound to the external atmosphere. So that means if this is an abscess cavity or this is an abdominal cavity, whatever is going to come out through these drains, remember that, is going to come out usually by a capillary action or by a gravity assisted action. And then you must need a big dressing gauge, which is always getting soaked by this. Now, the reason about using this drain, because you may have seen some senior surgeons use this kind of drains even after doing a cholecystectomy. I do not know. Have one of you seen your senior teachers give a corrugated rubber drain after a cholecystectomy? Hello?
Yes, sir.
Yes, you have seen that. Okay. And you must have seen, or what is the type of drain that you use? Do you use this type of drain or do you use
The corrugated drain, sir, not rubber drain. The plastic
okay, the corrugated, forget the rubber material, we're not talking materials. So you use the corrugated drain, isn't it? So that means the type of the dressing that you give is this gauze dressing or cotton dressing, whatever you have. Isn't it? Right. Now tell me, on a similar example, after the cholecystectomy, like my practice is to give this kind of a drain in the hepatorenal pouch or in the liver bed, with the expectation that whatever is going to come out is going to get collected in the bag. Now, what is the advantage of the closed drain? The basic advantage that I feel is that it is a much more neat, clean system, and the amount of the output that is going to collect in the bag, we can measure the amount of the output. Okay. So I think that this is a waterproof system. There is, except maybe some minor peritubal leaks that may happen, but you can measure the output. It is clean for the patient. It is easy for the patient to handle, and it is easy for you to monitor and discharge. Whereas, what is the biggest problem with a closed drain?
Sir,
Exactly. See, the biggest problem is what your sir or your older teacher says. Well, I told you, this can form a block. And hence, old people do not like to have this one because they feel that this material is always a foolproof material. It doesn't get choked, it doesn't get clogged, but there is one biggest problem. What is that one? The biggest problem is, what is the material that can enter the body through this? Or infections. So please remember, open drains are technically removed by 48 to 72 hours. Whereas closed drains, the advantage is that you can keep them for a long time. Now, what long time? Let us talk about that. So, these are the two classifications to start with. Okay, have I made you understand up to this point? Hello? Hello?
Yes, sir.
Right?
Yes,
Good. So now, I know that this is such a topic that all of you use every day. So I felt that this is a topic that we should discuss and your notes should be reflecting what are the points. So this is the second type of the classification that I could think of. Now let us talk about the third type of the classification. Now the third type of the classification, remember, is the third type of the classification that I think of is according to the material that is used. So point number 3 is classification according to the material. Now, when you talk about classification according to the material, I feel there are two types of drain. One that are made out by inert material, that means the amount of inflammatory reaction that it produces is minimal. And the best example is a PVC made drain. Now, an important cautionary word to remember. Remember, PVC made drains were made by PVC so that the body inflammatory reaction will be less and it has a lesser chance of forming a tract. That means if you are using a PVC made tract to make a T-tube tract or a biliary tract or a pancreatic external fistula, please wait for a gap of at least 4 to 8 weeks for the tract to mature. Early removal of a PVC made tube can be extremely dangerous. If you are requiring a tract to form, if you do not require a tract, that's it, very good. You can take it out within a couple of days. Whereas on the other hand, another class of the drains that they're made up of is something called as irritant. Now, irritant can be, as I have said, usually with the rubber, or irritant could be latex. Now, the main problem with these two are they are allergic, and you need to test for allergies before you use these materials. Now, what is important is that the tract that is formed is an usually good amount of tract that forms by 14 days. So if you're doing a suprapubic cystostomy, whatever is the material that you are using, please remember, before you go for changing of the catheter or before you are going in for a new tract dilatation, please understand what is the material. If it is a PVC made material, then please wait for a long time before you can change the catheter in the tract. So this is the third thing that I talk about. Okay, now can I erase this part? Hello? I think I can. So I can erase this one. So this is the second classification, that is the third classification by materials. Okay, am I audible? Hello?
Yes, sir.
Good. Now, the fourth type of classification is according to the diversion of the fluid. The fourth type of classification is according to the diversion of the fluid. Now, when you talk diversion of the fluid, either they are internal drains or they are external drains. Now, external drains are something that we identify definitely. It is in a bag. Okay, and you can measure the output. This is the biggest part of this thing. Now, what are the materials that you need to come out of the body? The answer for this is very obvious. When do you use an external drainage or not an internal drainage? When you use an external drainage, materials which are infective. Can you give me an example in which you are required to remove an infective material by use of a drain? Hello?
Sir, in laparotomy, sir. Pigtail.
Okay. Pigtail for what? Sir, a liver abscess? Okay. Remember, so in a pigtail for a liver abscess, remember, what are you going to take out? The pus. Do you recycle the pus in the body? No. Now, internal drainage. Whereas, in a patient with a hydrocephalus, that means there is more fluid in the ventricle. When do you put the internal drainage tube into? Very good. Peritoneal cavity. Why didn't you take this fluid outside the body? Because as I have said, number one is infection. Number two is that there will be chances of loss of the fluid. That is something that we do not need. Okay. So we can talk about an internal biliary stenting. Okay, right. So definitely it is about diversion. So we have talked about 1, 2, 3, and 4. So the first one that we did talk about was according to the rationale. The second was something that we talked about was an open and a closed system. The third one was the material. The fourth one of the drains is something called as according to the diversion of the fluid. Now, the fifth type of classification is something called as use of suction. Now, the answer for this is that if the drain is being used with a suction, that drain is technically called as an active drain. Well, people have funny ways of naming this. Okay, it is an suction drain or an active drain. Can you tell me an example where a suction is used in a drain?
Sir, axillary section.
Okay, very good. Sir, very good, sir. Either it can be a vacuum assisted suction, something that you use after a mastectomy maybe, or after a flap dissection maybe, or it could be an assisted suction, or it could be a mechanical suction, which is technically based on the device. Example being a chest drain. Okay, the material of the chest drain is the bag is made in such a way that you can attach a suction device to this. Whereas without suction, such drains, example being an abdominal drain, is technically called as a passive drain. So the first type of classification is important, in which you should know what is an active drain, what is a passive drain, what is with suction and without suction. So let us have a recapitulation. What is the first type of classifications that I told you is dependent upon the rationale. What is the second type? Open and closed. What is the third thing? Material. What is the fourth thing? Diversion. What is the fifth one? Is dependent upon the suction that is used in this one. Now, there is a special type of drain. I do not have the picture of that one. Is something called as what I will do is that I will go to this page. Something called as a sump suction. Okay. Now, some suctions technically are very important in abdominal surgeries, or say like you have done a necrosectomy and you need the fluid or exudate to come out. Now, what is exactly a sump suction device? Now, the better way of sump suction device is, has any one of you seen a sump suction device? Yes. Okay, good. Now, when I was a postgraduate, when in our unit, we used to make an indigenous sump suction device. Now, you must be wondering what that interesting thing is. So what we used to do is that my teacher taught me, we used to keep an outer tube, and in this outer tube, we used to make small holes in the outer tube. Okay. And then what happened was, what we used to do is that we used to put another pipe inside this tube, which used to be a little short in the length. And again, this pipe, as you can see in the picture, also had a few eyes and holes to be done out. But what was very interesting was that this connection system was attached to the wall suction, which we did it at a moderate pressure of about 75 to around 100. Suction pressure of around millimeters of mercury, we did a suction pressure of minus 75 to minus 100. Now, what is so special in this sump suction device is that, now if you think about that with a wall suction, if I keep it in the abdominal cavity, and then if there are holes in the wall, what is the biggest problem that you think technically can happen in the abdominal cavity? What are the problems that can happen in the abdominal cavity? So the biggest problem is the momentum comes out exactly. See, the most important problem. Now, all of you have done a laparotomy. You know that whenever you are doing the peritoneal lavage and taking out the fluid, what is the material that chokes the end of the sucker? Are usually pieces of the viscera and omentum. So whenever you are using, exactly. So whenever you are using the negative suction with a tube, there are umpteen chances that it is obviously going to get clogged by the bowel, the omentum and the mesentery. So what we have done is that, say for example, this is the pancreatic necrotic bed, and now we need all these exudative fluids to come out from the surrounding, but we also need the stomach to stay away. We also need the small bowel and the omentum to stay away. So how does it work? It works by taking all the fluids into this outer tube. And when you take all the fluids in the outer tube, what does the inner tube do? The inner tube gradually sucks in. But mind you, an important point, the inner tube, the colored in blue, has to be shorter in length than the outer tube. Because if you are making it at the same length, then this is the effect that is going to happen. Okay, so this is technically called as a sump suction and is used for conditions in the abdomen like a pancreatic necrosis or after a necrosectomy, where you need a prolonged exudate to be drained. So these are things, prolonged exudate to be drained. Now, more or less, if you have used a negative pressure wound therapy, this is something that we will not be talking today. Now, more or less, the gross philosophy looks like this. Okay, so these are the materials that we have talked about, and I have told you about the various classifications of the various genus. In this, I hope you have taken down the notes. Hello, right? Okay. So this is the first part, and you are asked about these questions in an examinations about what are the various types of drains and how do these drains act and what is the basic philosophy about use of these drains. Particularly remember, any of the drains will work by these four philosophies: gravity, capillary action, tissue pressure, and then negative pressure. Okay, right. So let us talk about now what are the complications that can arise due to drains. Now that all depends upon what is the drain that you are using. Remember that complications that can arise due to drains are umpteen. Drains have always been in a controversy. All conferences, more or less, every alternate year given debate for surgical residents to drain or not to drain. And we always, when we were postgraduates, we used to participate in such interesting debates. I do not know how many of you have done that. But again, so this controversy will continue. There are meta-analyses which have proved that drains are useless in majority of surgeries, except for some. Still, it is a practice. I do not know how many in this group do not use a drain. We all criticize the drain, but still use a drain. Okay. Now, what are the important complications that happen due to a drain? The first of the complications are definitely there is loss of fluid and electrolyte, particularly from the abdominal cavity. Pain at the site of the drain. Number 3 is again a restricted mobility of the patient. Now, it could be mobility of the limb, it could be mobility of the patient. Okay. Number 4 is a very important problem is erosion of the drain. And the 5th and the biggest problems are drains have been always associated with an ascending infection that goes through the drain pipe into the cavity. So it could have been a pancreatic or a procedure after a pancreatic drain, or it could have been a procedure after a cholecystectomy or an appendicectomy. Remember that there are not too good amount of literature, but some amount of literature that have even shown that after an appendicular perforation, if you give an intra-abdominal drain, the chances of post-operative adhesions, post-operative pain and ileus is more if you give a drain rather than not giving a drain. That means in an appendicular perforation, giving a drain is bad. You should not give a drain. And if you even read Bailey Love, the basic story is very simple. Bailey Love says if you have to drain the parietes, which will be a prophylactic nature of the drain, because it is expected that the amount of surgical site infection is more than around 40%. So it is good to drain out those collections that exudate in the parietes rather than intra-abdominal. So drains have always been criticized in this level. Okay, so more or less, as I've said, the more we go on talking, we can go on and on criticizing drains. What I have done is that I have a couple of pictures that I took from Google Images, with definitely credits to the people who have uploaded the images for a free use in a public platform. So let us talk about a couple of drains. I hope many of you will be using these drains. You know what these drains are for. And then we'll be talking about this couple of drains to remember. So the first of the drains that you can see in this picture, what is the name of this drain? Hello? What is the name of this drain?
Jackson-Pratt drain.
Very good. So this is technically called as a Jackson-Pratt drain. Okay. So the spelling of a Jackson-Pratt is again Pratt drain. Okay, so nothing to do with Michael Jackson. So this is a Jackson-Pratt drain. Now, when you talk about a Jackson-Pratt drain, what is basically this drain? Now, understand that this drain contains this part, which is called as, some people call it as bulb. Okay, I am an action movie fan. I call this material as a grenade. You say, oh, man. So this looks like a grenade. I call this as a grenade. And believe me, some people do call it as a grenade. This one is called as a stopper. Okay. This material is a flexible tube. Whereas what is not a flexible tube is a drainage end, which is technically a flat fenestrated sheet. Okay. So this is a flat fenestrated sheet that is used. Okay, so please remember that part. Now, what is important is, so as you can very easily imagine, what is the nature of this purpose? You can see the penetrations. Definitely this is soft and pliable. You can cut this to the requirement of your need. Now the so-called bulb or the grenade, whatever you call it to be, comes in various capacities of 25 ml, 50 ml, 100 ml, 200 ml. So it depends upon what is the use or where is the purpose that you are requiring to be used for the purpose. Definitely this is for the patient care. The patient can pull this, okay, and go about to see a movie. Whereas remember that this is enough. What do you think is the basic mechanism of this? What is the type of the drain? Okay, is this an open or a closed? Is this open or closed? This is closed. Okay. Now tell me, what is the mechanism through which the material is going to come in the drain? Capillary action. Out of these four things, gravity, capillary action, tissue pressure, and it. Okay. Think over so that it could be, say for example, I've used this after a thyroidectomy. What do you think is the mechanism? Definitely, as you use a vacuum suction drain, you will be applying the bag or the capacity of this grenade or the bulb in a collapsed state. So the mechanisms are usually initially with a negative suction, and the later mechanisms definitely is always a gravity and definitely some amount of a capillary suction. Okay. Now these fenestrations, as you can imagine, they are going to pull in the fluid, and this fluid is going to come in the tube. So what is the nature of operations in which you have seen a so-called a Jackson-Pratt drain? Now, there are manufacturers who have called this as Chemovac Jackson-Pratt drain. So we are not going to talk about, again, proprietary names, but this is very commonly called as a Jackson-Pratt drain, and you use it usually for surface surgeries. So for example, after a mastectomy, okay, or after a mastectomy, maybe after the thyroidectomy, maybe. So these are usually the indications of use of a junction drain. What is this? Okay, so this is this one. Now you can be very imaginative in the use. Now this is a drain that you have seen more or less every day while doing a mastectomy or even a wound closer. What is this type of drain called as?
Suction drain.
This is called as a vacuum suction drain or a vac drain. Okay, it depends upon the company that you use, like say for example a Romovac, Hemovac, are names of trade names. So this is a vacuum drain. Now the capacity of this bulb differs. The size of the tube differs to be from 8 French, 12 French, 14 French, 16 French, 18 French. Definitely the logic says that the more will be the diameter, the better will be the material. Now what is the nature of the operation that you use this material in? What is the nature of the operation that you use this? Can you give me an example that this drain is used in?
Sir, mastectomy.
Mastectomy. So now can you quickly tell me what is the classification of this drain?
Sir, it is a closed drain. And
number one, it's a closed drain. Number two, this is an active. Active by what mechanism?
Sir, active by negative.
Active by negative suction. Okay, very good. So this is what I wanted you to know from today's class. So that whenever you are given a patient with a ward round with a drain, it is good to know about a closed drain. It is good to know about an active with a negative suction effect of the drain. Okay, right. What is the mechanism through which fluid will come through this? Sir, point number one is the negative suction. What is the second point that the fluid comes through this?
Gravity.
Is gravity. And number three is capillary action. Okay, very good. Now the important question is, will you be using it in the abdomen after a lap colon? What is your opinion on this? Okay. Why not, sir?
Because of the momentum, the drain fenestrations will get choked with momentum. So very
okay.
And it is very tough which can injure the organ.
Okay, good consideration. That means you are more considerate that this is a narrow tube and the eyes can get choked. Valid point. Point number two, well said that the material is made out of stiff materials. So this will be discomforting to the patient. Maybe it can even erode into a bowel. But the biggest problem that I feel always is that if you apply a negative suction to this, the sump effect is going to come in. The momentum is going to get sucked in, or the bowel loops are going to get stuck up, and it is going to erode into a bowel loop. So there is a group of surgeons who still feel that no, this is really not a very theoretical issue. We always use a negative suction. There is a group of surgeons who believe that this is very good because this has multiple eyes. The diameter is small, but they say that we use it without suction. That means they do not allow the suction to happen. Okay. So this is the first part of the material to be used. Now, on a personal note, I will ask you an important question. I had a thesis on this the last year. After a mastectomy or an MRM, okay, what is the amount of suction that you give in this type of drains? Do you give a full suction? Do you give a half suction? That means depends upon how much amount of the bellows you are compressing. Or do you give a delayed half suction? What is your practice? Did you understand my question?
Suction and then after 4 or 5 days half suction.
Okay. What is your logic? What is your rationale?
Sir, if we give full suction continuously, it will drain some amount of tissue fluid in the drain.
Okay, good one. Now see, these are the points that should call always for a randomized trial. Well, I have done a non-randomized trial, but still, my effect is the amount of the seroma that happens, believe me, in all the 3 arms is equal. But again, your results may differ. So these are the small tidbits that you are asked in an examination. Okay. Right, come to this kind of drains. Okay, this kind of drains looks like a piece of rubber tubes is technically called as a Penrose drain. So this is called as a Penrose drain. Now what is this Penrose drain material like? Now Penrose drain materials are exactly like this. I took this picture from the Google images with a free reproduction. So remember that there are no copyright again. So what is important is, in my practice, I usually use a gloves as a very simple material to be used as a Penrose drain. But now remember, what is this Penrose drain material? Now Penrose drain is a soft rubber drain. So Penrose drain technically is a soft rubber drain whose you can see the amount of the size of the drain. And remember that definitely, as you can see in the cavity, if there has been an abscess cavity and the part of the drain is inside, now tell me, what is this type of drain by the mechanism of action? Open or closed?
Open.
Okay. What is the other mechanism then that this is going to act over? How does the fluid come out of this drain? Gravity. Gravity. Come on, man. Isaac Newton is sitting down here. He's smiling at you. Okay, so what is the mechanism in which this is going to come?
Capillary action.
Very good. This may be an appendicectomy wound, mind you. This is exactly by a capillary action.
Capillary.
Very good. So this is by a capillary action that this is done. Now, what is the technical consideration for this type of drains or a Penrose drain? Now, the biggest problems with this type of drains or Penrose drains are only one. Remember that they are more prone to get infected. Always remember that. And hence should be removed by 48 hours to 72 hours. Now, there has been a modification in this type of drain. I do not know how many of you have done this kind of modification. When we were residents, one of my registrars taught me this one, something called as a cigarette drain. Okay, so that's an interesting concept. What is a cigarette drain? Okay, now what is important is I do not smoke, so but I know what a cigarette is. What is interesting is in this drain, what if that if you give a piece of a roller gauge, or if you take a tail out of a roller gauge through this, that type of drain with a Penrose drain or a gloves rubber drain is called as a cigarette drain. What do you think will be the advantage of putting in that gauge?
Capillary action.
Very good.
Any
Capillary action, but there is an important consideration in the picture. Please see the picture.
it will prevent any organ to get stuck up in the drain.
Wait, no, sir. This one is not used in the intraperitoneal cavity. Exactly. See, infections can happen. But important thing, remember that the tail of the cigarette is not going to go up till the depth of the cavity. Because if you allow the tail of the cigarette to go, the problem is that with the exudate, this becomes a cake. The blood, the pus, etc. And it becomes very difficult for you to take out. So the main logic of this procedure of using this cigarette-like pack is that the exudate that comes in this cavity gradually comes and then is absorbed in this area and is removed. So this is what is important to remember as a part of the cigarette drain. Okay. So this is what you are required to understand, right? Chalo. It's all done. So this is a cigarette drain picture that I felt. This is another Penrose drain. I think I've made you understand what a Penrose drain is. Now, in simple innovation with a butterfly. So this is a scalp pen set or a butterfly. You can use this also as a drain. Remember that some people cut the metal part of the butterfly and they use this after they have cut the metal part of the butterfly. They have used it as a drain in various parts, particularly in children's small cavities, small abscesses. So they have used it as a drain. Okay. So there are various modifications that I could fit. Now, after these parts are done, is any closed suction drains particularly, remember, what is very important is a care of the closed suction drains. What is important in a closed suction drains are that daily you need to observe for these kind of materials. What are these in the closed suction drains?
Clots.
These are clots. And it is important for you to always remove the clots by use of a syringe to make the line again clear. This has to be done for the first 2 to 3 days until and unless the clots have stopped coming. Because if you allow the clots to form and the tube gets blocked, then the biggest problem is there are chances of a seroma happening. So this is the first care that you need to do. Number 1. Number 2 is that the whole procedure needs to be done under a sterile manner. And number 3, whenever you are changing the tube or you are making a procedure on the tube, remember that the clamp is always kept on. That means whenever you are doing it on a mastectomy tube or on a Jackson pad, remember this, say for example, you are cleaning this part of this tube with a blood clot. Remember that from the patient's body side, this clamp is always on. Please do not leave the clamp off. That means do not allow the materials to go in the body. The drains must always take materials out. We do not allow the materials to come from outside to inside. If this liquid that is coming out in the grenade or the bag, whatever you call that to be, comes in the cavity, that is best to happen. So this is the material that you should know. What are the things to know about? Right. Now, after we have talked about what is now, this is a corrugated rubber drain. All of you have used this. Just a technical question to ask. As I've said, you see how much time goes about. Now, how do we use this corrugated rubber drain for a practical use? Sir, what I do is that I take about 2 to 3 corrugations like this, and then how do you modify the use for use in the body? What is the modification that you do for this one? Sir, the only modification that we do is that we cut it like this. Exactly. Why do you make it round, or why do you make a tongue out of the tube?
Sir,
we used to call it as making a tongue.
If we have taken the full tube out.
Very good. So that means this is a part that is inside the body. This is a part that is outside the body. So that when you pull it out or remove it, you should be happy that I have taken out the full segment of the drain. Okay. Now tell me, what type of drain is this? Open or closed?
Open.
Open. What is the mechanism of action?
Sir, gravity and capillary action.
Very good. It is gravity and capillary action. Good one. Thank you for knowing this. Now, this is another corrugated drain with a radio-opaque line. This is more commonly available in our practice now. Okay. This is one of the pictures very commonly. I still know that there are many surgeons across the world who still uses this with their good logic. Even I know of a very senior surgeon who drives a Mercedes, but still, remember, he uses this with only one logic after the cholecystectomy. This never gets blocked. So his rationale is that this is a foolproof drain. Now, tube drains. Now, in the tube drains, important points to remember in tube drains. Remember that tube drains have a marking over them, and it is always good to document in your notes what is the amount of marking that is inside and that is outside. Because your consultant may ask you to take out the drain. Okay, so please remember, it is good to talk about that how many marking is in and how many marks are out. Point number 2, whenever you are inserting a drain in a body cavity, except maybe for a thoracotomy or for a laparotomy, always remember you are going to put in your blunt hemostatic forceps from out in. This is the correct technique. You are going to hold the drain and then you are going to pull it in. If you are doing this technique, okay, that means you are allowing the artery forceps to get in, and then remember that you are then allowing the drains to come like this. This is not exactly a very intelligent way. Can you tell me what is wrong in the technique number 2? What is correct in technique number 1?
Introducing infection.
You might insert the abdominal viscous.
Exactly. See, it is not about infection, sir. It is more about
while taking
a
out
safe
the drain
technique.
also, we will.
So we are going to exactly come to this. Now see, whenever you are going to poke the artery forceps blindly, there are chances that you are going to injure the colon. Sorry. There are chances that you are going to injure the colon or the bowel. You can say that, sir, I will be cautious, I know that. But it is always a good habit to give the artery from peritoneal cavity to outside, catch the drain and pull it in. Point number 1. After you have done that, place the drain properly and please fix it. Now, should you give a bite in the drain or not? Well, some people give, some people don't. But I don't think that is a good habit to use a suture to transgress the drain because fluid leaks out. Now, while you are taking out the drain, what is the mechanism or what is the way to take out the drain? You have done a sterile technique, explained to the patient, maybe given an analgesic. What is important is whenever you are taking out an abdominal drain, always, remember, you are required to give a complete 360 degree, then another 360 degree rotation in the drain. Until and unless you have done that, no drain should come out. If you are pulling out the drain, what is the danger about just pulling out a drain?
Sir, choke.
Okay, very good. How many of you have had this experience that while you pulled out a drain, the omentum came out through the drain? I cannot see your hands now. Okay, but believe me, ladies and gentlemen, I have had 2 such patients in which after a peptic perforation, the appendix came out through the drain side and we were so happy that we did an appendicectomy through the drain side. Okay, so please remember to avoid those funny complications. Please rotate the drain until and unless there is a loss of resistance. That is 2 360 degree rotations and thereafter remove the drain. So please remember this part. Okay, sure, done. Now, chest drains, I think we'll be talking about cardiothoracic in details, and chest drain is a very different arena to talk over. Important points to remember is that, what is this thing in the chest drain? What is this material in the chest drain? Hello?
Sir, we cut that out.
Oh, that is the reason I asked you.
This is a dissector. This needs to be dissected plain.
To dissect what? Not exactly. See. The material is that no. You can say, as I've told you, see, a chest drain needs a different word round class. I need to teach you how to give a chest drain. Now, the basic idea is that what is the difference between an abdominal drain and the chest drain? See, in the abdominal cavity, whenever you are giving this abdominal drain, remember that P1 is equal to P2. Pressure in the abdomen is equal to the pressure in the atmosphere. But while in the chest drain, while you are giving a chest drain for a pneumothorax maybe, what is important is this P1 and the P2 are not equal. Now, whenever you have inserted the chest drain in the chest cavity, the pleural cavity, either you put a clamp or an artery, or if you do not get a clamp or an artery, or if you have forgotten to put the clamp on the artery, which is very common, believe me, and that is the reason manufacturers have given you, this end is always closed. Because if this end was open by any chance, what do you think would have been the inadvertent complication then? Definitely. If you are dealing with a pleural effusion, or if you are dealing with exactly, so you will allow air to enter or infections to enter the pleural cavity. So this end has always to be closed until and unless you put a clamp or an artery, and then you decide that, okay, that is a useless thing, let us cut it off. What is this material for?
That is to fix the drain and the tube.
Okay, so please don't say that this is useless and throw this away. This is always used for a watertight attachment of what type? What it is for a watertight attachment of this material. Always remember that. This has to be a watertight attachment. Okay? And this is called as a water cell drainage bag. How do you know that this is not an abdominal drainage bag?
It has a central tube running.
Very good. An abdominal drainage bag, the tube ends at this point, whereas in chest drainage bag, the tube is going up till the end, but below this there is a line. What is this line for? For the water.
That is the amount of fluid we have to fill.
That is the minimum amount of fluid, sir, that you need to fill it in. Now, these are specific devices, and in a chest drain class, I will be talking about the various mechanisms of action, particularly what is the 3-bottle concept, what are the concept of these 3 bottles, what to keep into that. This 3-bottle concept is equal to this area, these valves, and how to use this in a negative suction. Now, how to fix a drain? Now, various techniques, various institutes have various techniques. I usually go by what has been taught in Hamilton Bailey's emergency surgery. And this is a picture that I took from the internet. What I believe is I use a silk suture because I feel the knot quality is pretty good. And I always use suture number 1 or stitch number 1 on one side, and on the diametrically opposite side, I give the stitch number 2. Okay. Now, I would like to again take you or ask you an interesting question. How many of you believe that there should be a purse string suture that should be inserted while you are giving the drain? Did you understand my question? Hello?
Yes, sir.
Right. How many of you give a purse string suture in a drain? In an abdominal drain, how many, or why do you think is a purse string suture given? Because for one single reason, it tends to look into, because it makes it a watertight, isn't it? Watertight, airtight, whatever you call that to be. Now, remember that in an abdominal drain, it is expected that this doesn't have any role because purse strings have been shown to produce a tissue necrosis. But in a chest drain, there are still societies which still recommend you to give a horizontal mattress stitch, or even there are older versions which ask you to still insert a purse string and then make the incision and put in the chest drain. Their logic being that why do you think this chest drain needs to be airtight?
To avoid barotrauma.
Very good. To avoid a pneumothorax and partly a surgical emphysema. I do not need air leaking out by the 2 sides of the tube. I do not need air going from out to in, and neither do I need an infection going from out to in. So thoracic surgeons still believe in giving an horizontal mattress. You can. There are studies which have showed that this is usually do not have any effect. They usually produce a tissue necrosis and may be detrimental in healing of the wound. But again, these are topics to be discussed during a chest drain. So with this, ladies and gentlemen, we have finished out the first basic part. It was a big class. I tried to condense many things together. Remember that when you talk about evidences, if you are going to ask me, sir, what is the role of putting drains in this era now? Let us be very clear. We have more or less level 1B evidences. That means with a good amount of studies to indicate that drains are essential after an esophageal surgery, where the use of the drains are technically prophylactic. This is extremely important because mediastinitis is such a disease that you cannot afford to have. So you must use a drain. So no more funny things in that. Talk about pancreatic surgery, like Whipple surgery. These are still debatable, but probably if there is a PJ leak, and if the surgeon expects a PJ leak, soft pancreas, could not find out the duct was undilated, 2 millimeter duct. Again, maybe this is important. Maybe in a trauma, this is important, but people have still asked question. Drains that do not have no role has been very categorically proved. With routine lap chole or open chole, there is no role for drain. Colonic resections, including an LAR, there is no need for a drain. paradoxically there are problems. Appendicectomy, even with an appendicular perforation, there are more problems with use of drains. Gastric surgery, there are more problems with use of drain rather than use drain. What is important is in a biliary enteric, say for example in hepaticojejunostomy, there is still a debatable role for use of drains. So this is what is the current level of our understanding in drains, particularly in abdominal drains. Okay, right, so complete. So the last topic for today is T-tubes. The last topic for the day is T-tube. And when I talk about T-tube, remember that just I'll take 10 minutes and we end the class on T-tube. Now, more or less all of you know what a T-tube is and no. First of reason is, what are the or why use a T-tube? Point number one, in use of a T-tube is, we'll talk about the indications of a T-tube in two gross headings. One is the biliary use and one is the extra biliary use. This is the better way to classify this. Now, when you talk about the biliary use, number one is that it is used after a CVD exploration, particularly for a CVD stone. Okay. Can you name me any other use of a biliary use of a T-tube? Hello? Can you tell any other biliary use of a T-tube? Come on, time is short. After a CVD injury, repair. Okay. Number three, a cholangiogram, which can be either intraoperatively or postoperatively. Any other use? Come on, ladies and gentlemen, I need a good answer. Think, imagine. Any other use? Yes, sir. After a biliary enteric anesthesia. No, sir. Absolutely not. Oh my God. So do you plan to put in a T-tube in a colorectal cyst and come out? Oh no, man.
Means after taking out cyst when we anastomose with.
That means biliary enteric anastomosis. When will you like to put in a T-tube in a biliary enteric anastomosis? When it is an undilated tube or it is a friable tube, probably your political cyst will come onto that, or there are chances that there was an active infection like a recurrent pyogenic cholangitis. Number fifth is a transplant. I hope that I was expecting that one of you will be saying that. After a orthotopic liver transplant, what do you do with the bile duct to the bile duct? Remember that is an undilated system. There was a big school of use of T-tubes after a transplant. Now, what are the extra biliary uses? Okay, let us start with the jejunum. What is the use that you can think of in the jejunum? Let me see how imaginative you are. Feeding jejunostomy. Congratulations. Any other use? In the duodenum. Any use in the duodenum? Come on. Any use in the duodenum? Sir, it is used for a not feeding duodenostomy, man. It's not working. In a duodenum, you can do something called as a lateral duodenostomy. In what procedure? In a case of a pancreatico-duodenal trauma. Remember, it is a part of a duodenal diversion. Okay, very good. Number three, in a case of a pancreatic ductal trauma, this is a rare procedure that used to be done. Nowadays, we are not doing this procedure. In an esophageal trauma, a small repair with an old perforation means more than 24 hours. It is good to use a T-tube and make a controlled fistula. Okay. In an ureteric trauma with a segmental loss or a lateral segment that has been lost, you can use a T-tube for a repair with a controlled fistula. So these are the things that I could think of quickly. If you can be more imaginative, more creative, okay, please post your answers. So these are the indications of use of a T-tube. Now, tell me, In a CBD exploration, this is a question that I always tell about. In a CBD exploration, after a CBD stone, why should we use a T-tube? This is the answer that I have given in the past. Why use a T-tube? Point number 1, to divert the bile from the suture line, because bile does not allow the suture to heal. Point number 2, it, remember, acts to decompress the bile duct. Particularly if there is a stone, the T-tube is extremely useful. It allows the bile to come out rather than the bile coming out in the peritoneum. It comes out. Point number 3, it allows a stent to repair the bile duct. Those of you who have done a bile duct repair, you know that. Number 4, it allows you to do an on-table cholangiogram or a post-op T-tube cholangiogram. Can you tell me any other use of a T-tube in a CVT stone?
Sir, button tip.
Exactly. So it is removal of a residual stone. Removal of a residual stone, that technique is given in Bailey Love, is called as a Burheen's technique. Okay, right. Final 5 minutes, then I will be having a lot of questions, I think, today, is what is my algorithm for a T-tube management? Because this is a practice that over the years in consultation with our GI guys who do that. Mind you that the T-tubes that we use are made out of PVC. We do not get latex anymore for our practice. As such, T-tubes are getting extinct. Now, what is the important point is that whenever I have given a T-tube inside the bile duct after a CBD stone, what I am going to do is that I am going to monitor the output, and I go on monitoring the output with a graph. The number of POD on this side and the output on this side. Initially, the output will be more, and then the output should come down steadily to this. Remember that daily output of bile from the liver is about 1 liter. So if a T-tube is draining around half, that means there is a spasm maybe. Now, after you have done about the monitoring of the output, the first question that comes on the post-op day 5 to post-op day 7 is, should you clamp? Those who do a clamp, the group of surgeons, they feel that the patient has no pain. Okay, maintain the clamp and then do a T-tube cholangiogram. Okay, but if the patient has pain, remove the clamp and do a T-tube cholangiogram. I am in the school, I do not put a clamp because I feel putting a clamp is much more dangerous. And GI surgeons usually do not put a clamp. And what we do is that on the post-op day about 9 to 11, we do a good T-tube cholangiogram. And after the T-tube cholangiogram is done, please go to this next table. My algorithm is very simple. I see if there is a stone present. Yes. Stone present. No. Now, if the stone is present, yes, then do not clamp the T-tube. Attach it to a bag, but keep it for minimum 4 to 6 weeks. And then at the end of 4 to 6 weeks, you can either repeat the cholangiogram, which is a good idea to do that, Maybe the stone may have passed out by this time. Or you can think about doing an MRCP if you like, which is not a good tool, and do an ERCP removal after 4 to 6 weeks. Remember that at the time of ERCP, if you have seen that ERCP gentlemen do an ERCP, the first thing that they do in the ERCP is that to negotiate the dormia, they take out this T-tube. This is the first thing that they do. So please remember, with a PVC med tube, do not take out the T-tube at the 10th to the 14th day as is taught. No, it is not done. Early removal of T-tube can be very dangerous with a PVC tube. Books were written in the latex age. Remember that. If the stones were not present, you can clamp the T-tube and then keep it for 4 to 6 weeks. Tell the patient to have a light fat-free diet. You may do a T-tube cholangiogram if you like, because sometimes there are stones which are in the hepatic ducts that may get missed. Should not be. You may omit the T-tube cholangiogram also. Please remove the T-tube. Now, important questions. How do you remove a T-tube? What is the word that the examiner is wanting you to say? How do you remove a T-tube? I need a smart answer, man. How do you remove a T-tube? Come on. Hello?
Sir, after giving basket.
I need a smart answer. I told you the answer. Oh my God. Exactly. Sir, by a few tentative pulls. Please remember, this is the exam answer. By a few tentative pulls, followed by a smart pull. Why did you give the tentative pull? Why did you give a tentative pull? Because I need to dislodge the T-tube from the tract, and then I will give a smart pull so that it comes out. But definitely, in my practice, I usually keep the patient for observation for about a day, maybe half a day, because with PVC tubes, your teachers will always tell you they have had their share of bad experiences. So this is the algorithm I follow. I do not remove a T-tube at the 10th day. If you have read it in books, it is removed at the 10th day. That is in the latex stage. In a PVC, please keep it for a longer time, at least 4 weeks for your safety. Let us have the tract that is made. Okay? So I think this has been a huge, big class. So I will not be telling you the Mingo's modification. I have taught during the CVD class. What is the Mingo's modification about the use of a T-tube? You know this, we will not be repeating the facts. Right? Your questions, please. It was a long class. Many controversies must be arising.
Sir,
to be comprehensive or not? Yes, sir.
Sir, in chest drain, is a suction drain.
Yes, by the mechanism, it is a gravity-assisted suction drain. Number one, open or closed?
So chest drain is always closed.
Closed, good one. Number one. Number two, is it gravity-assisted or is it suction-assisted? Sir, it is both. Initially, it is gravity-assisted and then followed by suction-assisted.
So please show algorithm of T-tube, sir. Once.
Sir, but in case of suction assisting, means won't the lung tissue will come?
No, absolutely not. That is the point that I will like to discuss when I will be talking about the chest drain as a part of the ward round. Chest drain as such is a big topic to discuss. Okay. So definitely we will not be giving a chest drain till the point with that. We will be talking when this topic comes. Okay. Now the gentleman was asking me the algorithm. So this is the first part of algorithm. And then this is the second part.
Okay.
Okay. Right.
Thank you, sir.
If stone is not present after 10th day, then
yes, sir.
Why we can't remove the T-tube then? Why to wait for?
Because for one single simple reason. How long does it take for the T-tube to make a tract? How long does the T-tube tend to make a tract? How long do you think does the T-tube tend to make a tract? 4 weeks. That means before 4 weeks, if you have not made a tract, what happens to that hole, the rent in the bile duct? Tell that to me. What happens to that hole in the bile duct? That hole is present there. And what happens to the bile now? The bile is going to come to the peritoneal cavity. Do you like a bile peritonitis or do you like a stable patient with a tube removal after 4 weeks? Tell me, which one is a much more safer option? Okay, so did I make you understand this concept? Remember, the concept about removing it at the 10th day was done in latex tubes. Latex forms a tract at 7th to 10th day. PVC does not form a tract at 7th to 10th day. Right. Other questions, please?
Sir, hello, sir.
Yes, sir.
Sir, in MRM, what is the full suction, half suction?
Well, see, that depends upon now. If you are asking me by how much millimeters of mercury valve pressure, sir, we have not quantified. This is the first honest confession. Now, if you have seen this, where did that go off? What we used is that say, for example, there are 10 bellows. Now, these parts are called as bellow. It looks like an harmonium bellow or a piano accordion. Okay. So, all of you have used this device. If we had compressed all of them, we call that at full suction. Or if you had compressed till half, we called it as half suction. Okay. Right.
Sir, in exam, what should I do?
What is your practice? In your hospital, what is your practice?
Sir, full suction, actually.
Full suction. See, again, these are nothing to be said as an absolute. There are papers now which have challenged the full suction. It is said that if you do a full suction, as I have said, someone said that their hospital policy is full suction for first 3 days, thereafter half suction. Very logical, very logical. So whatever is your hospital's policy or your teacher's policy, please mention that.
Okay, sir.
And if you really want to do a thesis the next year, or your junior wants to do a thesis, please ask him to do a thesis on this one. This is a very simple thesis that he or she can do.
Okay, sir. Sir, in peptic perforation, you tell that. Hello, sir.
Yes, sir.
Sir,
yes, sir. In peptic perforation?
Sir, you tell that the drains should not be used, but
perfectly said. But there is no role for use of drain. Now, not only your hospital, sir, in my hospitals, out of 10 cases of abdominal sepsis, 10 patients always have a drain. Don't worry about it.
Okay, because lots of pus fluid coming out after the OT. So
well. See, I did not have time to talk about the meta-analysis. Okay. Probably in a journal club discussion one day we can talk. And number two, if I go on talking about the theoretical things or the randomized trials, the only thing the randomized trials have come up is that there is no evidence, no benefit of putting in a drain after an peptic perforation, appendicular perforation. Okay, sir.
Okay, sir. Sir, on next question, sir, in peptic perforation, what should be the position of the drain?
See, the logic about
HRPM or pelvis?
See, the logic about giving an abdominal drain was that in the post-operative first 4 or 5 days, which is the most dependent part of the peritoneal cavity?
Pelvis.
No, sir. The patient is lying like this, isn't it? So this is the most dependent part, the hepatorenal pouch and the paracolic gutter, and the pathology is on the right side. So it is always good to give a drain in the hepatorenal pouch because the patient will be lying supine. Now, after a couple of days, when the patient is awake, now this is the patient who is sitting and this patient is very happy. Now tell me at this point, where does the majority of the pus drain into? The pelvis. So this was a logic that was propounded 100 years ago, that give 2 drains, one on the pelvis, one on the hepatorenal pouch. Okay, so that when the patient sits, but believe me, these concepts are long gone now. If you are to give a drain really, then maybe in the right side, it is good idea to give it in the paracolic gutter. Okay, so it is good. So if you are thinking about giving a drain, and this is the duodenum, and this is the repair that you have done, probably if you ask me to give a drain, what I tell my residents to do is that I give a drain like this, but again I try to keep it away from the duodenal site And these are the eyes of the drain in the paracolic gut.
Okay, sir. Sir, can you explain the differences between open and closed drains?
Open and closed drain. See, open drain is like this one, sir. This is a picture of an open drain or a closed drain. What is your opinion? This is an open drain. Whatever is going to come out through this drain, you need a dressing gauge or a gamgee maybe, or a dressing pad maybe, to collect this. So that is called as an open drain. Whereas, if there was a tube that was coming out, if there is a tube that is coming out, that would have been called, and it has been collecting in a bag, that would be called as a closed drain. So that is the difference.
Thank you, sir.
Okay, so I think it was a long class. Thank you, everyone.
Thank you, sir. Thank you, sir.
I hope this class was useful.
Yes, sir.
Okay, thank you.
Thank you, sir.
Hello? Hello?
Yes, sir. Audible, sir.
And visible also, right?
Yes, sir.
Okay. So I am doing 2 classes on transplant next month, right? And about the anatomy, I'm sure there will be another class taken by either Ramanuj or someone who's going to do the anatomy. But yeah, definitely 2 classes on transplant next month. Right, Adarsh, right. Okay, so today, again, on Saturdays, it's again short class. This is basically to increase your concepts. Maybe it will be these type of questions from this class will only be asked when you're doing very, very well. And most of the information that is given over here are all from the latest evidence. It is more to do with practice, and maybe you will have those difficult MCQs that come in examinations. Maybe if you have a good knowledge of this, you will probably know how to answer them. So I'm starting today. So today 8J is hepatojejunostomy strictures. This is it's actually a part of an operation for many other operations. I'm sure by now, as postgraduate students, you will know exactly when do we do a hepaticojejunostomy, which is a form of a bilioenteric anastomosis. Okay, bilioenteric anastomosis, right? So when I've done a class on biliary stricture before, then I told you about the other types of bilioenteric anastomosis. But this is what this class will be on hepaticojejunostomy. And one of the most complications of hepaticojejunostomy is the hepaticojejunostomy strictures. So the normal hepaticojejunostomy is done as a Roux-en-Y hepaticojejunostomy. If you know how it is, I'll just show you. This is the stomach, right? It is like this. And there's a Roux limb that comes and joins it over here, right? And some of this is actually like this. This is the stomach. The Roux limb goes like that. This is the liver, and this is the two bile duct which joins. Okay, so this is basically a hepaticojejunostomy. It's a Roux-en-Y hepaticojejunostomy. So the stricture that we are going to talk is when there is stricture formation over here at this area, right, in the anastomotic area. Why does it happen? What are the techniques that happens that we don't do well because that it happens? What are the initial conditions in which we should not do a hepaticojejunostomy? That will all be discussed in this class. So basically after hepaticogenestomy, so in this concept class, if you see that we are always going to move from the final solution to why it is happening. Okay. Normally it is a important post-operative complications that happen. A little bit higher from than your level, but you should know it. So what are the basically complications that can come after a hepaticogenestomy? So anastomonic strictures, almost 50% of all complications in a Roux-en-Y hepaticogenestomy are anastomonic strictures. What are the others? There can be stone formation. There can be reflux of gastrointestinal content into the biliary tree, like this. There can be an obstruction of the Roux-en-Y anastomosis, and there can be from outside. And there can be both de novo and recurrent malignant disease, especially when you're doing a hepaticogenestomy after a malignancy. There might be a new malignancy that comes near the anastomosis, causing a complication, or there might be a recurrent disease or a disease you have left behind, which is grown and causing the complication. So in a Roux-en-Y hepaticogenestomy, again, the most common complication after it, if they ask you, is an anastomotic stricture, and that will be the basis of this class. So the AJ. So there are few things in which you should always describe any anastomosis, and AJ in particular, that it has to be tension-free. So whenever you're asked in an examination, describe the anastomosis. Whatever anastomosis that you're doing in life, tension-free, right? Widely patent. That means that both the incoming and outcoming caliber should be equal and quite wide, right? Widely patent. Mucosa to mucosa anastomosis, right? Well vascularized bile duct, which is so important, especially in a duct anastomosis, because the bile duct vascularity all goes to 3 and 9 o'clock. So you have to be very careful in not pairing the bile duct completely. So you should have a well vascularized bile duct, and it should drain all parts of the liver. This is super important, especially when you're doing a high hepaticogenestomy, and you know the bile ducts have divided into a right, left, and right anterior and right posterior. You have to make sure that each and every output from the liver should have anastomosis in the jejunum limb that you have taken up. If you do not do the anastomosis over there and you left a duct, it is going to drain, or it is going to become occluded, and the entire liver segment is going to be atrophied. Atrophy will happen. Okay, so these 5 things you will have to describe when you're describing an AJ. It has to be tension-free. It should be widely patent. You should have a mucosa to mucosa anastomosis, and it should be well vascularized bile ducts should be there, and to drain all parts of the liver, right? So what happens after you have a stricture? So basically, how does the patient will present? Most of the patient is going to present with a recurrent cholangitis, which is actually, it might come to you, it has come to everyone when whoever is doing hepatobiliary practice, is that after you're doing AJ, the patient will say, how are you? Or you're telephonic. He said, yeah, I'm okay, but I'm having a little bit fever. It comes and goes. It comes and goes. Don't, brush it off as the patient is brushing it off. You have to see that whether a recurrent cholangitis is happening or not. It is life-threatening, because once the cholangitis happens, though when you are doing theory of it, it sounds okay, only infection, but it is not that. A cholangitis can die within 12 hours. So take it from me, whenever you're suspecting, a cholangitis can happen, get him admitted, and I'll tell you what to do when you train, when it comes to the treatment. So be very careful when a patient is telling you after your AJ, after say 1 year, 1 month or 2 months or 3 months, he's telling you, yes, doctor, the fever comes for a few things. And doctor, last Friday I had a shivering once, but then it became okay. So all these things, be very, very careful, because it's life-threatening. All the other sequelae of this thing is actually, it gives you time. Like biliary cirrhosis is almost an end-stage disease. Hepatic failure is an end-stage disease. Death is okay. But remember, the recurrent cholangitis in red is the most important thing. Don't ever discredit whenever everyone is having a fever, or I had a chill. All had a single episode of rigor. They'll come like that. Okay? Never ever discredit that. Right? Okay. So the diagnosis, how do you do? You've done the operation and the patient is telling you, I've got a fever or not, suspecting, okay, it can be a hepatic stricture. So it can be a clinical presentation or it can be a morphological features. Morphological features, basically what I'm trying to tell you is that we have to define the anatomy, what is there, where the stricture is there, where the dilatation is there, all these things that you have to know. So diagnosis basically broadly two parts. So what is the diagnosis in a nascent stricture? Nascent means what? Nascent means hidden. You're not too sure a stricture has happened. He or she has got no issues at all, no jaundice, nothing. But a stricture is forming. When should your bell start ringing? Yes, you do a LFT and it comes a mild elevation of GGT, elevation of little bit of transaminase level, and a transitory fever. So never ever discredit. Ask a lot of questions regarding fever. Did you have a fever that day? Did you have fever? Did you have a shake? Did you have a rigor? Did you miss office for one day? Just find out about that. So this gives you an idea or a pathway towards a nascent stricture. But when stricture has happened, what happens is that cholangitis, again, danger, happens in 80% of the cases. So the most common clinical presentation after a stricture is a cholangitis, right? But you must also be aware of the fact that after you do any operation for hepatic stricture, sometimes that stricture itself does not cause a cholangitis. It might be other causes but cholangitis. What are there? It can be an intrahepatic stone formation without an AG stricture or stenosis. Even an intrahepatic stone formation can cause a cholangitis. It can be a SUM syndrome. It can be in malignant cases, it can be a recurrence, right? Interluminal recurrence has happened. Or it can be a transplant cases, a graft rejection, a non-anastomotic biliary stricture. So when we are doing transplant, one of the complications is a non-anastomotic. That means strictures are happening not in the area of the anastomosis, but proximally and distally, multiple. Okay, that is a sort of a graft rejection. So in these cases also cholangitis happens. So when you have a cholangitis, yes, you think of a stricture, but don't put these out of your head also, right? And isolated jaundice comes only in 15% of cases. So the beauty of the slide is that you have to understand what we are thinking. Stricture happens, we think that okay, jaundice will come. No, it will come with cholangitis almost 80% of the time. Okay, so be very wary of that. So what is the morphological definition? We define it through a radiology. So either USG or CCT abdomen, whatever is available. But USG and CCT abdomen cannot actually show you a stricture. It is actually, you should know first to rule out important other causes. Okay, whether there is a stone, as I said, a stone formation, whether there is a recurrent of malignancy. That little chart that I put this. So this always comes out in USG and CT scan. Okay. You can do a percutaneous transhepatic cholangiography also. Okay, but that will give you an entire proximal biliary tree. Okay, so percutaneous, this is something which I use often. This is what? This is the liver. This is the two bile ducts which join and goes like that. And this is a tree, bile duct tree. It goes like that. Percutaneous is the skin. Is that you have done a small catheterization here. You have isolated a proximal peripheral bile duct and you have put a catheter in right up over here. And you do put the dye and you can see the entire biliary tree. So that is called PTC. The PTC also gives a very, very good of the biliary stricture over here. But PTC, what happens is that then complications. It is an invasive procedure and it causes maybe if the liver is already dysfunctioned, it can cause bleeding and then you'll be in trouble. So PTC is, though it can diagnose strictures very well, but you should not avoid it. So what is to be done? MRCP is an ideal thing. So whenever biliary stricture is coming, you will have to do what is the diagnosis. Radiological diagnosis of choice is an MRCP. Because MRCP is a non-invasive. MRCP does not require any dye. And MRCP is going to give you the complete biliary tree, the dilated, non-dilated portions, also the stricture or the obstruction, the levels. Okay. You can do an ERCP as well. But ERCP in a limb is a bit difficult. So, but you can do an ERCP, and ERCP also is sort of invasive and it has its own drawbacks. But then it can diagnose strictures also very well. So, what are the different types of ERCP that comes with the limb is there? You can do a percutaneous transvaginal if it is fixed loop. So, now what people do is that when there is the afferent loop, they put it near the skin. Okay. And you can do the endoscopy right from from the skin to that loop
and it goes right up to the epigastrocnemic, or you can do a USG guided concept of the non-fixed scoop. Okay, so you can do an endo USG. You can go from the stomach only, and near the D1, you will find that the jejunum also comes from there, and you can do an endoscopic. I'll show you the entire thing how to do it later. Okay, when we are doing the treatment of it. So basically, in this, you have to know that MRCP is the investigation of choice for any biliary stricture, right? So why is it investigation of choice? Yeah.
Can we say distal to the stricture in MRCP?
You mean proximal?
Distal to the stricture, sir. Any other stricture or any other pathology, tumor?
Any other stricture, any other pathology, tumor. MRCP is not very good for extraluminal tumors. It's very good for intraluminal findings. See, this is the two biliary duct. It becomes like that. MRCP shows the entire biliary tree, no? If there's stricture over here, it will show the entire biliary tree, distal as well as proximal.
No, sir, but after anastomosis.
After anastomosis?
Yes, sir.
So you have done an anastomosis over here?
Yes, sir, yes.
So there's a stricture over here? Yeah, why would it not show?
No, but any other pathology can be distal to the stricture also, any tumor also.
What pathology? Extraluminal pathology?
In the same lumen, sir, in jejunum, there can be any tumor or stone.
In the jejunum?
Yes, sir.
Why would it show in the jejunum? No, jejunum, what tumor will be there in the jejunum? Do you know of any tumor of the jejunum?
No, sir, just asking. If they
I'll tell you. Okay. If this is a trick question for your examination, the get out of this, how to get out of it, that MRCP actually sees the bile. Okay, that's the contrast media. And MRCP basically sees the filling defects of a path of the bile. So a stricture can easily be seen because the bile column will become thinner, right? If the bile is free flowing into the jejunum. So in jejunum, if there's air also, you'll not be able to distinguish a tumor over there of a jejunum. It's very difficult. First of all, I don't know of any tumor, interluminal tumor that can happen in the jejunum. And any extraluminal thing that happens, it is very difficult to see an MRCP. At that time, I told you, you have to do a CT scan.
Okay, sir. Thank you, sir.
Okay. So, as I told you, all investigation have to start with a CT scan because it's important to rule out the other causes as you are thinking that this might be a tumor, as you rightly said. So, do a USG and CT abdomen. But to diagnose a stricture intraluminally, you will have to do a MRCP. Okay? Right. So now, what are the conditions which causes, when you have done a hepaticojejunostomy, HJ, which can lead to a risk factor? So when do you do an HJ? You do an HJ during an iatrogenic bile duct injury, right? That is what I think Dr. Ramanuj has taught you. You can do an HJ when you're doing a bilioenteric continuation in a liver transplant. You can do an HJ after any pancreatic head resection, like a Whipple's. HJ is one of the anastomosis in a Whipple's. Or you can do an HJ in choledochal cysts. Okay? So these are 4 conditions in which you can do an HJ. Now, what is the initial 4 conditions which can cause the risk factor for after an HJ? A stricture can happen. So you must understand, in any iatrogenic bile duct injury, the anastomotic stricture chance is almost 5 to 22% in HJ. Now, previously when we were growing up, like I'm talking about when we were in your, I did my post-graduation in 2009. So at that time, whenever anyone used to have a bile duct injury, okay, don't do anything, put drains and all, after 6 weeks we'll do. Why? We want a stricture to form. And then why would you want a stricture to form? So that the proximal bile ducts, due to the pressure, dilates. That was the funda at that time. So absence of bile duct dilatation. So if there's an abscess, so when you're doing a bile duct, when you've injured the bile duct, okay, what happens is that the proximal bile ducts are not dilated, right? So we postponed the intervention until bile duct dilatation was obtained, or to routinely use anastomotic stents in non-dilated bile ducts. So this was the general funda previously, they do it. So whenever you have bile duct injury, even in HPP centers, don't do anything. Okay, because why? Because it is very difficult to do a HJ at that time because the proximal ducts are not dilated. So what to do? You allow that stricture, that injury to become a HJ stricture, okay, or a biliary stricture, so that the bile will not have a free flow from the liver, and the proximal bile ducts, due to that pressure, will dilate. So, and then after 6 weeks or 2 months or 3 months, when you see nice dilatation on MRCP, you do the HJ. That was the finding. But studies have highlighted that early repair within 2 or 3 days achieved similar results as delayed biliary reconstruction, provided that procedure was performed by a specialist hepatobiliary surgeon. So nowadays, over the last 10 to 15 years, it has come that no, if it has an injury, you do not wait for the stricture to form for 6 weeks. You go ahead and do a HJ, irrespective of proximal bile duct dilatation. It will show an equal result to what you would do after 6 to 7 weeks in late repair. Okay, and that is why after lab chole, after everyone who's teaching you like Ramanuj and everyone, early diagnosis and referral to a specialized teacher. You must refer it on that day so that he can have a repair the next day. Is this slide clear to all of you? So the exam questions will come like this. Exam questions will come that, okay, you have done a CBD injury, and in this first post-operative day, you find bile is coming. What will you do? Okay, so you say, basically you review the video, I will go in again and see what is happening. You will diagnose a bile duct injury. You will have to refer it to an HPP center so that they can repair it as soon as possible. Okay, so the examiner is going to tell you, why don't the proximal bile ducts are not dilated? Why don't you wait for 6 weeks? Let the stricture happen. Let the proximal bile duct dilate, and then you do an HJ. It will be easy HJ to do. You said, no, sir. There are a lot of evidence, a lot of papers have come out that there's no difference in the operative outcome between an early repair, if it is done before 2 to 3 days, or a late repair 6 weeks. That is the answer you must give. Okay? Right. So what are the other risk factors? When you do not, when you defer an HJ repair, when there's a presence of biliary peritonitis. See, this will also come why post-operative in lab chole, when you're waiting, when 7th day or 8th day, the bile is still coming out. So what they tell you to do? You have to control that fistula. So you put in a lot of drains radiologically so that there's no collection inside the abdomen, and that you have to follow for till 1 to 2 months so that the patient is sterile inside and all the bile that is coming out from the bile duct is actually going out externally through your drains. Because at no time do you want any kind of inflammation or biliary peritonitis to happen, because that is going to have an effect on your subsequent HJ that is going to do. So presence of biliary peritonitis repair is a big no-no. You cannot do a HJ when there's a biliary peritonitis present. Okay? Right. And the second is, when there's a postoperative complication following the repair, especially a biliary leakage, with both intuitively increase the risk of postoperative inflammatory stenosis. So what happens is that you've done an HJ and postoperative complication, there's been a small leak of bile, which you've managed conservatively, but you'll have to tell the patients, see, this was a difficult repair and there's some kind of bile that is still coming out despite our best efforts. You might be needing This might be leading to another HJ that might occur. Okay, this is something which you need to tell all patients when you do a biliary enteric anastomosis if there is a leak after a bile duct injury. Okay, so what are the risk factors? The risk factors that I told you is presence of biliary peritonitis at repair and postoperative complications as bile leakage. Okay, in the scenario of bile duct injury, these are the two most important things which can cause a HJ strictures subsequently. Right, presence of biliary peritonitis at repair and a postoperative bile leakage. Right, how can you avoid it? If it's a present biliary pattern is there, you don't do the HJ at that time. You give antibiotics, you drain, you wait for 6 weeks, and then you do an HJ. But post-operative, there's a bile leakage list which you treat conservatively. There's nothing for you to do, just to tell the patient that there might be an HJ that can occur, right? And of course, when there's an associated right hepatic arterial injury, in the occurrence of an anastomotic stricture is still a matter of ongoing debate. See, there's a lot of issues over here that, when you do a complex bile duct injury, if there's a right hepatic arterial injury, what to do? So you're going to answer in the exam by saying there's a matter of ongoing debate. Some people, what they do is that they defer the operation after doing a CT angio and seeing the biliary vascular tree, and if they find there's a right hepatic arterial injury, they defer the operation till later when there is either a collateral is formed or that part of the arterial drain, that part of the liver has atrophied. So there's an ongoing debate on how to do that, but you're going to leave it at that. What you do in your center, you will say that there's a routine CT scan with vascular reconstruction is done, is always performed if you're suspecting that there is a vascular injury to preoperatively assess the arterial vascularization. So what happens is that if the artery has been cut and you have not diagnosed it and you've gone ahead with a HJ, that HJ is going to fail. Right? So routinely, you do a CT scan with vascular reconstruction to find in a complex biliary duct, vascular biliary injury to find out whether the right hepatic artery injury is there or not. Okay, it is a matter of ongoing debate, and this is in the concept class. Understand the confusion. So there is a lot of confusion in surgeries, especially in higher levels. When you go to your super specialization, you will know there are ways to tackle it. There's ways to answer it. This is the way to answer it. You can use the term there's an ongoing debate. You don't have to say yes or no. Some people, my center, what they do is that if you are suspecting a vascular biliary injury, we do a routine CT scan with vascular reconstruction because we want to assess preoperatively whether the right hepatic artery injury has occurred or not. In a liver,
how to suspect?
What do you mean, how to suspect?
The arterial injury associated, how to suspect about it?
When do you suspect it? If you have done a very high kind of biliary injury during the operation, okay, bleeding will be there. You will know. Okay, but you will know which vessel. Right? So you will basically, what you're going to do, you're going to offload whatever the bleeding you're going to stop. And then you do a routine CT scan post-operatively. You keep it in your notes that there can be a vascular biliary.
But sir, if we clip the artery then?
If you clip the
artery?
So that is basically an arterial injury rather than a biliary injury. When you're clipping the artery and you've not done anything to the bile duct, how will you know? You will not know.
If you clip both, artery is adjacent to the cystic duct, and we clip both.
If you clip both, then you will not know. It will not come in the intraoperative. You will not know intraoperatively whether you have done the mistake or not. Unless you follow that, proximally, and you find out that is going right to the liver. Because when you have to take out the gallbladder also, na? When you take out the gallbladder, you'll find that artery is not going to the gallbladder, it is going inside the liver. Then you suspect it. Then you do a CT scan here.
Okay, sir. Thank you, sir.
Isn't it? See, whenever you are asking a question, please understand, it's a good question actually. Whenever you're asking, there's three things you have to ask properly. Whether you have whatever biliary injury or vascular injury, whether you've identified at the time of operation or not, whether you have not identified at the top of operation or not, whether you have identified in the drain or not, or any kind of immediate post-operative period. So all these managements are different. Okay. For example, what happens, in the operation when you have clipped it, a vessel, and you find when you are taking off the gallbladder that the vessel is going inside. Okay. You cannot do a reanastomosis over there. It's very difficult. So basically, and you also don't know what kind of vessel it is, whether it's an aberrant duct, whether it's the main duct. How will you know? Especially in an inflamed gallbladder. You will not know. So you'll have to make a note. So So many a time what happens is that if a major vessel is, you also have to see that whether that is how many segments of the liver or how many segments of the liver that is draining. So that will only come in two ways. One is that when you do, post-operatively, after many days, when you do a CT scan, you'll find either a segment has gone atrophy or that some kind of abscess has happened, hepatic abscess has happened. So that is the way to know it. So different cases have different scenarios have different managements. But yes, suspicion will come with the suspicion that when the vascular vessel is going inside the liver, then you will have to make a note of it definitely, and you will have to discuss it with your seniors, your HPV surgeons, and then you'll have to do a CT angio to diagnose it. And also, what you'll have to see is that if there's a combined vascular biliary injury, of course, you'll have to make sure that you have not at the same time injured the right hepatic artery. Because if the right hepatic artery is injured, it is your HA that you're going to do is going to be in threat. Okay. Now I'll go to liver transplant. As I told you, liver transplant also you do a sort of a biliary anastomosis. So I just do very lightly liver transplant here because I'll speak extensively 2 classes of liver transplant during the main class. But just take it in mind is that there's 2 types of liver transplant. One is a diseased donor liver transplant, and one is the living donor liver transplant, DDLD and LDLD. So in a diseased donor liver transplant, we can actually take the liver and we can actually the entire thing. We don't have to bother about the donor at all. So we always prefer to do a duct-to-duct anastomosis in a DDLD. Okay, AJ is done in certain conditions. Why? Because when there's a large disparity on duct diameter. So, for example, the duct of the recipient is almost, say, 8 centimeters, and the duct of the donor is 3 centimeters. So, it's very difficult to do a duct-to-duct anastomosis. So, you do an AJ. When there's a TSC, okay? When sclerosing cholangitis is there, the AJ stricture risk is almost 21%. Okay, and when we are doing a retransplantation, the AJ stricture is called 2%. Okay, so whenever there's a PSC, though AJ is done, sometimes in PSC you have to try and do a duct-to-duct anastomosis. Okay, so normally a duct-to-duct anastomosis is done in diseased donor, and AJ is done only in certain conditions. In an LDLT, also DDS preferred. And AJ is done only in 20 to 40% of cases. The majority, because you have to, when you take the part of the liver away from the living donor, you can't take out the entire extrabiliary tree. Okay, so you'll have to leave something. So over there, AJ is done. The risk factors is what? When there's significant steatotic grafts. So I'll tell you what steatotic is when there's a lot of fat inside the liver. Okay, when steatotic grafts is there with prolonged cold ischemia time. So cold ischemia time is what? Is basically when you've taken the graft from a donor, living donor, okay, and the time it takes when the graft is explanted away from a body to when you're connecting it to the vasculature in the recipient. That is called a cold ischemia time. So when there's a prolonged cold ischemia time, or when the graft is from donors aged more than 50 years, at that time the risk factor for a stricture is very, very high in AJ. Okay. Technical factors such as biliary anatomical variations requiring more than 1 biliary anastomosis, yes, and AJ can occur. Small donor right or left bile ducts when you are transplanting only the left part of liver and left bile ducts, that time an AJ stricture can occur. Just take a screenshot of this. When we are doing liver transplant, I've got slides which will go extensively in this and which I'll make you understand at that time. And we can bring it up. When if you're there next month, I think 2nd or 3rd week Saturdays is liver transplant. We can discuss it at that time. And some postoperative complication which can lead to AJ is what? Biliary leakage. So whenever there's an AJ you have done, biliary leakage is there. Okay, this patient marked, it can come down as a stricture. Hepatic artery thrombosis, right? Any hepatic artery thrombosis can cause a stricture. CMV infection and acute cell rejection. So these are one of the common complications of a liver transplant. What? Biliary leakage, hepatic artery thrombosis, these are actually graft rejections. CMV infection and acute cell rejections. So this can cause an AJ. Okay, so the patient will come as what? Like, they'll come as, you've done the transplant, but they're coming for recurrent cholangitis. Because cholangitis is the most common form of clinical suspicion that you'll have. Fever is there, so you're going to suspect something like that. Okay. In a pancreatic head resection in Whipple's, okay, it is surprisingly seen there's no significant risk factor for the development of strictures. So whatever pancreatic resection you do, HJ, okay, since HJ is not at all connected to your pancreatic duct where you are doing the biliary anastomosis, there's no significant risk factor with only marginal influence of preoperative bile drainage and no impact of either common bile duct size or postoperative biliary leakage. So, see, what happens is that these are all evidence that is there. Okay. You have to present this answer to your examiners like, so surprisingly, do we do the same thing as a biliary duct, bile duct injury? We do the same thing. We do a HJ, same HJ, non-malignant in that area is nothing. But there's no significant risk factors. So neither the common bile duct size nor the postoperative bile leakage, even if it is there, it does not occur. How, why, we don't know. But the numbers or evidence says that. So there's no significant risk factors for development of strictures was observed with only marginal influence of preoperative biliary drainage. That means when there's a, this periampular, the pancreatic head tumors, which is impinging on the ampulla, which is causing sort of a jaundice, and you've done a stenting, right? You do it sometimes, right? So marginally influence. If you do the stenting, there might be an HJ, but it is very marginal. But there's no impact to either common bile duct size or leakage. Okay, so this is where you're going to present this answer in pancreatic head resection, right? So even when you're getting a, say, GI NEET SS exam, they'll ask you, HJ strictures are highest in, least in, post biliary duct, post transplant, post pancreatic resection, post cortical cyst. Answer is post pancreatic resection. Okay, so something is there. So in a cortical cyst, this is the last point in which we do an HJ. The risk factors for developing HJ strictures are what? Age. So if the patient is really young, HJ strictures doesn't happen. But if the patient is presenting in old, like more than 20-25 years, whatever operation you do, there is a chance of having an HJ stricture. The shorter duration of symptoms, if it is an acute duration of symptoms and you're doing an HJ, it can cause an HJ stricture. With an increased size of cyst, so the bigger the cyst, the more chance of an HJ stricture. And if it's a type 4A cyst. So these are the four things in which the risk factors of developing HJ strictures post biliary enteric anastomosis after you've done a cortical cyst operation. So what are the therapeutic options that you have? So we have done basically the first part was the clinical features that come, like cholangitis and everything. Second part is the main investigation that you do, is an MRCP. Third part is that in these four types of scenarios, what operation you do can cause an HJ strictures, and last is HJ strictures happen, what are the therapeutic options? So the conservative management, whenever HJ strictures happen, is the best way to go. It is almost the therapy of choice. So what you can do, you can do an endoscopic, you can do a percutaneous transhepatic drainage, or you can do a transjejunal balloon dilatation. Okay, so these are three types of conservative measures. Conservative means non-open surgery or laparoscopic surgery. So endoscopic is ERCP, right? Percutaneous transhepatic, transjejunal balloon dilatation. And if it's a surgery that you have to do, whenever conservative measure fails, surgery is your second option or the last option, you can say. You can do a revisionary hepatogenectomy, so you basically refashion the HJ, or you do a partial liver resection. Resection is especially seen in HJ with an arterial injury, which has caused a part of the liver to atrophize. So you can do a partial liver resection, or if you find due to the HJ, ultimately the patient has developed a secondary biliary cirrhosis and a hepatic failure, and a liver, any part of the liver you cannot save, you have to go for a whole liver transplantation. So it's a very important slide. This is the measurement. This is actually the treatment of choice that you do. So there is a classification which I pulled out. So basically, it's called the Third-Blanche classification, and classification of the functional results of a hepatic ileostomy. Grade 1 has no biliary symptoms. Grade 2 is transitory symptoms. Current no symptoms. It normally comes in history, which will tell you I have fever some days, I don't have fever some days. I'm not feeling too well today. I had a rigor last Saturday. That's grade 2. Grade 3 is clearly related symptoms requiring medical therapy. The patient is in cholangitis. It requires some kind of drainage to relieve that cholangitis. And grade 4 is that you've done everything, but there's recurrent stricture requiring correction or related death. Okay, that becomes a grade 4 stricture. Okay, that's the results of a hepatic ileostomy. So what is the conservative approach that we have spoken about? So this is actually multi-step. You do 4 steps, and this is what you're going to write in the exam. This is what you're going to practice in life. So what is it? It is a treatment of choice. The first step is that we do a percutaneous transhepatic cholangiography with external drainage. So what happens is that you have got a stricture that is formed in the liver. This is the liver. So it's a very bad liver. Say this is the liver. Okay, this is the skin. This is the stricture that is formed over here, and this is the multiple biliary radicals. So you put a drain from here, okay, and you go all the way till here, and you drain it, okay, and you put a catheter. So the internal system, whatever biliary system is there, is relieved. Once the internal system is relieved, you have drainage coming out from here. Also, through the catheter that you have put over here, it can come out distally also to the duodenum. Okay. So first step is PTC with external drainage. Second step is after 3 to 7. So after the first step, what you're doing, you're relieving the cholangitis. You're saving the patient. Okay. Whenever the patient has HA and you're suspecting cholangitis, the patient has come shaking and fever and total count is somewhere around 22,000, whatever. So you have to say first, I have to drain. So do a PTC and drain. Second step is that after 3 to 7 days, you do a percutaneous angioplasty catheter. With the same thing, you put in a balloon. Okay. And with the balloon, you basically try to do a dilatation. And then you put a stent. You put a stent over here. Okay. So the second step is after 3 to 7 days. Why 3 to 7 days? The body, after it is in a shock and cholangitis, you're giving it time to recover and making the entire, all these counts and everything to stabilize. It takes 3 to 7 days. Then you put basically the angioplasty catheter, you dilate the stenosis, and you put a stent. Okay. What is the third step? Third step is again, after 6 weeks, you do a controlled cholangiography. You put a stent replacement every 6 weeks. So you continue. If 6 weeks, you let the patient come back. You again do a cholangiography. You put a stent replacement till the fourth step is when no stenosis is observed in that controlled cholangiography. In 2 consecutive sessions, you remove the catheter, you remove the stent. Okay. Some books says 2 consecutive sessions. Some books says 3 consecutive sessions or 3 months. Okay. So some books say 2 consecutive, some books says 3 months. So first step is what? The patient has come with cholangitis, HA stricture. What do? You put PTC with hepatic cholangiography with external drainage. Second step is after 3 to 7 days, you put a percutaneous angioplasty catheter and you dilate with a balloon dilatation. You put in a stent. Third step is what? Every 6 weeks, you call the patient, do a controlled cholangiography and you do a stent replacement. Fourth step is that with no stenosis is observed, 2 consecutive sessions or 3 months, you remove the catheter and the patient becomes okay. So this is the treatment of choice in HJ. Okay, don't jump saying that I'll do a redo HJ. This is the treatment of choice, right? Your endoscopic, your gastroenterology colleagues will do. Okay, what are the other types? You do an endoscopic retrograde balloon dilatation. So if this is your stomach, right? And this is your rule-in that comes like this. And this is your liver. And you've got you've done an HA. You've done HA like this, right? So you can either do, let me use a template. So you can either put the endoscope like this, retrograde, and do a balloon dilatation like this. Okay. So at many times what happens is that, I'll draw the liver again. Okay. See, this is the liver and this is your stomach. And this is your rule that comes like this. And this is your HA that has happened. Now the picture comes like this. Okay. So what happens is that transenteric kind of ERCP that you do, in which there is a sort of a double barrel instrument like this, which you introduce and you put it like this. Okay. Make a small gastrostomy and you put it to the limb over here, to the limb over here. So your scope comes, ERCP scope comes from here and it goes directly through this. Okay, this is a transenteric. It is called transenteric because it is going through the intestine. Right? So you can either do a retrograde like this or you can do a transenteric like this. Rendezvous technique is what? As I've told you, rendezvous technique is you are doing not only this, but you're also doing a ETC from here. Okay. So you have come and you have reached over here. So what happens over here? Over here you're doing a balloon dilatation. From here also you're doing and you're doing a dilatation over here, or you're putting a sort of a dye over here to see how much dilatation is there in the proximal diaphragm. So when you're using two ends, it becomes a rendezvous technique. Okay. So these are different techniques which gastroenterologists do to access the hepatojejunostem. Yeah.
So while doing the balloon dilatation in the stricture or the stenosed part, is there any possibility of perforation or like transaction?
No. See, what happens is that perforation is very, very difficult because the stricture has happened through thick fibrosis. Okay. So you can never put any part of your balloon will basically burst, but it won't. Thick fibrosis that has happened, right?
Okay.
Good question. Okay, Mike, guys. Okay. So there is other techniques also which I'll tell you. The another technique which you can do, I'll just erase all the link over here. The another technique is called the Hudson's loop. Hudson's loop. In the Hudson's loop, what happens is that this is the, I draw very bad livers. So this is the liver. This is say the stomach that has come like that. Okay. This is the root loop that is coming up from here. Okay. Now after you do an HJ over here, this goes all the way to the skin up. Okay. And you stitch it over here. So you can do a transcutaneous ERCP like this. This loop is called Hudson's loop.
Sir, over the skin means at the epigastric region?
No, at the side, right at the side. Okay, I drew it wrong. It came like that. So it's a good question. So you can either do it like that, or if you don't do it like that, you can put this loop near the skin. Okay. You can put a stitch like this and you can access it from this loop and go over here. So there are a lot of variations that you can do. So human brain is amazing at any amount of variations. So the thing which I want to tell you is that in any HJ, the initial treatment of choice is conservative percutaneous. As I told you, those 4 steps, and that is exactly what you can tell in the answer the question in your paper, whether it comes as a straight viva question or a case question or an OSCE or in your theory paper. Okay. Now, what's the revision surgery? Always remember, all revision surgery is a second choice. Okay, is a redo HA. Redo HA is a really difficult operation to do. So normally redo HA, you've seen that people who are doing the cases which are going up for redo HAs are basically which you have failed endoscopically, restricture has happened. So what happens? The entire thing becomes fibrosed, and the only way to do redo HA is to go to secondary biliary radicals and try and do a HA over there. So it is a very, 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 very difficult operation. Okay, with a very low your success. But yes, it is the thing which you can do. Redo HA. Second is a partial liver resection. It can be left or right anterior or right hepatectomy. So what happens is this: is that suppose you have a sort of a biliary stricture that has happened, and the scenario that the doctor has told me that there is a associated vascular injury also. So if there's an associated vascular injury and you find an HJ has happened, so in a bile duct injury case, so what do you do? Yeah, I do a CT scan. I'll find out whether the lobe, right hepatic lobe or right anterior lobe, wherever that vessel injury has happened, that has become atrophied or not. If I see that, yeah, that has become atrophied, so what will I do? I'll do two things. One I'll do is that I'll put endoscopically, I'll embolize that artery so that the remnant liver becomes bigger. Once the remnant liver becomes bigger, okay, then we are going to do a hepatectomy and an HA with that part of the liver. So we do a partial liver resection at those times of usual surgery, provided the remaining part of the liver, which is good, has got no steatosis or not got any secondary biliary cirrhosis changes. If that remaining part of the liver has got secondary biliary cirrhosis changes, then there's no other option except to do a liver transplantation when there's irreversible parenchymal damage due to secondary liver cirrhosis or liver failure. Okay, so this is something which you have to know. Redo HA is a very, very difficult operation. Normally, it's not easy because you have to do a HA in even more proximal segment. Maybe it can be 2 to 3 artery, you have to do an HA for that. 2 to 3 bile ducts, you have to do HA with that. Or you can do a partial liver resection and then associated biliary vascular injury, and you've seen an atrophy of one lobe. Provided the remaining part of the liver is okay, you can do a partial liver resection and HA over there. And if you find the remaining part of the liver is also very bad, but secondary biliary cirrhosis have occurred due to recurrent HAs that you have done, you will have to go for a liver transplantation. I worked in a IGI unit during my specialization, and used to have HA injuries coming from all over the country. And we have always used to say, and they are very frustrated people, because multiple times they are doing operations in various places, but nothing is happening. You'll have to say, see, 7 to 8 years or 10 years down the line, when no longer this works, you will have to go for a liver transplantation. Okay, so this is it. Any other questions?
Sir, in your transplantation, duct-to-duct anastomosis or hepatoco-enterostomy is better?
So I told you, they always prefer to a duct-to-duct anastomosis.
The structure will be more in duct-to-duct or hepatoco-enterostomy?
It depends. It depends on the initial conditions. If it is PSC, if it is retransplantation or anything like that, the chance of having a stricture is higher. So they prefer duct-to-duct anastomosis.
In normal situations, a duct-to-duct anastomosis.
Yes, it's preferable.
Sir, in hepatico-duodenostomy, these strictures form just like the similar hepatico-jejunostomy.
In hepatico-duodenostomy, see, what I've told you is that the majority of things, the same thing happens because the physiology is the same. So any kind of biliary enteric anastomosis, if you try and put whatever I'm telling you right now, you'll find that the initial conditions, for example, if there is a biliary peritonitis, yes, it can occur. If there's a leak, postoperative leak from the hepatico-duodenal anastomosis, yes, it can occur.
Okay.
Okay, chat question. Hudson is basically when you are taking the rule in. Stomach coming down like this. Okay. There's the JJ that you have done rule in. Okay. Let me do, as she has said, is on the right hyper content. And this is the liver. This is the liver, and this is the HJ that has happened over here. and this comes all the way to the skin. Okay. In the skin, through the transcutaneous, you put the tube, endoscopic tube, transcutaneous, and you access this area. This loop is called Hudson's.
So will it not cause a billion trips?
No, it is closed loop though. You see, it is not a stoma. See, this is the skin. You've taken the loop and you put it like that with a stitch over here.
After the procedure, sir.
No, why will it go? You nothing will happen over there. You've closed it, no? Okay. So the thing of this is that you'll have to do readings of a slightly higher books for this. And if you do a reading on the net also, because most of the things we have told you have basically come from, if you do specific searches in the net on, say, for example, Hudson's loop, or you can do a search for HS strictures, read those papers. Because when you read those papers, then only you'll understand that what I've done is that I've put everything in one slide. But if you read those papers now, after having this understanding, you will know exactly what is happening. Okay, please read it tonight or tomorrow when this class will be repeated. And it will be fresh in your mind. See, the intent of doing these Saturday concept classes is that, you should have a broader sense of what, or a higher sense of what surgery is. So it is not only very yes or no MCQ types. And I liked all your questions. All your questions were very, very good. Okay. So to end this class, I'll just put stress on 4 or 5 points. See, in bile duct injury following cholecystectomy, always refer as soon as possible. Okay, there's a golden period to do an early repair, 2 to 3 days. Let the HPP surgeon do it. Second is that repair of bile duct injury should only be attempted in the absence of ongoing sepsis, regardless of the delay. So even if you have if you've done a delay for 2 months, okay, and the patient party is telling you, sir, please do. I've read on the net. It's 6 to 8 weeks. You have to do it. But then if you find no, there's some kind of sepsis there, patient is having fever or a little bit like that, do not do. You say, okay, wait for another month, right? In patients undergoing liver transplant for primary sclerosing cholangitis, duct-to-duct biliary anastomosis provides better functional long-term outcomes without increasing the risk of disease recurrence and should be preferred over an HJ. So in patient undergoing liver transplant for primary sclerosing cholangitis, in living donor LT, optimal selection of grafts and microsurgical HJ construction decreases the rate of postoperative and anastomotic HJ strictures. So these are something which is important. When I do liver transplant, I'll tell you all these different types of biliary anastomosis that you do for a liver, both in the dead donor and dead transplant and living transplant. How to tackle therapeutic is that as much as 50% of the late age-related complications are not anastomotic strictures and should be meticulously ruled out. That is why don't jump into MRCP. What is the first investigation you will do? Sir, I'll do a CT or a USG. First investigation. What is the investigation of choice? My investigation of choice is MRCP. Is this clear? So as much as 50% of late age-related complications are not anastomotic strictures and should be meticulously ruled out. What are the not anastomotic strictures? It can come as a recurrence. Yeah. So basically you have to do all of these. You have to rule out all of these. So first investigation is CT, USG. Second investigation of choice is MRCP, right? Percutaneous transhepatic biliary dilatations with or without stent placement is currently the approach of choice in the management of HS strictures with high success rate. So this is the percutaneous transhepatic biliary dilation with or without stent. There's controversies whether to put stent or not stent, but there's some authorities who put stent. Both is right. But percutaneous transhepatic biliary dilation with or without stent placement is currently the approach of choice in the management of HS strictures. This is your MC question. The existence of a Roux-en-Y loop does not represent an absolute contraindication for endoscopic therapy. As I've told you, you can do a percutaneous with a Hudson's loop, or you can do a transenteric, that thing that you put in. Everything you can do. You can do a retrograde balloon. So existence of ruin, a lot of people are going to tell you, oh, ruin while loop is there, I will not do an endoscopy. Wrong. You will have to do an endoscopy. If it is not there in that place, you will have to send it somewhere else. Okay. Surgery should remain a second line treatment since the vast majority of strictures can be managed conservatively with percutaneous or endoscopic dilation. So surgery only is the last. So in HJ strictures, surgery is the last option. What are the three options in surgeries? Redo HJ, very difficult because they are asked redo HJ, you have to do a anastomosis even more proximal to that. Second is that partial liver resection, okay, and third is that liver transplant. So this completes your 360 degrees about HJ. Okay, right. So our app is out. You can download it, and there are a few things which we should know. This is like a test run which we are doing. In that, you will have to register with your proper name. Don't register with a like Messi or Ronaldo kind of name. If you are in this masterclass, you don't have to pay again. Okay, it is free for you. After you registered, your payment page will open up. Don't go with the payment page. Just send a message to Shilajit. Okay, and Shilajit will enable the entry at one time. Okay, so in the first time only, Shilajit will help you to enter it, and then you can log out and log in with your ID, whatever you have created, as much as whenever you want to. And since this is the first time you bring out an app, please report privately if any gross error of content or anything you want to change. You can give a call to Shilajit. Shilajit will escalate it to us, and we will either change it or take down the video for the time being and then restructure and put it back. There are more than 100 videos over there, and we are going to add more and more videos as we go along. So it's in the Google Play Store. It's an Android app today. It will come. We will get the iOS version next week, and after the iOS version comes, we have to get the feedback from our own masterclass students. Okay. If you have any issues, you can give. Don't write anything on the PG masterclass groups because PG masterclass groups has a lot of other students also. Just give a note to Shilajit, and Shilajit will escalate to us, or either I talk to you directly or I'll help you out. Okay. Any questions?
No, sir.
Okay. So thanks a lot, all of you. And one more thing that I want to do about masterclass is that, that masterclass Tuesdays and Saturdays will not be on the app right now. The Mondays, Wednesdays, Thursdays, and Fridays class will be there. These kind of classes are basically concept classes which we do not want to put in the app. We just want our masterclass students to have a good measure of it. And the Tuesdays class are very basic class which are not going to put in the postgraduate app, which it's only for our masterclass students. So these two things will not be there for the time being. They might put it later after the app is running nice and we have a thing for them. But Monday, Wednesday, Thursday, and Friday's classes will be there. Okay. So please enjoy the app and please give me feedback as much as possible, as early as possible, so that we don't have some major issues over there. Okay. Thank you. Have a nice weekend and please stay safe, all of you. Right. Good night.
Thank you, sir. Good night, sir.